we are starting our sixth cardiac device update, Kolkata, and we are happy to have stalwarts of CRM therapy in India, and it will be a kind of involving and kind of much revealing and much educative one-day program for all of us. So to begin with, may I invite Dr. Mantosh Panja sir, Dr. Ravin Chakravarti, Dr. Kajal Ganguly, and Dr. Praveen for lamp lighting, and it will be it will accompanied with Saraswati Vandana, and then we'll be initiating our program. Yeah. May I also invite Dr. Nayak, who is there, to come for the lamp lighting, please, sir.
Mata Saraswati Sharada, He Mata Saraswati Sharada, Vidyadani Dayani Dukha Harini, Jagat Janani Jwala Mukhi Mata Saraswati Sharada, He Mata Saraswati Sharada, Vidyadani Dayani Dukha Harini, Jagat Janani Jwala Mukhi Mata Saraswati Sharada, He Mata Saraswati Sharada. कीजे सुदृष्टि, कीजे सुदृष्टि, सेवक जान अपना, इतना वरदान दीजिए, तान ताल और आलाप, बुद्धि अलंकार, शारदा, हे माता सरस्वती शारदा, विद्यादानी दयानी दुःख हरिणी, जगत जननी ज्वालामुखी माता सरस्वती शारदा, हे माता सरस्वती शारदा, हे माता सरस्वती शारदा.
So, without much ado, let's begin with today's scientific program. And before we go ahead with the presentation of Dr. Mantosh Panja, sir was my teacher and still my teacher, and he will remain be my teacher for lifelong. Before that, may I invite Dr. Ravin Chakravarti to say a few words about the concept of device update, and then Dr. Panja will take over. May I invite the chairperson and moderators for the first session, Professor Kajal Ganguly, Dr. Saroj Mandal, Dr. Dipankar Ghosh Sastidar, and Dr. P.C. Mandal, please.
Good morning, everybody. I think it is really indeed a pleasure to say that eventually in cardiology, the device specialty has been a recognized specialty. Now, a lot of cardiologists are getting interest in only on device implantation device details, which is extremely important. And over the years, we realized that device has taken a huge leap in the development and in the treatment and therapy of heart diseases, particularly not only the pacemaker, heart failure, conduction system pacing, and sudden cardiac death, and much more complex situation where role of device has been recognized as an independent and important specialty in interventional cardiology. And Dr. Dilip Kumar has started this, I still remember, in a very small way. And today, over the years, I would think for the last 7 years or so, it is progressively increasing, and it has been recognized nationally as an important program for in cardiology, particularly the device specialty of cardiology. So with that few words, I wish that it continues, and more cardiologists should take interest in this area, and the industries are also equally contributing towards such development. Their algorithm, their complexity has slowly getting percolized in our community. So with that few words, I wish this program to be a great success. A lot of important faculties are attending this meeting today. I request everybody to listen to them and sort of understand the complexity of the device and its usefulness for the human heart. Thank you very much.
So now may I invite Dr. Panja to deliver his lecture. And I'm clubbing the first and second session together. So may I also request Dr. Biswajit Majumdar to be on chair, please.
Ladies and gentlemen, welcome to all in this good morning of this winter. And before starting my lectures, we are doing the pacemaker 1974, and then particularly day after day number increasing. Prior to my retirement by FSCAI hospital, I worked in FSCAI 40 years in different capacity. That time, 15,500 pacemaker I presented in Asia Pacific conference in Singapore. The foreman told me that your indication is a biphasic block, but our indication is a six-signer syndrome. Why it is? I mean, no, you are doing the proprietary pacing. That is why your number is top of the list of indication, that is a six-signers. But our is a biphasic block. There must be some stroke and syncopal attack and straight line ECG. Without that, we do not do it. Silently accept our situation also. Therefore, so in this vast experience, and Dilip Kumar organized a fantastic meeting and inviting me to talk on the introduction of the pacing as well as the scope of device update. First thing, okay. First, before the pacing, we have discussed the electrical therapy and heart. That should you understand. 1964 publication speculated about the bioelectric nature of cardiovascular system. That should understand. 1774, some reference there, external stimulation of the heart over the young girl, which is recorded in the register of the Royal Human Society. In 1775, Danish physicist, conducted the first study of electrical energy on a living organism. Cardiac pacings, really 1928, Mark Lidwell. He done the pacing. He saved the life of the infant due to cardiac arrest. And 1932, Hyman pacemaker, that is the artificial pacemaker made of the top is the big size. Then hoop pacemaker, 1940. Joule pacemaker, he also invented the first catheter electrode also, 1950. And 1957, Becken's pacemaker, he were the wearable pacemaker, rechargeable. So 1957, that is also universal history. In Calcutta, this external wearable pacemaker also used Dr. J.C. Ghosh, and they use it. and rechargeable battery also there. You have got to experience that time you were DM student, long time before. And before that, diagnosis must be done by the heart block by the ECG machines. And this electrographic machine here conducted the whole study of ECG a separate laboratory. First human being pacemaker implantation done by William, 1960, by surgery. In case of heart block, patient age is 77 years old and successfully done in human being. After that, pacemaker, 1960, successful pacemaker, the pacemaker available in the market, commercially used. In Calcutta, in 1965, Dr. A.K. Basu in FSCAI hospital in Department of Cardiology done the first pacemaker in India. So 1965. So after 5 years of the first pacemaker in the world, 1960. Then historical background of the different companies, 1958, Siemens Elma, he sold his entire pacemaker business to the American company St. Jude. And after that, different manufacturer, American Optical, Cordis, and General Electric, different companies come. As a whole, increasing complexity, improved battery charge, and hermetically sealed component and integrated circuit is available to improve the pacemaker quality. If you see the evolution of pacemaker technology, 1958, weight of the pacemaker 73 and size of 35 cc. 1981 it is reduced from 55 and size 25, and 1995 smallest pacemaker for the used to be children heart block and here 14 size and the size is 6 millimeter. 2009 size is 2000, that is the 23 gram and size is 12.8, and 2013 weight is 2 gram and 1 cc size, the lowest size from St. Jude company. So milestone of cardiac pacing, see asynchronous fixed rate pacemakers, single chamber pacemaker. In FSCAI during my period, we see 90% of use of the single chamber pacemakers and only 10% of the dual chamber pacemaker. So that is, but is now at present is just reverse. 90% is the dual chamber pacemaker and 10% hardly single chamber pacemaker. So after that, demand functions improve, programmability available, dual chamber available, and rate modulated, rate responsive pacemaker, automatic adjustment of pacemaker parameter to optimize the device function is now. The internal diagnostic purpose also use it, and in cases of the arrhythmia and heart failure, multi-site pacemaker also very important utility is there. On a program follow-up period from the patient from the home by the telephone or modem, availability download of the identical data for pacemaker is also used now. Now, indication particularly say the product, bradyarrhythmia first, single chamber pacemaker and dual chamber pacemaker. For cardiac arrhythmias and ventricular fibrillation, ICD single chamber and dual chamber pacemaker available now. For treatment of heart failure, CRT-D and CRT-P, if it is CRT-P, particularly you know what is utility of that. But after that, and before that, the MRI protected, very important need of our country for the management pacing. Most advanced pacing technology, FDA approved, fully body MRI cases, and designed and tested for the cardiac MRI, even proving the reduction of progression of permanent atrial fibrillation by this pacemaker. And after that, smallest pacemakers done by the Medtronic Micra, and is very important issue in case of elderly frail people, when the repeated replacement done, no vein, that cases is also used, and some cases people are very fondly to use of the, without a scar on the chest they can use it. So this is very important. And ultimately, there is systemic, the pacing site, you see RP pacing, responsible cardiac arrhythmia, atrial fibrillation, heart failure, among not only that, the cardiomyopathy, RP cardiomyopathy developed. So in that case, what to be done? You have to do the pacing, septal pacing, followed by left bundle branch area, we can do this pacing. So ladies and gentlemen, at the end, Hippocrates medic, this is very important. He mentioned those who suffer more frequently and strong faint without any manifest cause die suddenly. Therefore, we are lucky to get the pacemaker to improve the quality of pacemaker. Today, I am thankful to Dilip to discuss various aspects of the pacemaker device. Thank you very much indeed.
Thank you, Dr. Paja, for a beautiful deliberation on evolution of pacemaker, current status, and future we shall see also the biological pacemakers. So with this, I invite Dr. Sujit Majumdar to talk on basics of pacemaker hardware. Sujit is here. Sujit?
So they are on their way. So we will invite Dr. Praveen to talk on CRT device longevity in CRT, and then we'll move on with the next session.
Good morning. So I thought I'll just talk on methods of how the newer generation devices, the latest devices, increases the device longevity. Device longevity is of utmost importance because most of the heart failures are now living. Earlier, the quoted mortality was 80% mortality in 5 years. That was in the medical management era. But in the device era, the longevity of heart failure patients is much different. And now we have people more with devices, living with heart failure with device. And the difference is that in medical management and the device is that they are living a higher quality of life with heart failure. So their EF may be very low, but they'll be walking around with good functional quality of life. So generally, now we have more patients, about 35 to 45% of patients with ICD or CRT that are less than 65 years of age. And mildly symptomatic heart failure with CRTD patient has a survival of more than 80% at 7 years. And pure ICD patients living after 10 years is around more than 40%. This is because ICD patients, ICD is selected because they are probably worst heart failure patients. So even their survival is more than 40% with an ICD. And annual mortality rate for CRTD patients with moderate heart failure is 3%. So that is quite less. From a big 80% has come down to 3%, 80% at 5 years, but this is 3% annual mortality rate. And the change of ICDs, 50% of ICD changeouts are avoidable for people less than 50 years of age using an ICD of 12-year longevity. And it has been found that there's a 75% CRTD changeout is avoidable for patients more than 70 years with a 9-year longevity device. So definitely patients are, nowadays patients are getting devices earlier and they are living longer, so they need more longer lasting devices. So it's a need that we need to have more long lasting devices. So what is being done is basically it's improvement in battery technology. That's a constant research which is going on. What is there is improvement in battery technology. What we can do to devices are either therapy dependent or pure device dependent. In therapy dependent factors like pacing output, basically pacing, the more you pace, the more is the current drain, because pacing requires more energy than sensing circuits. So basically if you reduce the amplitude, definitely you can save a lot of battery. So you need to keep the lowest amplitude possible. Pulse width is another factor, but if you see amplitude is more important, because pulse width, even if you increase it, you can put it, if you can put it at a lower amplitude, you will be actually saving more battery. And impedance, that is another thing, which higher the impedance, higher the battery drain, because the current, to reach that voltage, you need more current. So current drain will be higher. Next is the pacing rate. Suppose you need to pace a patient for some purpose at a higher rate, average rate. Like in late heart failure, you may have to pace at a higher rate to keep the cardiac output. So in such cases, battery drain will be higher. So as advanced heart failure, sometimes you may have to pace higher and their battery drain will be higher. And of course, it depends on pacing percentage. More the RV pacing percentage, if you can reduce the RV pacing in a CRT, like if you have an adaptive bi-V CRT, then definitely the battery drain is going to be lesser. And the more you do time in telemetry, so these days we have more of remote telemetry. Suppose you use telemetry in excess, battery drain is going to be very high. So device dependent factors include the static current drain, which is not very avoidable. And suppose you switch on all the algorithms like AF prevention algorithm, then battery drain is going to be very high. So nowadays, the new devices have come up with newer battery configuration. Like Medtronic has come up with a new stack plate battery configuration. The communication energy is now Bluetooth, which requires less energy. And so there are methods to reduce current drain also. And the total battery capacity also has increased. Now what has been done in battery is that silver vanadium, it's a combination of carbon tetrafluoride and silver vanadium. And multiple carbon tetra, difluoride or etc. are used. The proportion of that depends on, that will increase the longevity. Suppose SVO, silver vanadium oxide is a high capacitance, sudden discharge, basically came for an ICD, but endurance is with lithium. So carbon tetrafluoride lithium is for endurance. So if you vary the proportion of these components, the battery longevity is going to increase. So there is an increased proportion of carbon tetrafluoride in the present day batteries. And then configuration also improves. Now they have come up with a stack plate battery design that gives more of 15% more energy efficient. This was the old one. It's a coil plate. It's like a plate which is coiled around itself. So this acts as multiple bipoles. Now what is done is multiple separate stacks of battery. This is very similar to EV car technology, where they use the same technology, where multiple battery packs are stacked. So that gives maximum number of separate batteries which can be connected in series with least space. So that's how EV batteries has come. So that has come in pacemakers also. It's a stack plate battery design. So that is, and another thing is the high density integrated circuit. That also reduces the battery drain and increase longevity. What happens is a microprocessor, if you switch on algorithms, etc., what happens is each time microprocessor wakes up and for all calculations. So suppose the calculations are repetitive, this can be reduced. So in cobalt and chrome devices, what has been done is if there's a repetitive task, the microprocessor remains in the sleep state. So that markedly reduces the current drain and increased longevity. And some other features which contribute to energy conservation are, one is suppose you use a quadrupolar lead and a bipolar lead. That actually increases the longevity by reducing battery drain. Active fixation definitely improves the battery longevity, because if you do active fixation, there will be a more chance of constant contact between tissue and the lead. So that will increase, there will be a consistent impedance, consistent contact, which increases the battery life. Then all electrodes are these days steroid eluting, that definitely helps. Then capture management. Earlier we used to use safety margins, but in CRT, the good thing is that we can put a lower safety margin. Even sometimes dynamic capture threshold management, or just plus 0.5 above the capture threshold. You can program it like that rather than 2 times safety margin, because here pacing dependency is not there in CRTD. Even if you miss 1 or 2 beats, usually patient will not know. So you can afford to reduce the capture the pacing voltage just to above plus 0.5 above the capture threshold. That is another way of increasing battery life. That you can do it even in older devices, but minimum safety margin that you can program is 1.5 times the threshold usually. But in a CRT, you can, in newer devices, you can put it plus 0.5 than the capture threshold. And if you turn off atrial sensing in chronic AF, because it will be unnecessary using excess energy for sensing all the higher atrial 400 rates. So that also, if you turn off the atrial sensing, that will also increase the output in a AF patient with heart failure. So definitely the improved longevity due to electrical efficiency, improved charge transfer, improved charge efficiency, and no capacitor formation is required. and there are less of internal electrical connections. So what is done is everything is made into a single module, or advanced valve metal capacitor. So that single capacitor reduces the connections, interconnections. So definitely we are getting devices of longevity of 10.4 years, 13.4 years with ICDs and chrome CRTs. Thank you.
Praveen, may I ask a question? So what's your percentage of patients where you use active fixation LV lead? Because, and what is your concern, like the concern about the retrieval of these leads or removal of these leads if something goes wrong? Like infection patient with CRTD and we have put a active fixation lead. How comfortable are you and in extracting these leads?
Even if it is a passive lead, I don't know whether it will come off so easily, but active fixation leads, it can be taken out. But I think it is more difficult to take out an active fixation lead than a usual bipolar passive fixation lead. Definitely it is more difficult. Second thing, regarding active fixation, something else you asked?
Yeah, that's what extraction is one important point. And how is the percentage of patients where you are using active fixation?
These days we are using almost 95% are active fixation leads.
No, LV. I'm talking about LV.
Understood, LV.
Yeah.
Now,
So
is it necessary that 90 such a big number of active fixation is required?
I think if you see the battery longevity, probably it is much better. And the bipolar usual passive fixation leads, you tend to have variable thresholds and all. So probably active fixation leads is much better in that term.
Yes, definitely electrically it should be better, but this most of the time anatomy is not so bad that we have to go for fixation. It is just for, your indication is just for surety that it should be stable more.
Definitely if it's a large vein, definitely active fixation leads.
No, that is all right. After assessing the coronary sinus anatomy, then we can think of
Change of vein,
But if anatomy is favorable, in that also we will go for fixation, active fixation.
Usually, again for electrical parameters, longevity and all, I think these days I prefer active fixation leads.
There is question to you and also this company people, any technicians. Is that removal is recommended? Is there any safety issue of removal? Safety is removed. If we want to remove,
I don't know. I'm not aware of any safety issue regarding removal of an active fixation lead. I didn't have to perform one so far, so I'm not very aware of the difficulty. Probably it should be more difficult than a passive fixation. And even passive fixation, I'm not very sure will it come back so easily.
Yeah, I think so passive fixation LV lead the easiest to extract. So just
now most of the time it's
even
come
without
out easily, no
taking
problem.
stylus in, we can just pull it out. As these are unlike the ICD leads and all, we require a lot of pull and push and pull. But this LV lead, which is bipolar or quadripolar, whatever may be, this is easily removable.
Just concern is during this passive fixation lead of LV, if we want to remove, passing this stylet, during that time we should not kink that. That is the only precaution we have to take. If you can pass up to the last pin, it is very easy to pull out. It is very easy.
Just asking, there are new devices are coming with so many features like remote monitoring, everything. So how do you plan that it will save the battery? More features, it will drain the battery.
Definitely. That's why the one battery capacity has changed. Definitely the battery capacity itself has changed. They've added mixture of, as I told, carbon tetrafluoride plus SVO. So it's a variable ratio, so that the more you add carbon tetrafluoride, the more endurance we'll have. If you switch on more features, then definitely battery is going to be lesser than, it will be a range. So it will be in the lesser part of the range. Suppose we can switch off like atrial sensing, in patients with AF. Such things we can do. And the new thing is that, again, if you can reduce the threshold, like safety margin is not 1.5 times in a CRT. Nowadays it is like plus 0.5, plus 0.25, plus 0.5 than the threshold which is measured. So dynamically those things are offsetting for the increased features. That's it.
Any initial safety issue regarding this coiled battery based on wire coiling and to dipole, small dipole, small batteries?
Yeah.
Is there
Basically,
any
the
safety
stacked
issue?
batteries like
Yes.
multiple dipoles.
Multiple dipoles
Stacked
are-
on.
Yes. Is there any safety issue?
Not
That-
that I
besides-
know of, but because everything is hermetically caged, so it should not be a problem. Whether it was a coil design or a multiple stack issue, there will be a dielectric in between definitely. So there should not be any safety issue in that.
Thank you.
Thank you.
I think nice discussion, nice presentation, and so many new things we have seen. Thank you. Call for the next. Dilip?
Thank you, chairpersons, and thanks Praveen and Dr. Panja sir for the nice deliberation. Now we move on with the next session.
Okay.
And may I invite the chairperson and moderators of the next session, Dr. Nayak sir, Dr. Ghosajra, and Dr. Biswajit Majumdar sir to take. Yes, sir, please. The positions on dais. And now, basically, this entire device update is focused on conduction system pacing and leadless pacemakers. And there we are going to press the accelerator pedal now. And we will be talking, stepwise on basic electricals of conduction system pacing, which will be, dealt with elaborately by Dr. Deobrata Bera. Anindyo is going to talk a little bit about basic electricals and then the techniques of LV area pacing. And then we will have some what we see and what we have gained in last 2 years, and a little philosophical talk for Shanmuga, because I feel he has done a lot of work in CSP, so I have given him a free hand to give his opinions and ideas about CSP in future. And then we will talk, we'll show some tools and improvement, scope of improvements. And then I will be showing some of the cases in difficult anatomy. So may I invite Anindyo to start with. Debu is taking a little time. He will be there in 10 minutes.
Good morning, everyone. At the outset, I would like to express my sincere thanks to Dilip sir and the organizing committee for giving me this opportunity to present in such a highly prestigious forum, in which I don't think I'm qualified enough, but I'll try my best. So we'll discuss today about how do we get through a left bundle area pacing implant. So before getting into the implant proper, an implanter should have in mind some basic concepts of left bundle area pacing. Where is the target site? What is the chance that I will get a left bundle area capture? So with this, first we'll see there are modes of different endocardial pacing. There is the age-old RV apical pacing, then came his bundle pacing, and then now we are all talking about left bundle area pacing. So the difference is, in a normal heart, as you can see in the top panel, the activation slowly goes through the AV node, fast through the His-Purkinje system, and then slowly through the myocardium. That is how a normal activation happens. In RV pacing, RV apical pacing or myocardial pacing, it is slow activation, cell-to-cell initial myocardial capture, then sequential activation of both the ventricles, resulting in a ventricular dysynchrony. His bundle mimics the normal activation sequence and left bundle area pacing. Again, because it starts from the left of the conduction system, there will be an incomplete RBBB, but resulting in a narrow QRS. So this is the results. The most physiological way of pacing still remains his bundle pacing, but there are all issues with the electrical parameters with his bundle pacing, and that's why we have resorted to left bundle area pacing. Now, just before going into the implant, we'll do it very fast. What we know about conduction system from our med school days. So it's a his bundle dividing into left bundle, right bundle, and then the left bundle divides into maybe 2 fascicles or 3 fascicles. So if you consider this scenario, we have, and if it goes like this and maybe Purkinje division in the myocardium, we have still, then this is RAO view, by the way, if you imagine this is the RAO view. We have only a very thin target for implant even in left bundle area pacing, correct? There are areas which are empty. So the statistical chances of success with this kind of anatomy, if we keep in mind, will be less. But this is not the, what happens in the body. Sunao Tawara, who was a Japanese pathologist, he first told us what is the connection. So each fascicle from the left bundle will give off branches starting from its origin, which will communicate with all the branches of its own origin and also with the branches of the neighboring fascicle. So starting beyond the proximal 1/3, there will be no area of the septum on the LV side which will be free of conduction system tissue. That gives us the confidence that if beyond the proximal 1/3, if I go anywhere in the septum deep enough to reach the LV subendocardial aspect, I will definitely catch some portion of this vast network of left bundle and the His-Purkinje system. This is another CT reconstruction in the left lateral view. In left lateral view, we just remove the free wall, and you can see AV node is an epicardial structure, divides into a left bundle and then a right bundle. The left bundle immediately, it's a very small structure, it immediately divides into a much broader posterior fascicle, and there may be anterior fascicle and sometimes a septal fascicle. After just 10 to 15 millimeters, it will immediately divide into multiple branches, making it a reticular network and therefore a rich, wide target of left bundle area pacing. So if you can see, this is a case where we have done an implant where there is a His bundle and the left bundle both. So if you can see, this is the RAO view projection, RAO projection with the morphological specimens shown. Beyond the proximal 1/3, there is rich network of conduction system. And if I can show you in overlapped view, this is the RAO view, and if I superimpose this with the conduction system in the background, we know that there is a big area which is all up for grabs if you just penetrate the conduction system. So this is the pathological specimen where you see the left bundle divides and there is a rich network, this constant web of conduction system tissue which is easy to capture. Now the classical teaching is you go to his bundle and 10 to 15 millimeters below that you will get the left bundle where you have to penetrate. That is the ideal location, but that may not be always possible because sometimes it is difficult to achieve a perpendicular orientation. We all discuss about that. So this bubble, this green bubble is classically the left bundle area where you get a left bundle capture, but this is not the only site where you get a left bundle area capture. So the left bundle area pacing is, and the entire area, you can go more posterior also, you can go more anterior also, little more apical also, and you will all get the conduction system capture. It is also to be known before we go into the implant quick. So left bundle area pacing according to the European Society is not equal to conduction system pacing always, because if we just cross the midline of the septum, it will lead to an incomplete RBBB. And that incomplete RBBB is the definition for left bundle area pacing. So you can see the left bundle area pacing is actually outside the bubble of CSP. Left bundle branch capture, left fascicular capture, and then LV septal pacing. If you just cross the midline of the septum, there is incomplete RBBB, and that is defined as left bundle area pacing. So there are some, before you go into the implant, there are some, if you want to use the EP system, there are some settings which you have to change. You need to have an unfiltered setting, you have to have a filtered setting. The band pass filters have to be arranged so that you can get a injury pattern. The ST elevation you can see in the bottom right, and also a separate channel where you can get high frequency signals for capturing the left bundle or fascicular potential. So the basic design of the hardwares which we all use for conduction system pacing is a dual curve catheter. Dual curve in a catheter, if you see my body, if you consider my hand as the catheter which goes from the left axillary vein, subclavian vein, SVC, and goes through the RA into the RV, a single curve catheter will take you to the RV apex. But if you add a secondary curve, then you will face my body, my body being the septum, the RV endocardial aspect. And that's how all these catheters will automatically orient themselves towards the septum. Now how do you move the catheter, such a three-dimensional catheter, through the septum? You just rotate my arm clockwise, it will disengage, pull, push, go to a new location, and anti-clockwise, and that will bring you again back to the septum at a desired location. So these are on the 4 catheters, all kept side by side. You can see the basic design is the same. There is a there is a primary curve in all of the catheters, which will take them across the tricuspid annulus, and there is a secondary curve with variable degrees of curvature, which will bring them perpendicular to the septum. Now the secondary curves are a little different, but when you take the lead inside them, they will straighten out. So you don't worry about them being a little more acute. So how do I implant? You can put a His bundle catheter to localize the His bundle area and then go the conventional way 10 to 15 millimeters beyond. It starts with the puncture. You take an axillary puncture, the usual way. What we do is we take a long Thermo 034 wire and we take it to the RVOT. This wire goes to the RVOT, and then we just track the catheter which I showed you in the last picture. We'll track it to the RA. At this point, we'll just take out the dilator and just follow the wire, and the catheter will be pushed to the RVOT. If you can see the left fluoroscopy image, it is being pushed across the tricuspid annulus, following the lead wire, and it is placed in the lower RVOT. Once you have done that, we are in the lower RVOT in the right picture, you take the lead inside, don't take it out, and then you maneuver. Try to position as basal as possible. As I told you, clockwise torque will disengage from the septum, will help you move. If you see on the right side of the screen, if I'll pay it again in the beginning, when I rotate it clockwise, it jumps because it is free from the septum. It will jump there. Then you pull back slowly, and wherever you are comfortable, you again engage it by doing a counterclockwise torque. So you can see the final location which we achieved at the target site in RAO 20 degrees. This is a proximal location near the His bundle catheter. So there are 2 working views. One is LAO, one is RAO. We commonly use RAO 20 and LAO 30. But that is not you have to keep in mind that these are not true LAO and RAO views for the patient. Some hearts may be differently oriented. LAO 30 may not give you a perpendicular profile of the septum. Some hearts may be little counterclockwise rotated, clockwise rotated. So this is all an assumption that RAO gives you a picture like the one which we saw in the beginning, and LAO gives us just vertical orientation of the septum. So after placing it in the RAO at a more proximal site, I told you how to engage and disengage from the septum and position it. You just pace at that site. The pacing it has to be done in a unipolar configuration. I'll go back and I'll show you how the connection has to be. So the red crocodile clip has to be connected to the skin, or if you have a self-retaining retractor, you will connect it there. And the black crocodile clip will be connected to the IS1 pin of the lead. So this is how you make it in unipolar configuration. You will pace at that site. You will pace at the site where we just reached with the catheter and the lead. And what is the target site for screwing? Our target site is at a place where you get a notch, a W in V1. The scope is beyond discussion why there should be a notch, but you should remember there should be a notch in V1. The axis should be as normal as possible, so there should be a lead 2 and 3 positivity. Ideally 2 more than 3. Sometimes lead 2 positive, lead 3 negative is also okay. And there should be an AVL-AVR discordance. AVL should be positive, AVR should be negative. It is like if I take an ECG in my body. In my body, lead 2 and 3 are positive, 2 more than 3. And AVL is positive, AVR is negative. Now we saw that the conduction system is spread throughout almost to the apical septum, but we don't want to go to that apical because we want to mimic a normal activation. A normal activation comes from base to apex. How do we know it's base to apex? Because the precaudal leads give us a precaudal transition at V3, V4. So a transition at V3, V4 is possible if we are proximal. If it is too apical, there will be no transition at all. There will be a QS in V4, V5, V6. But we don't want that. We want to pull it back. We want to be at a place where there is at least a positivity in V4 or at most V5, V6. If you can see, we have kept this lead at a location. The lead 2 is positive, 3 is negative, AVL positive, AVR negative. V1 has a notch. And if you see the transition is like, at least we have some R in V5 and V6. So the preferred target site to start screwing is inferior lead discordance, AVR discordance, a precaudal transition by at least V3, V4, and with that, a notch in V1. So with this, I'll also tell you why lead 2 characteristics may not be always required, because this lead 2 positive, 3 negative thing is not always possible. Sometimes when you put the lead inside, the primary curve will stretch out. It will stretch out and it will not allow you to go to the anterior location. You will be stuck at a posterior location. At this posterior fascicular location, which is the most common site of pacing, which was around 75% of all cases in the Mellows registry of left bundle area pacing, they found that 2 and 3 will be negative in that scenario. So in real life practice, the most common paced configuration at the target site you will get is actually 2 and 3 both negative, because particularly in stellate driven leads, they will stretch out the primary curve and make you go more down. So you are not able to come up because of the lead which is splaying out the primary curve. So with this, we just, this is not required actually, but we have done a septogram in both the views. You can see in RAO view, we are just below the tricuspid valve. You can see the negative contrast, and this is a septal leafleted tricuspid valve. I'll just freeze it here. And you can see the chordae also. So this is at the basal location in LAO. Then you go to a LAO view. LAO is 30 for us. And then you just do a septogram just to see the orientation, whether you are perpendicular or not. The classical recommendation is it has to be 10 degrees to 30 degrees. It is not horizontal, by the way. It has to be little inclined up, because the heart is oriented in that fashion in the body. So after that, if you are using a stellate driven lead, you first take out the helix. So in the left video, the helix is being taken out with rotations of the IS1 pin. And after you are done with that, then after fixing it, you just rotate the body rapidly as rapidly as possible. Sometimes slow rotations are also okay. You will notice that with these rotations, the helix is rotating.
Anindya, if you can hurry up a bit.
Yes, sorry, sir. So it will go inside. How do you know when to stop screwing? We will see the V1 morphology. The V1 morphology will go from a notched QS, and slowly the notch will become right, and it will become an incomplete RBBB. So this pacing morphology is actually an indicator of where my lead is inside the septum. If I am on the RV side, it will be LBBB. If I am on the LV side, it will be RBBB. If I am on the RV side, it will be LBBB, and if I reach the LV subendocardium, there will be a RBBB pattern. So this continuous monitoring is possible with stellate driven leads, and you can continuously monitor something called left ventricular activation time, and which will be discussed by other speakers as well. So in this image, in this continuous transition, you can see we started at a place where 2 was positive, 3 was negative, and precaudal transition was V4, V5, V6. But as I reached towards the end, the 2 and 3 have become both negative. How is it possible? I started at a site and I was perpendicular, and my precaudal transition previously was late, and how did I become more positive, more early transition towards the end? This is because we think we are going perpendicular, but it is not the case always. Almost always that will not be the case. We will be going little oblique in the septum. So this is a case where you can see in RAO view, we are actually in posterior. In LAO view, you will think, I am perpendicular to the septum, what went wrong? But in RAO view, you will see it actually went posterior. There will be other cases when you think in LAO view you are going perpendicular, but in RAO view, you will see you are going more anterior, more towards the RVOT. That's why the change in morphology. Sometimes, however, you can catch selective fascicles also. In this case, at a lower output, at a higher output, it was a QR with a transition early, but when we decreased the output, it selectively captured the left posterior fascicle, and the morphology changed. So this is another example where you can continuously monitor the left ventricular activation time and the impedance. It is important that the device representative tells you the continuous monitoring of the impedance, because a sudden drop of more than 200 or an absolute drop less than 450 will imply that you have perforated. You also have to see, when you go deep inside the septum, your ring will also, there are 2 portions of the lead, there is a helix and the ring, both will capture. So the ring will show you the morphology very big and notch. Do you remember 2 positive, 3 negative notch in V1 transition late? So this ring is also still capturing and tip is also capturing. So you are that deep in the septum, you're capturing both. So when to stop advancing the lead, as I told you, when you reach an RBBB pattern, so this is the septogram which you can do, which is optional. How to give a slack? The slack has to be, the loop has to be in the RA and not in the RV, otherwise it will give you traction at the lead septal interface and there will be too much of a pressure there, increasing the chances of a lead fracture, which Shanmugasundaram also has published. So this is another example. Sometimes you will get the fascicular potential. That is a criteria of conduction system capture. I'm not going to go into deep conduction system capture criteria, but you can do an S1, S2 protocol, just like a dual AV nodal physiology in AV and RT. You can get differential response, which will tell you there are two different kinds of tissues at that specific location. You can pace from high output to low output. You can correct bundle branch blocks with conduction system pacing, even with his bundle area pacing, because in two-thirds of cases, the block is actually proximal. I'm already a little late. So one of the criteria for conduction system capture is to pace at a higher output and a lower output, and you will see change in morphology if you are near the conduction system. So lead bundle area pacing using a lumenless lead is also not so much different, but it is typically guided by template beats. A template beat is like a paced beat only. The template beat, the PVC is actually coming from the site where my helix is. So if my helix is on the RV side, it will give a QS pattern, and when we reach the lead bundle, it will automatically give a PVC, which is a QR. So with this, we'll finish the implant. Slitting is like in any other standard criteria, you'll have to give a slack. There is a summary of lead bundle area capture, but which is not relevant to my presentation. So perforation, I told, sudden impedance drop, current of injury drop, loss of capture. So with this, I'll just say that conduction system pacing is definitely a paradigm shift. Left bundle area pacing has taken over. It is relatively straightforward when you know the basics. Expertise definitely comes after initial 20 cases. EP system is not a requisite, but the knowledge of the anatomy and conduction system physiology is required. Thank you.
Thank you, Anindo. It was a wonderful presentation. Just one, I can invite the opinions, like usual way of going in the RV. So you demonstrated that you have to go with a wire and then to RVOT and come back. So these, especially Boston and Abbott sheets, are a little sturdy. Sure. And while coming from RVOT, if you are not very you have not turned the catheter clockwise, it may fall in anteroseptal groove, and their chances of injury can be there. Yes. So for me, it is we maneuver the sheath without the dilator from RA to RV. Yes. I can have opinion from Shanmuga, Dr. Gopi, Praveen, Debu. So what like I do in situations where I'm unable to take the sheath directly to RV. Sure. So yeah. Can we have 1 or 2 mics?
Good morning, everyone. Like Sir was pointing out, our concern is also to preserve the right bundle conduction, especially in patients with baseline left bundle branch block, where you can get a beautiful fusion with the right bundle native right bundle activation. So we tend to take the C315 sheath from right atrium to right ventricle. It is not really a tough job. Even with the hard sheaths like Boston sheath, Abbott sheath, you can still maneuver it from right atrium to right ventricle. That will prevent the injury to the right bundle, which is very, very crucial. But in patients where we are doing it from the right side, so I tend to take the sheath into the right ventricle and pull it back, because there we don't have, apart from Boston, I think we don't have any specifically designed sheaths for right-sided access. So only in those scenarios, I tend to take the sheath right into the right ventricle and pull it back. There also I'll be very careful in avoiding injuring the right bundle. But going into the RVOT and coming back, there will be a definite high chance of injuring the right bundle. So that particular maneuver we tend to avoid.
Yes. Yeah. Sir, actually, in some Abbott sheets and Boston sheets, they are not so stiff, and when you put the lead inside, they will straighten out, and you will not be able to go anterior at all. In that case, maybe this helps.
Agree with Anindya. I just make a comment. Although the master is here, I would say for Medtronic sheets, it's very easy to go from the right atrium to right ventricle, which we regularly do with the Medtronic lumenless lead positioning, that you come to right atrium and just clock and go into the right ventricle. For stellate driven leads, I have been doing it almost 100% from RVOT as you discussed and coming down into the left bundle area. Till now I have never found like AV block or RBBB. I would say none of the cases I have found. The concern which Shanmuga sir and Dilip da is telling, I have never encountered. So my approach would be for Abbott sheaths, you can go from RA to RV. For stellate driven lead, go to RVOT, because we have found a lot of difficulty in these sheaths. The shape is such that if you try to go from right atrium to right ventricle, it's very difficult unless you are a master like Dr. Shanmuga. The second thing is the same maneuver which clock can go into the right ventricle has another difficulty. I have faced that the sheath got kinked in that process. So both of these can be prevented the way you have showed.
Yes.
Go with the termo wire, go into the RVOT and drag it back. Don't go with the sheath into the RVOT.
And not
let the
drag it
wire
back,
be,
so it
yeah,
has to
let
be
the
like-
wire be in the RVOT.
Yes,
Your sheath be in the just mid RV region. Any comments, Dilip da?
So with the Arun comment, we'll move on to the Debu's presentation. Arun.
Yeah, so we realize that every implanter has his own personal choice, but what my own way of doing it is for the Medtronic sheath, chance of kinking is less. So with the Medtronic sheath from RA, we just counterclock, get into RV, and it just stays in there. For the Boston and Abbott sheaths, they are stiffer, and if you torque them without a dilator or wire in, they tend to kink, and they tend to kink mostly in the subclave and all the SBCs. So all these cases, we put a wire into RV and then enter, but as Shanmuga and Dilip felt, I never go to RVOT, I just go to RV apex. Because your purpose is to avoid the tricuspid superior annulus where your right bundle is. So we never go superior part, we go to the RV apex, track the sheath in, and then with the wire inside the sheath, clock it to the septum, and then pull the wire out. So we to avoid the RV outflow.
Perfect. So thanks, Arindo. We move on now to Debu's presentation, Basic of Electricals, and he will show us the criteria and everything. And then, Debu, please.
Thank you, Dilip da and the organizers for the kind invitation and introduction. Actually, Anindya's talk, I got late, so Anindya had to present early, and that actually had benefited the audience, I believe, strongly. Although he overshoot his time maybe for 5-10 minutes, but I would say this presentation, if it is uploaded, will be taken as a master class on left bundle pacing. So my job has become very easy after Anindya's talk. I'll just not go into this thing. I'll make my presentation only 5 to 7 minutes to compensate for Anindya's talk. And he has actually covered the portion I wanted to cover. I'll directly rather go into Anindya's talk. He was supposed to say how to do left bundle pacing. I'll just show you a couple of cases. So other than going into the detail, as Anindya has shown that what our job is to do, we have moved away from the his bundle pacing. So we are doing now, globally also, there is a significant shift from his bundle to left bundle pacing. And our job is penetrate the septum and reach the left ventricular subendocardium into the left bundle area. Now, this is this image is again borrowed from the master Dr. Shanmuga. So if you look at the image, this is the his bundle region, and this is the left bundle area. So even if you are a non-EP cardiologist, if you have a temporary catheter, not even a quadripolar diagnostic catheter as in this case, even if you have a temporary catheter, this hump is very important. If you can imagine that how your temporary wear is in the RV, just below that hump will be your left bundle area. You don't need to be a electrophysiologist. So I just removed that image, superimposed image. Now you can see, you can imagine yourself that you have to reach this area. Fortunately or unfortunately, the stellate driven leads by default goes to this left posterior fascicular area, which is not as ideal as main left bundle trunk pacing, but which is much easier to do because that part of the septum is much easier to penetrate. The success rate goes as high as 95%. This is one of the way what Dr. Gopi was telling, that we have gone into the RV apex, and on that pterymo wire, I'm taking my sheath and dilator and I'm reaching that below that hump area. So what Anindya discussed, that you have lead 2 positivity, generally 3 is negative, AVR negative, AVL positive. This generally tells you that you are in the main left bundle trunk. Don't be apprehensive even if your lead 2 is negative, but make sure lead 2 has some slight positivity at least to tell you that you are not too much inferior and you are losing out on the whole left posterior fascicular system as well. You are just penetrating the myocardium where the success rate will be too low. In V1, this notch is very important. We have found if this notch is in the ascending limb, the chances of success rate of penetrating and reaching the left bundle area is more than 90%. Whereas if you do not have the notch, it is unpublished data, if you do not have the notch, the chances of getting left bundle area once you penetrate is around 50 to 60%. So this notch in V1 is very important, AVR is very important. And one important thing to remember, that sometimes some of my colleagues ask me, if a patient already has a baseline RBBB, how to approach the case? You don't have to worry about at all whether the patient is having a RBBB or a LBBB. You do it just like that, because even if in presence of RBBB or LBBB, you are doing pace mapping on the right side of the septum, you get a LBBB morphology like you are getting here. And your job is to screw it, make it a RBBB pattern. I'll just show one of the case, but this is one case to show you. This is a left posterior fascicular pacing. When we started on pace mapping on the right side of the septum, lead 2 is almost completely negative. What we are expecting, even a small positivity like here is good enough. If you have a notch here, is very predictive that you might still get a success even if you are inferior in the left posterior fascicle area. The same case in a slow or faster speed, if you look at this, is a little different case actually. Lead 2 is positive here, the same case in a different side. So this is when you started off, and we thought it's a good side because it's ascending limb notch, 2 is positive more than 3. Then you partially screwed in, I'll show you how to screw in. You see that notch here has climbed up a little and become a hump here. Once you screw a little more, you see there is a prominent R prime. Your job is done in majority of the cases. Only couple of things to show. If it is a non-LBBB case, try to connect the lead and show a left bundle potential in some of the cases. Unfortunately, because of the current of injury, finding left bundle potential is not that easy. Only in my cases, I find 20%, less than 20% of the patients have a left bundle potential. The other thing what you actually should see, that there is some kind of a transition. Once you have this kind of a morphology, you try to show that this is not just a left subendocardial pacing, and it's truly a conduction system capture. You start from a higher output, maybe 8 or 10 volts, and come down gradually till the threshold. You will find some kind of a QRS change. If you can show some kind of, any kind of a QRS change, wide to narrow, narrow to wide, that tells you you are actually capturing some myocardium and some conductions tissue. Most of the cases are done in that way. This is one particular case where you could find a left bundle potential as you see here, but as I said, many of the cases you may not find. This particular case, as I was telling you, see we started with the RBBB, but it doesn't matter. When you pace, you will find something like a LBBB morphology. Once you screw in, you will find something like a QR or a RS/R' pattern. So I'll just show a couple of cases here. This is how to connect in a unipolar fashion. Then I am showing that this is a stellar driven lead. You have to expose the helix in a particular site where you have pace mapped and you find it as well morphology. Then you have to lock the device in majority of the stellar driven lead cases. Once you lock it, once you are manually drilling it, then the helix will not fall back. And then once you try to screw in, you see we have started with a W and lead 2 is negative. So this is predominantly a left posterior fascicle. We are screwing in, we are trying to screwing in. I'll skip the video for the interest of you. See the notch is climbing slightly. The notch which was in the just at the nadir has climbed up almost at the end of the video. We'll see it is almost at the end of that QRS complex. So I generally stop here and try to see, because one thing, this stellar driven lead has a slight inertia. Even if you stop little prematurely, check it, and then you go turn by turn if needed. That same side, when it was a simultaneous this thing, then as you find the lead was progressing. And then this is the same patient, once you slightly drilled in, maybe half turn, 1 turn more. Now another advantage of the stellar driven lead is you can see continuous ECG and live beats, so you know when to stop. In lumenless lead, you have to drill it and again recheck it, drill it again, recheck it. That's a little difficult job, but in stellar driven lead, you have the luxury of getting live ECG monitoring when you are drilling in, because you connect the crocodile to the stylet and you know when immediately you have to stop. There are many ways of screwing it. This is one of the way, but I prefer the other way, like left hand going like in other way. But there is no right or wrong way. The major thing is you have to drill it well and you have to stop it. Before you slit, how much time I have left? Can I see? Yeah, 1 minute. Yeah, thank you. So before I slit, once I am done, two things needs to be seen. Current of injury, you see here, there is a ST elevated MI almost like in the current of injury. In fact, it is a ST elevated MI at that local site. And if you perforate, what will happen, I'll show you. There is this RV unfiltered will show you, that there is no ST elevation. So look at the appearance is also very important. Sometimes the machine will tell you have a current of injury 20, but have a look of it. The look of good current of injury is like this. The other thing is your impedance has to be more than 400 or more than 450. It depends on varying on the labs, but below 300, 350, it is invariably into the left ventricle if it is associated with less current of injury. So just going to couple of cases post shooting in next 1 minute. This is one of a case with LBBB, and we had got on table very good left bundle capture. Next morning you find this. What are your DD? So you have to remember that if you are doing a conduction system pacing, it's like CRT, you have to compete with the conducting right bundle. So in this case, what we had to do, we just had to shorten the AV delay. You have to remember, if you are doing for resynchronization purpose with DCM LBBB, you have to keep a AV delay. In this case, the same case which I showed, the sensed or paced AV delay was made 40 milliseconds and 50 milliseconds to overcome that right bundle conduction. Another case, once you conducted the pacing, this was the pacing, and as soon as after slitting is done, you find in the V1, there is no RBBB. Sometimes you will be horrified to see this. After slitting, have I mobilized the lead or have I dislodged the lead? You always remember after slitting, sometimes we try to check the lead in bipolar. When you check the lead in bipolar, you can have an anodal capture. What I mean to say, once you lose the anodal capture, you still have a very nice left bundle capture in V1. This is one of the meaning of anodal capture. When this anode is touching the septum, it can capture from there. You can do the conduction system pacing without EP system also if you can just mobilize your EP, your TMT machine or the TMT monitor in the Cath lab. What you can find here that there is a notch in the R prime. So I'll just stop here and take up any questions. Thank you so much.
So wonderful talk, Debu. There are situations when you get a very good LVAT, maybe around 80, 78, something like that. Good transition, but you don't get a good R wave, okay, in V1. So, and also the QRS, if you measure with calipers, it is around 100 or 110. So, and you are advancing further to get further capture and maybe a pseudo RV pattern, but it's not coming. So what do you suggest in this situation? Should you stop there, accept this, or you should look for other positions?
So why we get this R prime is because of the right ventricular or right bundle delay. If I am not finding after several attempts, I will consider this as a deep septal pacing, which is okay, but I will definitely not consider this as a left bundle capture. If I am doing it for a pacing indication, that's all right. If I am doing it for a resynchronization purpose, I will certainly put another coronary sinus lead if possible.
Great. So can we have some other opinions? If
just in the same context, I will try to see what happens. Generally, we check the lead parameter at 5 volt and 0.4 milliseconds. Sometimes in 5 volt, you find a narrow QRS complex, no RBBB. But as you come down, there will be from non-selective to selective capture. The scenario you showed, maybe at 1 volt, you have a very nice left bundle capture. Always before advancing the lead, try to see at various outputs whether you are capturing or getting R prime or not.
But in my around 200 cases experience, what I have seen, in almost majority of the cases, you get a good RBB, good R wave. But in some of the situations, you don't get it. But you get a good LVAT and around 70, 75. And then you leave this patient, and by some programming and all, you get a good QRS, maybe 90 or 100. You can say it a deep septal pacing, or you might say that the narrowness of the QRS, if you have achieved less than 100, it should give us the same result. But definitely we need to go further in to get a R wave. We should not try stopping when we are getting good LVAT and good QRS. You should keep on drilling till you get your impedance dropping more than 200, or you are feeling that with stylus driven you are going out, with a nodal capture also getting, but still you are not getting a unipolar, a good R. So perfect.
I'll just make one more comment before I conclude, that in CRTs we look for a QRS narrowing. In conduction system pacing, especially left bundle, his bundle pacing also we are looking for the narrowing. For left bundle pacing, especially in 75% of the cases, Anindya rightly said, same is my data, 75% of them are left posterior fascicle pacing. I do not even bother about the QRS narrowing. I bother about whether I am producing a right bundle delay. I am bothering about the LVAT. Because if you are producing a RBBB and LAFB, by creating or by producing a left posterior fascicular pacing, obviously your QRS will be wide, like 120, 130, even 140. But if I have a QR, if I have a transition in the QRS, the echo response is very good. I must say the QRS narrowing in left bundle pacing, especially in left posterior fascicular pacing, is not that important. I would like to hear from Dr. Shanmuga on this comment. Thank you so much for the opportunity. Have a good day.
Thank you, Debu. So, so
Dilip,
yeah.
Dilip, this is Dr. Clay. Sorry you couldn't come physically.
Sir.
Just two comments. For one is that I am bothered about the QRS narrowing. I will not be happy if I am doing the conduction system pacing and my QRS is more than 120 milliseconds. Number one. Number two, R prime you don't get in every patient. There are few times the QRS is very narrow, LVAT is excellent, and you don't get R prime, and I don't bother about that. The another comment is about the impedance. The speaker said that it should be more than 450. Yes, I agree. But we have seen that sometimes the impedance is around 380, 370. It looks low to me, but then we, kind of wait for some time. We check the parameters. If LVAT is good, if the impedance is stable, and your QRS is good, we accept it. I don't think you can put a figure of any like 400 or 450, but yes, usually it's in that range when you get the conduction system base.
Thank you, sir. And we are missing you in person. So, but you have to wait for your turn. We are going 15-20 minutes late. So, may I invite now Arun for his presentation. What all evidence we have gathered in last 2 years and what's the development? Arun?
So, a warm, respected Chair, a warm good morning to all. At the outset, I thank Dilip for the opportunity, and my talk is not exciting or anything much on a case-based stuff. It's more of like a journal club that you would see in your DM dates. So it's about what's new in the field of CSP and what is the new evidences that has come forth in the last 2 years. That's what I'll be dwelling on. So let's start on with what's the most starting of publication in 2022 was the Gessinger-Rush CSP registry on a subject which we knew very much, but it has this Gessinger-Rush registry from the pioneer Vijayaraman sir and Parikshit Sharma. They actually established the fact that CSP is clearly superior to right ventricular pacing, which showing statistically significant reduction of QRS duration, mortality, heart failure hospitalization, and need for CRT upgrade compared to RV pacing, and more so in patients who have more than 20% pacing requirement. So this is a well-known fact, but they put the fact on paper with this registry. Similar thing was echoed by a Singapore group by Tan et al., where they showed similar results, statistically significant reduction in mortality, heart failure hospitalization, and CRT upgrade in patients with CSP compared to RV pacing, especially people with pacing more than 20%. Now, the Mellos registry that was alluded to earlier, it is actually from a multi-center European registry from 14 European centers with almost 2,000 patients, where they found the overall success rate of left bundle branch area pacing in Brady indications to be 92% and for heart failure indications to be 82%. But the more intriguing thing in this was the complication rates. It is very reassuring to see that the complication rates are not that high. It is 8%, but majority of those complications dwell on to the septal perforation from the lead, which is 4%. So this is a benign complication, and none of the other major complications have been alluded to. So it's more reassuring, and with a success rate of 92%. Now, in the real world data, what the US looks at is how CSP is effective. We have data from more than 2 lakh leads, and it is very safe and effective in the real world experience. The Europeans also echo the same. They did a physician survey. They found that there's increasing use of CSPs more. Lumenless leads take the lead here. Now, some of our concerns when we start off this therapy have been dwelled in with. In young patients, it is very safe with equivalent success as the adults. So this is a publication in Pediatric Cardiology where it showed similar success rate. In elderly patients, more than 85 years patients, again, this is a publication, Nature Scientific Reports, which says equally effective results with CSP in patients more than 85 years. Now, stellate-driven versus lumenless lead, it's always a controversy, but all these studies show similar outcomes Similar implant success rate with stiletto-driven leads or lumenless leads are operator choice. It's about the technique rather than what hardware is used. Although stiletto-driven leads have shorter implantation times. That's the only thing that was found to be statistically significant. And this is what was was echoed by Hallenbury and group as well from the European Society, where they found similar results and implant success rate with SDL versus LLE, lumenless leads. Now, some of the modifications that has been suggested in last 2 years is when you're using a stiletto-driven lead like Solia, it is better to give an angle, at least a 35-degree angle, which will ensure more of the electrode into the septum, and which will ensure at least 18 mm thickness, 18 mm length of the pacing lead into the septum to avoid the vulnerable point being outside. And CLS closed tube simulation equally works well with left bundle branch area pacing as well. And they also looked at this concept of lead fractures, which have been reported with stiletto-driven leads to the tune of 0.6%. They found that this is the vulnerable point that we all talk to. This is the vulnerable point. So if you get 13 mm into, you can avoid this fatigue fracture, which happens when there's abrupt bend more than 12 degrees in about 1.3% of patients. So this is one thing which has been dealt in the bench testing to avoid a conductor fracture in stiletto-driven leads. Again, in left ventricular septal hypertrophy, there is some publication which says that stiletto-driven leads have an advantage of getting in very well deep in and getting good pacing parameters. One thing that was earlier shown by Deb was the continuous lead stylet pacing facilitating a left bundle lead implantation, which has been published which shows that a beat-to-beat real-time monitoring of impedance and pace QRS definitely goes a long way in ensuring good success. So this is the concept that was again alluded to. The moment you lose his Purkinje capture, your ventricular septal pacing outcomes are just similar to what you do with the conventional RV pacing. So it's important to maintain capture of the conduction system. The moment you lose his Purkinje capture, this is what happens. This is publication from Shanmuga itself. A lot of in the last 2 years, if you see, it's publication from Shanmuga himself. So this is one concept that he has alluded to. New onset LV dysfunction after left bundle branch area pacing. He found it in about 3% of patients, and the major reason was loss of conduct system capture, suboptimal AV delay, AF, and idiopathic. So this happens in as long as 9 months after the initial implant. Reinterventions definitely corrected this, but it emphasizes the fact that you need to periodically assess in the device clinic, because new onset LV dysfunction might be because of loss of conduct system capture. Again, post AVJ, there's data which says CSP is superior to RV pacing. It's a no-brainer. And again, there's good data which says as a left bundle branch area pacing is better than his bundle area pacing. The LB versus CRT, all data universally show that there's lesser QRS duration, lesser mortality, lesser heart failure hospitalization, and better NYHA improvement with left bundle branch area pacing. This is a publication in JACC. Similar publication in Heart Rhythm, which says similar results. Another registry in Heart Rhythm, which says similar results. But all data clearly show that left bundle branch area pacing is superior to CRT for major outcomes in resynchronization. And the moment you lose the conduct system capture, you have LV septal pacing, the outcomes are dismal. So this is again when you need to when you're extracting a CRT, it is probably wiser to go back with a left bundle branch area pacing rather than putting a CRT again. Now, hot CRT, clearly this data shows that hot CRT is superior to a conventional BIV, and this has been published in JACC EP. Lot ICD, that is again, so the conventional ICD, in addition, in the patient sport, we place a left bundle lead, which showed to have a stable R wave sensing. It was in fact a better cost-effective resynchronization way with lesser fluoroscopic exposure. So we have a DF1 system where you have a patient sport being connected to the left bundle area lead, and this is what is called the Lot ICD. Now from there, they went to the next system of implanting an ICD lead directly into the left bundle branch area, which is called LBB-AD, which is left bundle branch area defibrillator lead. First in human feasibility study was published in 2023, and then in 2024, they published the first in human experience and the short-term follow-up. They found it successful in about 11 out of 12 patients, and Shanmuga also published this. Actually, this is a standard ICD lead through the conventional sheath getting into the left bundle branch area. So this is the standard ICD lead, and this is Shanmuga's publication, which showed a success rate of 62% when we're using this. And one step ahead is if you are able to get your defibrillator into the left bundle area, you can actually do a single lead CRT with a DX IC lead. You have atrial sensing from the DX IC lead, and your defibrillator is in the left bundle area. So you have a single lead CRT also feasible, which has been shown in. Now, RV activation pattern during left bundle branch area pacing has also been described. 3 patterns, type 1 being through the conduct system, type being through the myocardium, and type 3 being a hybrid of both of these. Again, Shanmuga will be alluding to on this. Right-sided approach again has been shown to be safe and effective with about 84% success rate with the conventional C315 sheath itself. As I said, if you do it for any kind of QRS, if you have a narrow QRS or right bundle branch QRS, you will preserve the synchrony. For left bundle branch block morphology, you will improve the synchrony. Well, left trunk versus fascicle, again this has been compared well. Majority of time you will end up with the fascicular pacing as was alluded to by Deb, and it has almost equivalent electrical synchrony and pacing safety compared to the trunk. So this is what has been shown in the studies. When you are doing a left bundle branch area pacing, you end up with septal pacing in 23% of patients. In 76% you do the left bundle branch area pacing, and out of which only 12% of times you are in the trunk. In about 40% you're in the posterior fascicle, 46% you're in the septal fascicle, and 12% you're in the anterior fascicle. How do you differentiate between these two are based on your morphologies in the inferior leads. When you're anterior, you will have inferior leads positive, your AVL will be negative. When you're on posterior fascicle, you will have inferior leads negative and AVL will be positive. Your trunk versus septal fascicle will almost look the same, but septal fascicle will be slightly broader. Now, if you want to, this is again a publication from our own, from India itself, where they used how to do a left bundle branch area pacing in a non-EP setting. You can use a modified V1, V6 lead and a TMT ECG to just do it with a conventional PSA itself. TechSpam study is another one thing which eluded our fears of extraction of lead, where they extracted 341 leads, out of which 321 are lumenless leads and 20 were stellar-driven leads with good amount of success rate. So they had a 99% procedural success rate of extracting the conduct system leads, only 2% minor complications, 95% were re-implanted. So the predictors for need for extraction tools were just two. One is diabetes and long lead dwelling times. Now again, atrial resynchronization, another thing that is coming up much. So just like the ventricle, you can resynchronize the atrium with either a handmade stylet which goes and paces the lower end of the atrial septum, or as our own colleague Muthaiya Subramaniam Narasimhan sir's group showed, you can use a sheath-assisted, electrogram-driven, a backbone bundle branch area pacing with a stylet-driven lead to get atrial synchronization on. Now, I'll conclude with this. The last 2 decades also had brought the IBHRE clinical consensus statement on CSP, which clearly depicted the guidelines or the consensus statement on what are the criteria for achieving left bundle branch area capture. This is the 2023 Heart Rhythm Society guidelines, which gives a 2A indication for CSP if your CRT is ineffective, and 2B indication for CSP upfront, and 2B indication for CSP even if you're doing for patients with AVJ. And the last breakthrough, or the biggest breakthrough that I would say that has happened the last week or so, is the hybrid of conduct system pacing as well as leadless pacing, where Abbott actually announced the first in the world leadless pacing procedure directly into the conduct system. So this would be a hybrid of the latest innovations, both the leadless as well as the conduct system pacing, where you have a leadless device going into the left bundle branch area pacing and giving you a conduct system pacing. So that's the latest development that we have, which has been published a week back, that is on December 17. And this would actually really open up arenas and making up of the hybrid of best of both the worlds. So that's all from my side. I'll be happy to take on any questions.
I think, yeah, so we got wiser what happened in last 2 years with Arun's talk, and we also, looking at leadless system with conduct system pacing fusion, how we do that, and especially the Abbott system, the delivery catheter is I tell them always, this is a super catheter they have made. This is such a atraumatic distal end, and it can go to 360 degree. You can turn turn around, and you can go and fix your lead and capsule, leadless capsule at a place where you desire. So Arun, can you elaborate us exactly how they are doing with this connection system?
Doesn't make any sense.
Yeah, so we have implanted 4 of AVIRs till now in the last 1 month. So what we have found is, as Dilip rightly said, they have a safety sheath over it, so it ensures that you are not traumatic compared to the system that we had earlier from Medtronic. We are not worried about with the safety sheath in, we can just give any amount of clock. But this device that is being alluded to by Peter Newsell, Vivek Reddy and group, it's actually a newer device, it's not the conventional AVIR LP that we have. It has a extended helix at the tip, which actually goes into the septum and achieves conduction system capture. So it's not the conventional AVIR that we have, which we have been implanting in the last month or so. It's actually a slightly different device with an extended helix, which is going to penetrate deeper into the area of conduction system pacing. And this is only in the first preliminary study that was done in Prague in Czech Republic, and it just showed that this device is feasible. A lot of engineering needs to be done to get it into the conventional delivery system and to make it feasible on a long term.
Any comment from chairpersons?
We have been enlightened on a topic probably some of our cardiologists are doing, but it is excellent knowledge for all of us, and we can try and bring in this type of pacings in our practice. Thank you very much.
And now we move on with the Dr. Clear's presentation, and then Dr. Sunmuga will give his presentation. Dr. Clear, sir, are you online? Can you hear us?
Am I audible?
Yes, sir. We can hear you, sir. We can see you as well. Yeah.
Right. So now the thing is that I have one comment on Arun Gopi's talk that, see, I don't believe in left bundle area pacing. I believe that it has to be conduction system pacing, whether it is a selective or non-selective, that doesn't matter. But ultimately, there is data also to show that when you lose the capture, the conduction system pacing in the left bundle area, that there is a clinical outcome, they start worsening again. So, and it makes, it's not a rocket science, I think it makes sense that you should have a conduction system pacing for proper resynchronization.
Good morning, everyone. At the outset, I'd like to thank Dilip sir for giving me this opportunity. This is, I believe it's my 5th occasion to stand in this device update. So I was assigned the topic of discussing about the future of CSP in the next 5 years. I believe it is bright, and so only I'm here now. So what we have learned in the past 5 years about conduction system pacing, we still believe that his bundle pacing is the most physiological form of pacing, but it has its own limitation. Left bundle has come as a salvage procedure, and it provides excellent long-term stability. But the only issue with left bundle is to differentiate between the true conduction system pacing versus LV septal pacing. We also learned that during follow-up, a significant number of patients, nearly about 4 to 4.5% of patients, can have a loss of R wave during follow-up. And these patients are at risk of developing a new onset LV dysfunction, which was seen in around 3.75% of our cohort, which involved 400 patients. So it's very important to monitor these patients regularly in device clinic, both with ECG as well as clinical and echocardiographic assessment. We also have learned about the long-term durability of these leads, be it styler-driven leads or lumenless leads. So we need to carefully monitor these patients because these leads are not meant for deploying it deep inside the septum. In fact, this was a collaborative study involving close to 8,500 leads, which had shown that the fracture rate or distal conductor fracture rate is more with styler-driven lead as compared to lumenless lead. So overall in the world, there were 2 lead fractures reported from lumenless lead. One is from my center, another from Dr. Vijayaraman Sir Center. Apart from that, there are no episodes of lead fractures from lumenless lead. So what we can expect in the next few years, we can expect some improvement in implantation tools, better criteria to confirm the conduction system capture, and imaging modality, which is an upcoming one to facilitate conduction system pacing, combining the technologies of defibrillation therapy and leadless therapy with conduction system pacing. And we need more and more randomized trial to bring it up as a class 1 indication so that it can be used routinely. We know we all started with C315 sheath and 3830 lead, but we have now delivery catheters, both deflectable as well as fixed from all our industry partners. And probably in the near future, we'll be having a dedicated conduction system pacing leads meant for capturing the left bundle. And probably that will definitely improve the procedural success rate. So there is still a debate of discussing about the extendable helix versus fixed helix lead. Probably in the near future, who knows, maybe all the industry partners, they may be coming out with a styler-driven
fixed helix lead. Probably that is the way to go. And as I've discussed, the confirmation of the conduction system capture versus differentiating it from a left bundle branch, left ventricular septal capture is very difficult when it comes to left bundle branch pacing, but it is quite easy when it comes to his bundle pacing. It's like differentiating the cat from the tiger. You can easily differentiate his bundle pacing from myocardial pacing. But for left bundle pacing, the QR pattern, which is the so-called classical pattern of left bundle pacing, can be seen in 40% of LV septal pacing. So we need to have a simplified but a better criteria which should differentiate LV septal pacing from left bundle pacing. So this is the criteria which we always adapt, and we are almost like 99% of the time will be correct by following this simple criteria. So one is the QR pattern or RBBB delay pattern, which will be seen in majority of the patient, not in all patients with the left bundle branch pacing. But this should be taken as one criteria. Apart from that, we need to have one other additional criteria to confirm that we have captured the bundle and not the myocardium. So this can be a short and constant LVAD or an output dependent transition in QRS morphology. I was talking about the imaging. This is one paper which was published a couple of weeks back in Heart Rhythm, where they have where they enumerated the anatomy of conduction system from the CT angiographies. They have used fixed landmarks, and based on the activation pattern and the QRS morphology, they have demonstrated the anatomy of the conduction system with the help of CT angiography. So in fact, we had a study on CT angiography where we have done CT angiogram at implantation and at 6 months follow-up. So we got to know about some important things which happens at the lead tip inside the myocardium during 6 months follow-up. So almost like 94% of the patient had consistent conduction system capture, but nearly 75% had a stable lead which moved at less than 1 millimeter. But there were certain leads which were deployed little inside the myocardium, retracted back, and there were some leads which migrated little into the myocardium, touching the LV cavity. So these three group of patients, though there was some micro movements, there was a consistent capture, but those leads which got dislodged by more than 2 millimeter, so remember this number of magic number of more than 2 millimeter, this is what we got from our CT angiography study. These patients had a loss of R wave or loss of left bundle branch capture. So when we retrospectively went there and analyzed the histopathology of or histological specimen of a conduction system, we got to know that the thickness of left bundle fibers was around 1 to 2 millimeters. This is all postmortem studies. So this is matching with our CT angiography study. So when there is a lead displacement by more than 2 millimeter, then definitely there will be a loss of conduction system capture during follow-up. So this happens in nearly 6% of our patients. So we collaborated with the Italian group. We sent our CT for analysis, and we got to know about this beautiful picture of reconstruction of conduction system anatomy with the help of CT angiography. This is all post-procedure CT angiography. You can see the white dots, which is nothing but the pacing leads. So it is in the trunk, it is in the anterior fascicle, it is in the septal fascicle. So this helps us to confirm that we are into the conduction system. So we are going to go one step ahead by doing the CT angiography before the procedure and integrate it with our specifically AI-integrated fluoroscopic algorithm, so that we can navigate the conduction system during implantation, and that will facilitate and that will help us to reach either the main bundle, posterior fascicle, or anterior fascicle, wherever you want to go. So this is purely an experimental one, which we expect that the results will be coming in another 1 year. So if you are going to get a good result with that navigation system, I believe the conduction system pacing will be still more easy in the upcoming years. The another important thing, my all-time favorite cardiac MRI, it is probably a luxury to get cardiac MRI for all the patients, but it is always an essential one to determine which mode of therapy to be given or offered for a patient with a heart failure. So when you have a scar completely encircling the infralateral wall, I believe the CS leads will not work. You have to go for a CSP-based strategy. On the other hand, if you have a septal scar, based on the distribution of the septal scar, you can decide about a conventional left bundle pacing, a conventional CSP, or a combination of both. For example, this particular patient had a scar. You can see anything white in the cardiac MRI. After giving gadolinium, after 20 minutes after giving gadolinium, that can be considered a scar. You can see in the upper picture, the superior part of the septum is scarred. So I positioned my lead in the mid part of the inferior septum, where I could get into the left bundle, and you can give the beautiful appearing QRS. So in this way, if you have a pre-procedural MRI, demonstrating about the distribution of the scar, definitely that will help us in deploying the lead at the right area and to decide about the modality of the therapy. So combining two therapies, so defibrillation therapy with the CSP, though these days we have an experimental dedicated defibrillator lead which can capture the conduction system, but as of now there is no commercially available lead, so we have used the Abbott lead to deploy it directly in the left bundle area, but before that we had to do certain homework so that we can, when you are doing something new, you have to be very precise and be specific that it is not harming the patient. So we had analyzed all those patients who had undergone lot ICD and lot CRTD in our cohort and demonstrated that the sensing property of the left bundle lead for ICD function was appropriate. So almost 90% of the patient had appropriate sensing of arrhythmias from the left bundle lead, which is connected to the ICD chamber. So only in 10% there was an inappropriate detection. That happened purely because of T-wave oversensing, and that too with a particular device from Medtronic. So this we got to know that, okay, so this is working good, so the sensing will not be a problem. So we can safely deploy the ICD lead directly into the left bundle zone. So we have to discuss about the pros and cons. Advantage, obviously, you are reducing the number of leads, and you can directly deliver the ATP into the conduction system. That is going to have a better effect of termination of the arrhythmias. You are going to reduce the injury, valvular injury. But on the other hand, it is going to be a bulky lead into the myocardium. The delivery catheters, we don't have a specifically designed catheter. We have to keep in mind about the ICD coil length. Different vendors have different length. You don't want the coil to float in the atrium. That is going to produce atrial oversensing. And the patient needs to get appropriate therapy at the appropriate time. So we have chosen this DF1 Durata lead. So these are the criteria which actually made us to choose this DF1 Durata lead. It is a smaller size lead as compared to other ICD leads, 6.7 French. It goes easily into the 10 French locator 3D sheath, and it has an IS1 port which is compatible with the helix locking tool, and it provides an option of future lot CRT upgrade. Suppose if there is a micro dislodgement, since it is a DF1 PG, we can always use one more lead and connect it to the DF1 port. So this is how we prepare it. It is nothing new. You have to deploy the lead in the table itself, deploy the helix in the table itself with the help of helix locking tool. Then you take it into the sheath, deploy the lead by continuous spacing method, and once you reach the area, you will be able to demonstrate all the capture confirmation criteria. So once it is confirmed, you have to be little careful in removing the delivery sheath because it's a very snugly fit sheath. The sheath is 10 French, the lead is 7 French. So you have to be very careful. I tend to keep the stylet till the septum and then remove the sheath. And the sheath removal will be little rapid to avoid micro dislodgement. So what we have shown was nearly 62% of the patient had a procedural success. The failure occurred because of a GC septum and 2 because of atrial oversensing. Only in one patient we could not deploy the lead because of fibrosed myocardium. That too we'll get to know if you do a pre-procedural MRI. But the main important thing is all these patients received a DFT test on table to confirm that the arrhythmia will be appropriately detected and appropriately treated. So leadless technology, we believe in the future it is all going to be a leadless with conduction system pacing to provide physiological activation that will reduce the number of wires crossing across the tricuspid leaflet, and hopefully it will improve the battery life as well. So this is in the pipeline. Every single vendor is working on it. Probably in another 5-6 years, we'll be having at least one of the industry partners coming out with a leadless left bundle branch area pacings. So we not only target the ventricles, but we also target the atrium for providing resynchronization. So Bachman bundle is one good thing which can be easily approached. So it travels on the superior aspect of the atrium from the SVC-RA junction towards the superior limbus of the fossa ovalis. It can be targeted anywhere along its course, and there is a dedicated sheath. We call it as a C315 S5 sheath from Medtronic, and the 3830 lead, which is used for conduction system pacing, can be used for doing a Bachman bundle pacing. So you have to move between RAO and LAO to make sure that you are capturing or entering into the Bachman bundle and not into the aortic route. So trials are very important. We need a lot of randomized trial to show that the conduction system pacing is not inferior or in fact superior as compared to a biventricular pacing. This is a slide I borrowed from Vijayaraman sir. I was very happy to see one of our study included in 2023 as a landmark trial for conduction system pacing. And this is in the future. The future is definitely bright. So we can see a lot of randomized trials in Europe, in China, in US being done. The largest one is going to be the left versus left. Close to 2,500 patients are getting enrolled. The study is already on. Probably in another 2 years, we'll get to know about the results of this study. And we believe the conduction system pacing is going to work better than biventricular pacing for patients with heart failure. And probably in the next HRS guideline, we may even get a class 1 status for patients who want to get a conduction system pacing. Thank you.
So there was a kind of Medtronic is working on 4.1 French ICD lead. So how about this 6.3 French ICD lead from Abbott going in? If you try for multiple times, 3-4 times, do you see any chance of substantial injury to septum and some of the perforators, vessels, and injury to the septum?
Yeah, so that dedicated, obviously anything dedicated for doing a procedure will always be better as compared to the already existing leads. So Medtronic is working on a dedicated 3030D lead, omnisecure lead, which is going to get into the left bundle. The studies on septal pacing has done remarkably well. And there are certain pros and cons about the lead. Pros is obviously it's a small size lead. You can go for multiple attempts. But the coil length of the lead is going to be longer than the ICD lead. I believe it is 6.5 centimeter as compared to a 5 centimeter from the Abbott lead. And the sensing polarity is going to be integrated bipolar with the Medtronic as compared to a true bipolar with the Abbott lead. So I think these things matters, and we're waiting for the results of leadless LBBP study trial. We don't know how the ICD lead is going to get accommodated inside the right ventricle and how they are going to solve the issue of atrial oversensing, especially with a long coil and an integrated bipolar sensing vector. But otherwise, dedicated lead is going to work really well. As far as the Abbott leads are concerned, we have done now close to 12 cases, and there was not much of issue in damaging the septum or injuring the coronary artery. So far, we have never damaged or created any VSR or had any coronary artery injury, though we had failures in 2-3 cases because of septal issues. But yeah, like you said, we cannot go for a multiple attempts as this 3830 lead, so we have to be more precise. So as we do a pre-procedural MRI, we tend to measure the septal length from the tricuspid leaflet to the apex. Since I want to deploy that 5 centimeter of coil inside the right ventricle, my primary approach is the left posterior fascicle, not in the trunk. So once I deployed it in the trunk, I had atrial oversensing issue. That case was declared as a failure case. So my approach is to deploy the lead in the posterior fascicle with majority of the coil. So it is another big advantage is it's a true bipolar. So majority of the coil, if it's inside the tricuspid leaflet into the right ventricle, that solves the sensing problem.
Can I have?
Yes, sir.
Regarding the localization of the LVV area, which one would you prefer? Is it CT angio or MRI for the exact localization of your point?
So for on table, we can go by anatomical and electrocardiographic parameters. So CT angio and MRI is for assessing the septal morphology, how we are going to get a procedural success or procedural failure. But for localizing before deploying the lead, so we have to see the septal thickness just before getting into the table, and we have to see the electrocardiographic parameter at the site of implantation. So all we have to do is know about the His bundle location, either with a quadripolar His catheter or with the hump of that TPI catheter, the hub corresponding to the superior aspect of the tricuspid leaflet. Go 1.5 centimeter below that hump, pace map, and see whether you have a W pattern and a discordant QRS in AVL and AVR. Then you can deploy the
Would you like to wish to have the CT or MRI as a pre-procedure protocol each and every case? Would you like
so
to have?
for LV dysfunction patient, for any patient coming for a heart failure device therapy, I believe MRI is the best tool because it is not only going to give us about the scar distribution, but also it gives us an idea about deciding to choose ICD If there is no scar, probably the ICD may not be required. And to prognosticate the patient also, if there is an extensive scar like it happens with sarcoidosis or any form of infiltrative cardiomyopathy, I don't know whether the CRT-D will really work or not, rather it's better to send the patient for a cardiac transplant. So I believe MRI is better in terms of prognosticating the patient and deciding about the device therapy in patients with heart failure.
There's one question, and I'm just wondering how on CT angio it is so authentic that we are looking at the fascicles and the kind of bundle
Yeah.
because when we do a CT for structural heart intervention like TAVR and all, we do see membranous septum, but we don't get any idea about the conduction system. So what do you feel that is very authentic, and how could they do that?
Yeah, so that's what we are working on. It's all like experimental studies. This is the first ever study published on anatomical reconstruction of conduction system based on CT angiography. Just published a couple of weeks back in Heart Rhythm. And we are closely working with that same group in validating the data. So we are collecting large CTs, post-procedural CT, and comparing the electrical parameters as well as the anatomical parameters. For example, if the CT says that it is in the conduction system, then we have to see the electrical parameters, whether it is really captured or not. So the preliminary studies were good. So whatever CTs we have done and we have compared, it was really good. So, but it's like an AI thing, so we need to give more and more input to validate that it is a correct output. So it's still it is in the experimental stage. But once you have demonstrated that it's all based on fixed anatomical landmarks and the activation of the electrical impulse at that particular site in reference to the QRS, it's almost like a 3D mapping. So once you validate this thing, once you validate this thing, and probably it will be easy to integrate into the fluoros system, and you will be able to see the left bundle in front of your eyes just in the fluoro screen. You just have to go there and deploy the lead.
Perfect. So thank you, Shanmuga, for your wonderful presentation. And if there are any other questions to Dr. Shanmuga? If not, then we can move on with Dr. Claire's presentation. Dr. Claire is there? Is online? No.
I have
We
one more
lost him?
talk. I have one more talk. I'll complete this now, sir.
Yes. Arun has to catch a flight, which is he has to board at something on 12:25. So what we do is, we can go ahead with the assess your presentation, and then Arun will present. Yeah.
Disconnected.
Okay. Thank you for the excellent presentation. I just want to ask one question to you. Regarding the integrating the conduction system pacing and the defibrillator together, do you think like if whenever the patient gets a shock, can the LB pacing, the capture loss can be there or not?
Yeah, it's a good question, because every shock is associated with myocardial damage. So that's an important thing which we have analyzed. So the patients are getting regularly followed up in the device cleaning. We do, as a protocol, 6 months fluoroscopic analysis. Though we can get the electrical parameters from the pacing parameters as well as the pace QRS morphology, but we want to see it fluoroscopy as well. So every patient will get a 6 months fluoroscopy just to make sure that the lead is in the same position, and the electrical parameters will be checked at every instant. And fortunately, the first case was done in last January. It's almost now 1 year now, and none of these patients had a change in pacing parameters nor in defibrillation impedance during follow-up. So.
And sir, like any of those patients have got ICD shocks, and after shock, has the parameters changed or not?
No, that's what I'm telling. So these patients, I think one or two patients had received shock and ATP, and all these were successful. There were no unwanted shocks, and there were no episodes of syncope despite giving shocks, and the pacing parameters, both in terms of capture threshold as well as shock impedance, were the same as compared to the baseline parameters.
Thank you, sir. Thank you.
So SS, you can continue with your next presentation.
So I think it's another important thing. Conduction system pacing, are we in the prime time? So these are my disclosures. So clinical implication of conduction system, I'm not going to talk about the implantation technique and capture confirmation. Rather, I will be more clinical. So these are the two important areas where conduction system pacing works. One is bradyarrhythmia, symptomatic patient, another patient with a heart failure and wide QRS. So you have learned over the past 40 years that the RV pacing has its own limitation. There are a certain group of patients, roughly around 10%, can develop pacing-induced cardiomyopathy. The number varies depending upon the definition which you are going to use. And the CSP has been suggested as one good alternative modality for treating as well as preventing pacing-induced cardiomyopathy. So in brief, the conduction system pacing involves deploying the lead in the his bundle or in the proximal left bundle or one of its fascicles. We know the pros and cons of his bundle pacing, though it is considered as the most physiological form of pacing. It's associated with high thresholds, need for redo procedures, and premature battery depletion. In almost 10 to 15% of the time, you may not be able to correct the distal conduction system disease. The left bundle came as a rescue, but the only issue as far as the current scenario is concerned is to differentiate left bundle branch pacing from LV septal pacing. So once the patient develops pacing-induced cardiomyopathy, so there is no way you have to keep the patient on the same right ventricular lead. You have to go for a biventricular pacing, or more commonly in our center, especially when you pick the patient at the early part of the natural history, we tend to remove the right ventricular lead, put a left bundle lead. So we know the limitations of removing the old RV lead. If it is a old lead, we may have to use an extraction tool, and sometimes you may end up in doing a fibroplasty for a stenosed vein. All we do it to change the QRS on the right side to a beautiful appearing QRS on the left side. And needless to say, once you have a resynchronized activation of the ventricle, this being a purely iatrogenic problem, because you're going to rule out all other possible causes, the patient will have normalization of the LV function. So remember, you have to intervene probably at the early part of the natural history once the EF falls below 50%, because as the patient gets older and older with the advancing natural history, there may be fibrosis inside the heart, which will prevent the reversal of the LV function in this patient. So it is always better in the medicine that prevent the complications from occurring rather than treating it. So we have analyzed our own data of RV pacing versus his bundle pacing versus left bundle pacing. Clearly, conduction system pacing has shown a significant improvement in LV ejection fraction as compared to a baseline value. And those patients who had a low LVEF with the AV block, the typical block HF population, had also shown improvement in LV ejection fraction as compared to a fall in LV function in patients who received a right ventricular pacing. So we have now meta-analysis of all the available trials which clearly showed that the incidence of LV dysfunction, heart failure hospitalization, as well as atrial arrhythmias are less in patients who received conduction system pacing as compared to left bundle pacing. Now comes the important question: can pacing-induced cardiomyopathy occur after conduction system pacing? So this is the most important question to answer, because in fact it's a difficult question to answer, because not all QR in lead V1 are considered as left bundle branch pacing. So you need to validate the statement of conduction system capture first before analyzing the incidence of LV dysfunction in patients with conduction system pacing. These 400 odd patients from our center are all those who had a conduction system capture, who had either baseline normal LV function or recovered LV function from the baseline LV dysfunction. So we have found out close to 3.75% of the patient had a new onset LV dysfunction, and fortunately the first three reasons you can see all are reversible. The idiopathic reason which we got was seen in only 0.45%. We have seen only in 2 out of 400 odd patients who had really an unknown cause for occurrence of LV dysfunction despite consistent conduction system capture. So this clearly re-established the fact that conduction system pacing and ensuring the capture of conduction system pacing during follow-up is very, very important. As far as the heart failure is concerned, I don't want to discuss a lot of trials, because already Dr. Arun had described about the trials which I had published so far. This is one of the largest one, which was published by our group in JAC last year, comparing 1,700 patients with the biventricular pacing versus conduction system pacing. This is another very important study from the Chinese group, where they have shown that the LOT CRT is much, much better than BIV CRT for IVCD groups. This, I believe, it's most important study, because we don't have much therapy for IVCD group of patients. But when you combine the left bundle with a CS lead, it's going to produce a superior outcome, both in terms of electrical as well as mechanical performance. Not only it is going to give reduction in heart failure hospitalization, but also it reduces the new onset atrial fibrillation, new onset ventricular fibrillation, and reduce the number of electrical shocks in patients who had already established VT when you compare the two different modalities, BIV pacing versus conduction system pacing. So it's a very important question to answer about the need for AICD. There are a lot of debates occurring about the importance of or the need for adding ICD lead in patients with underlying non-ischemic cardiomyopathy. In patients with ischemic cardiomyopathy, there is no doubt you have to go for an ICD-based strategy, whether you are putting a CS lead or not, or CSP lead or not, but ICD is very, very important when it comes to ischemic cardiomyopathy. But when it comes to non-ischemic cardiomyopathy, especially when the patient has a typical left bundle branch morphology, it's rather a difficult question. So we tend to categorize the patient based on cardiac MRI. I love doing cardiac MRI for patients who are coming for a device therapy for heart failure, and we categorize the patient based on the MRI scar burden. So when it comes to ischemic cardiomyopathy, it's all ICD-based strategy. The patient will get a CS lead depending upon the correction of QRS morphology. I mean the correction here based on the LVAT. So when I get a good LVAT of less than 100 milliseconds with a QR pattern with confirmed left bundle capture, I believe that is sufficient. I still narrow down the QRS with the help of a native AV fusion. On the other hand, if my LVAT is more than 100 milliseconds, or if I am not correcting the QRS morphology, or if the LBBB correction is incomplete because of peripheral disease, I tend to put an additional CS lead. So with this strategy, we have done our Madurai LBBP study where we have shown that when you are risk categorizing the patient based on MRI, the survival rate is really, really good. And those patients who had a high scar burden had poor cardiac events during follow-up. And in those patients with a nearly zero scar burden, they have almost 80% normalization of the LV function at the end of 12 months follow-up. This 80% is a huge number for patients with heart failure because we tend to reduce the heart failure drugs in almost like 25% of the patient. They even stopped the medication, even the beta blockers they were not taking. So it's an important question to answer. Are we in the prime time to use CSP for all patients? So I go by probably in a safer way to enumerate 4 important categories where CSP can be easily advocated. One is those patients who need a committed ventricular pacing, meaning that the pacing burden is going to be more than 40%. As an alternative modality for CRT, if there is a complete QRS correction, where you can just put up a dual chamber left bundle branch pacing, LOT DDD, or LOT ICD if they need an ICD-based strategy. If incomplete QRS correction, probably a LOT CRT-based strategy will be good. Pacing-induced cardiomyopathy, especially when you are doing it an early part of the natural history, you just have to extract the RV lead, add the left bundle lead, use the same dual chamber pacemaker. Another upcoming indication, AVJ ablation. We know the predominant AFib population in our country is rheumatic, and the rheumatic AFibs is not going to go anywhere. It's going to stay inside the left atrium or in the right atrium. So it's very difficult to ablate and get a curative treatment for AFib. Rather, we can knock off the AV junction and put a left bundle lead. And with the left bundle lead, we don't have to go for a backup RV pacing lead itself. So that is going to be a one-stop solution for patients with a chronic rheumatic AFib with poorly controlled ventricular rate. Remember, there is one important historical, I should not say it is a historical one, so rather every electrophysiologist, rather every conduction system pacing implanter should be aware of this is-bundle pacing, because we know some strategy in the lead may not go inside the septum. So this was one case which I've encountered recently, just 3 months back, where the patient was referred for management of chronic AFib with dilated atrium with a bilateral SVC, and we could not just deploy the lead inside the septum for some reason, and I had to go for a rescue is-bundle pacing. Unfortunately, I could get a quick correction of QRS morphology with this beautiful non-selective to selective is-bundle capture, and you can see the good, beautiful is-bundle potential on the pacing lead as well. So you need to know the alternative strategy itself. So just learning left bundle alone is not going to be sufficient for treating patients with heart failure. You need to know about the nuances and experience of is-bundle pacing itself, so that you will be able to give a complete solution for patients with heart failure. Thank you.
Any questions, comment, Arun, Praveen?
Yeah, first of all, we should congratulate Shanmuga for his wonderful work that he's been pursuing on this field. Is actually most of the publications are being coming from his group. So 2 queries.
Okay, Majak.
Two queries. One is since one of the most important predictors of new onset LV dysfunction after conduct system is loss of conduct system capture, are there any work on any device algorithms which look at auto capture? What I'm meaning is all the auto captures are EGM based till now to look for the capture of the myocardium load. Are there any device algorithms which are coming up in the pipeline which looks at specific conduction system capture on the follow-up, which tells you on follow-up, like on the BIV you say that 98% is BIV. On your follow-up of your conduction system devices, they say that, okay, this much is CSP, this much is RV pacing. How are there any algorithms being built on that lines, and what are the thoughts on that?
Yeah, excellent. Actually, this is very important, especially with the future is more of a conduction system pacing based strategy. So, yeah, a lot of algorithms are in pipeline, especially to look for the LVAT rather than the QRS morphology. We know the QRS morphology is going to be different based on the fusion pattern, but I think LVAT is the one which is going to be the important one. So there are algorithms which is focusing on the LVAT to be monitored during follow-up and to tell us whether the patient is getting the really left bundle pacing captured or not. Because it's not like a pacing spike delivered QRS generated is equal to left bundle branch pacing. So not only the loss of R, even you can see the second point which I mentioned was suboptimal AV delay. So especially when you get a dual chamber pacemaker and the left bundle branch block with the patients with the baseline 1:1 conduction, when they had a shortening of PR interval during follow-up, it will result in pseudo fusion. Again, the patient is going to develop a heart failure. So it is very important to monitor the capture of conduction system. There are algorithms which are in the pipeline which Medtronic is working on, and definitely in the future we'll have all the devices which have an integrated algorithm to monitor left bundle branch pacing, and in the future there may be even a left bundle branch pacing pulse generator which can give us all the specific algorithms.
Yeah, because we need to look at the EGM. What all we're saying is all on the ECG, which we might be monitoring once in 6 months, or if they periodically do also, we don't know at one finite point of time whether he has captured, another time he's losing. So we need to have on the EGM all these criteria won't matter. Your QR, your LVAT, nothing comes on your local EGM from the lead. So local EGM from the lead, how can it predict an LVAT?
I don't believe in monitoring the local EGM alone. Rather, I would go by doing a unipolar pacing, not a bipolar, but unipolar pacing at high and low output. Because EGM varies depending upon the filter pattern which you are going to use.
But for the device to see, device cannot see the paced QRS. Device can only see the EGM.
Yeah, no, that's what. So the EGM, whether it is in the mid septum or in the deep septum, unless it has perforated in, so you will not have a change in EGM morphology as compared to the baseline, because it's not like a template which is going to register it for a long time. Even if there is a micro movement, the EGM will not change, but only the QRS morphology will change. But definitely, so in fact, we are a part of trial which with the Medtronic to bring out these things. I cannot disclose much. So where we are going to monitor the QRS morphology during follow-up to confirm that it is all conduction system capture, not myocardial pacing.
One final question. Have you had instances where there is a septal infarct on follow-up and loss of conduction system capture purely because of an ischemic etiology? Because we see that in the CRT arena, but we never see of that being talked in the conduction system arena, although we see septums getting infarcted much more than the lateral walls.
So we had seen the other way, like infarcted patient, inferior wall infarcted patients, his bundle pacing done with a wide QRS, regenerating the pathological Q waves, old inferior wall MI, DCM will be left bundle pacing done, regenerating the old infarcted Q waves, and left bundle pacing patient getting inferior wall MI, but still with a consistent capture. So I have not encountered any patient with a massive anterior wall MI after left bundle branch pacing and loss of follow-up. Fortunately, I believe it should not happen. But yeah, these things has to be kept in mind, because when you have scar in and around that left bundle lead, so definitely it is going to change the QRS morphology and capture threshold and final outcome as well. So that is the importance of following this patient carefully in the device clinic, not with the satellite monitoring, remote monitoring devices, where you will not be able to adjust the settings and assess the patient's clinical status. It's important to see the patient at least once in 6 months or once in a year in the device clinic.
Unipolar left bundle pacing or deep septal pacing, along with the active can giving the far field ECG, and that you can detect that there is LVAT is below 70 or 80 milliseconds. That might be the way to detect that whether left bundle pacing is occurring or not.
Yes, sir, exactly. So exactly. I think LVAT should be given the utmost importance when it comes to left bundle branch pacing.
I think, thanks, Armuga. And a quick one, before Arun starts his presentation, he has to catch a flight. All the studies have shown better synchronization with conduction system pacing as compared to BIV. But I still feel this is a complementary. LOT CRT is the way to go. One of the studies showed that there can be 25% of the patients they may have fascicular disease, and you may not get a classical narrowing and QRS shortening and synchronization with conduct system pacing. Do you feel this 25% data is overinflated? We have seen quite a less number of patients. If we insist that we'll do conduction system, 95 to 98% chance it is correct. But there are studies showing 25% of cases in which conduction system pacing is not possible. So what's your comment?
So
on
the
that?
25% is a huge number. I think that is not, rather you can talk in terms of ischemic cardiomyopathy and non-ischemic cardiomyopathy. I believe non-ischemic cardiomyopathy, the correction rate is going to be as close as 97 or 98%, because it is all, the block will be in the proximal bundle, and the distal fascicular involvement is very, very rare. But when compared to ischemic cardiomyopathy, the success rate varies depending upon the population which you are going to improve, including predominantly interval MI, inferior MI. There the success rate may be quite low, but when it comes to overall mixture of these two things, we believe 80 to 85% should be an appropriate number when you have a mixture of both ischemic as well as non-ischemic cardiomyopathy. There will be probably 15% of the patient when you take the whole substrate of CRT population where you may have a suboptimal correction, but 25% is an overinflated number.
So thank you so much, SS. And now we move on with Arun's presentation.
Respected Chair, colleagues, warm good morning again. So at the outset, I really thank Dilip for giving me a precedence and allowing me to present earlier so that I can catch up with the time of my return flight. So moving on from one advancement to the other advancement, which has really made a paradigm shift in the world of treatment of bradyarrhythmias, that is leadless pacemaker. So this gets emphasized from this picture. This is the picture of the person who got the first pacemaker. This was his cumbersome life. He had to go along with this device all along with a nurse along with him who would connect the electrodes all on. This is the life of the first implanter patient who got the device, but he started off his life in 1967, lived up to many generations of device changed. In fact, he outlived a surgeon who got it implanted, but that's the real life scenario that happens. From there on, we moved on to this conventional system that we implant all of them, what we have been discussing till now, more from here into the conduct system. But the thing that is going to take the world by storm is this. This is the world's smallest pacemaker, the leadless pacemaker, which has actually made a paradigm shift in the way we manage bradyarrhythmias. So why do we need this? Traditional pacing systems are very well reliable, but if you look at them on the follow-up, 3 event data rates are, we have a failure rate of conventional pacing systems to the tune of 15% on the acute and 16% on the long term. And where do they fail? If you look at the Achilles heel of conventional pacing system, it happens at twofold. One is a pocket-related issue, which is about 8%, including infection, hematoma, erosion, at the tune of 8% at the end of 5 years, and lead-related issues, which can be a lead fracture, like here, insulation breach of the lead, venous thrombosis from the subclavian vein thrombosis from a long-dwelling, indwelling lead, or a tricuspid valve issue from a lead, which happens to the tune of 11% at 5 years. So these are the Achilles heel in conventional pacing systems. Moreover, in this world of where people want cosmetic results, nobody wants a chest wall scar, nobody wants a bump, visible bump on his anterior chest wall. If you look at minimally invasive procedures which have fewer post-implant activity restriction, leadless pacemaker is the way to move forward. And that is why traditionally and now we implant Micra VR, which is a single chamber leadless pacemaker for all patients with paroxysmal or permanent high-grade AV block in the presence of atrial fibrillation. Also, we give it as an alternative to atrial or dual chamber pacing therapy when the dual chamber pacing system is considered difficult, high risk, or deemed or not deemed necessary for effective therapy. From Micra AV, we give VDD pacing for patients with adequate sinus rates who would benefit with maintenance of AV synchrony in presence of paroxysmal or permanent AV block. So these are the current indications as per guidelines. And when you do this in the real world scenario, this is from the Medica data, then it leads on to a 66% reduction of complications on the long term with a leadless pacing system compared to the transvenous pacing system. And what is this capsule all about? The capsule that I'm talking about is about 1.75 gram, which is the world's smallest pacemaker, 0.8 cc in the volume, 18 mm is the interelectrode distance, but this this 0.8 cc device has a battery which lasts about 8 to 13 years, with the newer devices even up to 17 years. It's MRI compatible, it has a very novel fixation mechanism, and you can remotely monitor it as well. Our interaction with this therapy started way back in 2017 when an elderly person came to our ED with ventricular fibrillation. She was defibrillated, and we put in, and this was the rhythm. You can see clearly it's AFib with complete heart block with an escape rate of 26. An emergency temporary pacer was put in, and the patient was fully pacing dependent, but the family was just not willing for a surgical or a conventional pacemaker implant. And so we were in a fix because the patient was fully pacing dependent. The moment you reduce even that pacing rate, the patient develops brady and brady dependent VF. So patient was fully pacing dependent, and the family was just not willing for the conventional pacemaker. That's when our story in 2017 started off with leadless pacing therapy. What it just requires is single venous puncture for right femoral vein access. This is the delivery sheath, actually, which is 23 French inner diameter and 27 French outer diameter. In that, you take in this pacing capsule, the delivery system with the pacing capsule on it, loaded outside, and from the right atrium to right ventricle, you have a deflection. But this is just to show how simple this procedure is. From the right atrium to right ventricle, you get in with the deflection system, get in shoot contrast and check whether you are in an optimal position. The target location is typically a mid-septum or apical septum. Preferably always stay on the septum. So this is the delivery system. We check on with the contrast injection to see whether we are opposed to the septum. On the LEO, it will face the septum. So this is again a shot on the RAO views to see that there's a space between the site of implant and the free wall groove. This is called the RAO space sign. Again, once you've got a good anatomical position, what you just have to do is get the tether out, unlock the button, and this is the deflection button which you use to release the device. So with the press of this blue button, the device is actually released, and then the device is actually the delivery system comes back, and this is what happens on the endoscopic view. So this is the trabeculated right ventricle, and you can see the leadless pacemaker capsule staying in there. This has a very novel fixation mechanism compared to what the leads we have, which is called the FESC nitinol tines. These are the tines which have almost each of the tine have 8 times the holding force keeping the device in position. So even if 2 tines are fitted in, it has 15 times the holding force to device to stay in. That is what it ensures excellent stability. That's where you find 0% dislodgement rates, and you can actually wirelessly interrogate this device with a wireless telemetry. You can check whether the electrical parameters are good, and once the electrical parameters are good, with the cut of the tether, this device is released into the heart, and then it stays in there. And the patient goes home the next day. The local site is actually closed off with a figure-of-8 suture, which can be removed after 6 hours. And patient goes home with the smallest pacemaker inside the heart, and there is no activity restriction after that. This is what it sees on the fluoro. And these are scenarios where we typically use this, typically indicated initially for patients who had complications from the transvenous system, like patients who had Twiddler syndrome, patients who had lead dislodgements because of Twiddler, patients who had pocket erosions, patients who came with pulse generator infections, patients who had lead endocarditis. You see this huge amount of vegetation on the lead. You have lead endocarditis. You have to extract this lead and implant a leadless pacing system. You have a person who has a thrombus on the lead and a patent PFO. This is actually a time bomb where he can have a stroke at any time. These are typical indications for leadless pacing system. This is a fracture of the conventional pacing lead. Again, sure shot indication for leadless pacing system. You see the natural history of any person who gets a conventional pacing system. 70-year-old, complete heart block, gets a dual chamber in 2007. Fully dependent, 100% paced, gets a first generator change after 8 years in 2015, goes uneventfully, second generator change in 7 years' time, 2022, now gets infected. This is a natural history of all patients. The more and more time you replace the battery, you are going to get an infected device, and then starts the trauma of these patients. Fully dependent patients, after extraction, what do you do? We do a semi-permanent pacing. We have a pulse generator placed in and a lead placed into the septum. And after that, what is the end point? So we extract this lead, and in the same setting. So traditionally what was done is we put a semi-permanent pacing and then go in for an implant on the other side. It's actually a cumbersome procedure. Now, in this time, we would actually put in a temporary, we would get the infected PG removed, we would extract that, we would take the leads out and implant a leadless pacing system at the same setting. This is the device taken into the septum, anatomical and electrical stability ensured with a tuck test, and then you release the device. So the entire procedure becomes very handy, and the patient goes home. Leadless pacing have almost least incidence of infection because it almost gets encapsulated very soon on. So thoracic outlet syndromes, any venous occlusions, you can do balloon angioplasty, but leadless system is the best way to deal with these patients. CKD patients, where you want to preserve the venous access systems. Young patients, whether you want to preserve the venous access system, leadless pacing might be the way forward. Patients with severe TR, you're going to implant a lead in this scenario, you're going to worsen his TR, you're going to give him refractory right heart failure. Better to go for a leadless pacing system in these kind of patients. So traditional leadless pacing systems we have been implanting in patients who have a complication of transvenous system, patients who have higher risk of infections, patients who have anatomical and vascular issues, patients who require infrequent pacing, extremes of ages, patients who have cosmetic requirements. So and now we have some safe practice systems where we ensure to minimize the complications. All access are ultrasound guided and with a micropuncture, and finally closure is with a figure of 8 suture. You assess the risk scores of the patient to ensure that patients who are at high risk, we don't re-implant again. You cross with care. That's what we say. We start low, go slow, and pause once you cross a tricuspid valve, and always ensure septal deployment with multiple views and contrast injection. So these are the typical scenarios when we have perforations, elderly patients, patients with chronic lung disease, elderly frail females with a low BMI who are on oral steroids. They are at high risk of cardiac perforation and pericardial effusion. In these patients, the dictum is to minimize the number of redeployments in these kind of high patients. So it's always prudent that you wait for 3 to 5 minutes after initial implant, because most of the time the pacing capture threshold settles after that. So the typical site is to target the mid septum, avoid the apex, avoid the groove. And when you're going on the typical deployment system, going on the lateral view becomes handy, because if you see on the lateral here, on the LO it looks septum, but on the lateral it is clearly free wall. So if you go on lateral, you can clearly see this is septal, and although on the LO you can differentiate between these two. Again, the RAO space is important, because when you inject contrast, there should be a confirmed space between the catheter tip and the chamber border in the shallow RAO, which confirms that you are septal. And this again ensures, so this is the RAO space sign, or the same thing on the LAO. If you have a contrast-free space, that ensures that you're not in the groove and you're not having a higher chance of perforation. Again, the position of the micro, you should always verify as you move the catheter in the LAO. You can see here, if you're on the septum, you will become more perpendicular at septum. So this again, you're on the LAO, you look for the direction of deflection. And then the direction of the catheter always should be pointing towards the spine in LAO. In the RAO, it will be away from the spine, and on the AP view, it will be towards the patient's left. So this is you should position always related to the tricuspid valve as well. You should understand with a shot of the contrast where the tricuspid valve is, where the apex is, and where the septal free wall groove is, because contrast will actually show you good wall contact, because it points towards a trabecular structure. And the direction of contrast is also important, because if you have a definite flat flow pattern, so if you see here the contrast injection, there's a definite flat flow pattern which indicates that you are abutted to the septum, and that indicates good contact. But on the other hand, if you are not on if you're on the free wall, you can see really contrast just floating on, and that indicates that you're not on the septum and on the free wall. Again, the shape of this oval, shape of the circle, if it is oval, it indicates septum, and if you're seeing a full circle, it indicates you're on the free wall. Again, these are some safety practices which you should do. But again, always during the procedure, you can get wiser with a transthoracic echo-guided implant, or even an intracardiac echo-guided implant. Or if in difficult anatomy, it's always wiser to do an RV angiogram, as in these cases, we do an RV angiogram, understand the difficult anatomy, and then get it deployed well. Again, what do you do at end of life? These are now with longer longevities, we are looking at one device for a lifetime, with devices which are going to last 16 and 17 years. At the end of life, this is one pacemaker which can be turned off, and an additional micro can be implanted, and an average heart can accommodate at least 3 micro devices, because micro takes up just 1% of the volume of the normal right ventricle, and even if you want, you can retrieve it also and then implant other device. So before I conclude, our experience with device has been over the last 7 years. There are absolute niche indications. We don't go for leadless pacemaker for all the patients. We traditionally always go for leadless pacemaker in patients who have failed conventional pacing systems. So that is why you see we have only implanted about 27 leadless micros. We have done about 4 AVIRs in the last time. So in the last 7 years, 27 micros that we have implanted, 6 were AV devices and 21 were VR devices. 20% of patients had atrial fibrillation. AV block was the indication in 25 of these patients. Almost majority had conventional pacing failures. Procedure time was average 29 minutes. The fluoro time was about 14 minutes. We have absolute stable thresholds on long term. Because the fixation mechanism and the pacing electrode is quite distant, we have stable lead thresholds, almost 0.5 threshold on 0.24 pulse width on the follow-up. We have almost 7-year follow-up of these patients. None of these patients required a replacement. None required a retrieval. No incidence of infections or device failures. We had 1 death after an implant that was related to a severe AR leading on to heart failure, which was nowhere related to the device implant. So to conclude, before I conclude, I would extend my thanks to our team behind, which was in fact the team which was behind the first leadless implant in our state. It was also, we also were the team which got the first Micra VR implant in our state in 2017 and the first Micra AV implant in whole of country in 2021. So that's all from my side. I would be happy to take on any questions.
Thank you, Arun. Wonderful talk. So one or two, comments from my side. So we have done 3, implants in pacemaker, infected pacemaker patients, but we avoid doing temporary in these patients. While the patient has a pacemaker, pulse interest still there, infected site, we don't touch that. The lead is still there, and we do Micra first, and then we explant the, the infected pulse generator at the lead in the same time. So we have done 3 cases, and because of its unique coating and better, the chances of pacemaker infection, leadless pacemaker infection is very, very less, negligible. And there is one also large study shows 127 patients with infection. Around 30% of the cases, Micra was implanted first, followed by lead extraction, the same sitting. The idea behind this is the temporary the lead, the electrode, and the delivery system of the Micra, they interact a lot. And most of the perforations which we used to feel that because the Micra it is happening, it was happening because of the temporary lead interaction. You push the device, temporary lead goes in. And that's what we also have seen in one of the workshop which was happening from Malaysia. So they also don't do temporary, especially avoid temporary. So one of the 2 cases which you have shown us, TPI lead is still there. If you are doing the same sitting, you could have gone for Micra first, followed by lead extraction.
Yeah, your point is well taken, Dilip. We too, although in the case that we showed, we had a temporary placed in, but nowadays what we also do is we implant the Micra first and get the lead extracted. This was the first of the cases which we did. So here we thought it was a slightly longer duration lead, so we thought we were looking at a difficult extraction, and that is why we placed a temporary and got the lead extracted, ensure that we didn't have to use much of mechanical tools, and then got the Micra implanted. But your point is well taken. At all these point of time, it's always better to avoid temporary pacing. It's always temporary pacing induced complications much more than your leadless system hardware is causing complications. So nowadays, we also do the same thing. We just have the conventional pacer giving the backup pacing, implant the Micra, ensure that but we don't implant the Micra close to a conventional pacing lead. We have at least, if the other one is on the apical septum, we go mid-septum, but at least we ensure some anatomical distance and then extract it in the same setting. I fully agree on that, but that's the current practice. I fully agree.
Okay, Arun, another question. You have mentioned the infection. Dilip also mentioned the infection rate, particularly our centers, is really initially high. Now it is not increasing at all. It is just 0.1%. Question of that: when any fever, how will diagnosis? Any fever of unknown origin in cases of pacemaker, you have the index of suspicion of the endocarditis. You see. Yeah, but the ultrasound, you see vegetation along the whole electrode, just like a garland of flower. You see, this is very important. After antibiotic control, you see, then should be surgically removed whole entity, pacemaker, all the electrode to be removed, then replaced by the new one. That is we published in 7 cases of that type of cases, and surgical removal as well. It is published in the South Africa Journal of Cardiology. Thank you. Your experience, how many cases you have got it?
Yeah, so as you said, it's a very valid point that if you have an unexplained PO in a person who has a device, if you're not able to find the cause, it's very likely to be seedling on the device. Now we tend to use more of CT PET for these kind of cases where an uptake on these leads would give us more information that that is the culprit in these scenarios. And as you said, in these scenarios, we go for percutaneous extraction of the leads with all the hardwares that we have, including laser. We try to extract these leads and then try to implant a leadless in these scenarios. But your point is well taken. Infections are actually sometimes difficult to pick up with the thoracic echo. Of course, transesophageal echo is more makes you more wiser. But what we felt recently is CT PET is more handy in picking up a lead endocarditis in an unexplained PO in a person who has a device. And in all these cases, entire system has to come out percutaneously or surgically, and then implant of a new device. In most of these cases, we have implanted a leadless pacemaker.
Sir, what is your take on ICD lead infection retrieval followed by a subcutaneous ICD and micra together.
Yeah, that's a wonderful thought. See, when you this concept of a subcutaneous ICD and a micra, it is being brought about by Boston, which they call as a modular system. So they have their own leadless spacing system with a wireless communication with the subcutaneous ICD, where the leadless spacing system, which is called Empower from Boston, the modular system is mainly uses this communication for even delivering ATP through the leadless pacemaker and deliver the shock through the subcutaneous ICD. So this is a modular system being developed by Boston. At the moment, this is still in the study phase. There have been some publications on the modular system, including a publication in New England Journal on this feasibility and the way in which the system works. But possibly this would be a way for future where we would have a subcutaneous ICD and the leadless pacer inside, which gives you the pacing capability for Brady as well as an ATP through the leadless pacing. But if you look at the newer extravascular ICDs, they also have the pacing capabilities with a lead which is in the substernal location.
Thank you, Arun, for a wonderful talk and coming all along from Kerala to here. And sir, you have something to say, sir?
I have one question for you. A patient came with complete heart block with recurrent synco, and the patient had the ejection fraction between 45 to 49%. Now, what is your comment on that while using the leadless pacemaker about the future program?
So anytime you have any form of LV dysfunction, we don't advocate leadless pacing at all. If you have AV block with any form of LV dysfunction, any drop in ejection fraction, the way to move forward is conduct system pacing. Because conduct system pacing is the only entity which is known to prevent further deterioration of LV function or sometimes even improvement of LV function. So unless you have this hybrid systems that are being developed, which is a leadless conduct system pacing, which is still in the pipeline, with Avir system is trying to develop that system. Unless that comes in, at this point of time, if you have LV dysfunction, we don't implant a leadless pacing at all.
Sir, in your series, particularly CID infection, coagulase staph negative, and which is the commonest you are getting?
Unfortunately, because all of them get treated with multiple antibiotics in the peripheral centers, we are unfortunately not able to identify the microbe, but whatever we got were mostly staph aureus, which were actually MRSA staph. So, sir, from the Medtronic group, we still only have VDD pacing, but with Abbott, we definitely have the dual chamber Avir system, which have a device in the atrium, separate device, with an eye-to-eye communication with the ventricle. With the Medtronic system, we still are in the only with the VDD pacing. I am not very aware.
Thank you, Arun. You have to catch the flight, and I think you should move now. Yeah.
Now,
1 o'clock is.
Now, Dr. Dilip, please.
Yes, sir. So, Clear sir is unable to share his slides, I heard. So, I will be quickly going through. We are running late, so I will be showing some of the cases of CSP in difficult anatomy. Can we have my Devendra update? Sir is there. Dr. Clear sir, can you hear me?
Can you see my slides?
No, sir. Yeah, we can see you, sir. We can see your slides, sir. Yes, sir.
Okay, first of all, sorry, I couldn't come. Dilip is wonderful. Actually, I listened to the talks, very nice. And well, the thing is that there is a clear-cut rising trend in publication on the CSP, and this seems to be the way to go as far as Brady indication as well as CRT is concerned, to my mind. And these are the old, tools. We know that Medtronic guider. It was easy to select the largest body of data available in this lead, and lacks stiffness, and it's a single curve. And when the lead, I think we have discussed this already. My maximum experience of the Medtronic 3830 lead, and I think we don't have to go into the details of the thing. Then Abbott has the CPS locator and tendril lead with different curves. It's minimum 9 French introduced is needed for this device. The lead is tendril, we know that, and the steroid is less than 1 milligram dexamethasone. lead body diameter is 1.96 French. The Medtronic one is the 4.1 French. These are the Biotronic guides, 65, 55, 40, and these are usable lengths are 32, 42, and 39. Now, in this Biotronic, there is sturdier than the other contemporaries, comes in different curves and lengths. The longer length and the larger curves sheets may fare better in large hearts. There is no option of deflectability in this, can't be used for mapping the intracardiac signals. Use of different curves in specific patient groups not defined as far as this is concerned. Well, the lead is the Solica S lead, and I think there is not much in this. Is also still a driven lead. It's a 5 French, 6 French lead. Its stillet driven features offers greater stability, able to record and map intracardiac signals. Comes with a slit introducer tool which can be used, as the inner conductor single structure. No standardized lead fixation method yet. Lead is not made for deeper penetration as far as this is concerned. Boston is SSPC. The only additional thing in Boston is that we have a SSPC from the right side. Other contemporaries, they don't have any specific guide when we are doing the conduction system pacing from the right side. The lead is same lead as we use for pacing. I think there is nothing much to talk about this. Now, this is kind of landscape of CSP delivery tool, catheters, of all these 4 companies. Working length 42, very close, 43, 43, 40, 32, 39 in Biotronic. Inner diameters vary. Abbott is 7, Medtronic is 5.7, 5.4, and Biotronic is 7.3. Only deflectable is available so far in Medtronic, but I'm sure the other companies will come up very soon as far as the deflectable things are concerned. Lead, the main difference is Medtronic, as you said, is the it's not a extendable stiller driven, it's a non-stiller driven lead, a solid lead, and it's a relatively thin lead. But not all stiller driven leads are same. There are some differences in all the 3 companies, and because of shortage of time, I think I will not go this. Now the thing is, when we talk about the left bundle branch optimized CRT, this is the concept of lot CRT. I am sure this audience understands this. We do the conduction system pacing. There is the additional left lead. The standard DF lead, we have to cap the sense and pace port because we are using that DRB lead. This is YB. The standard YB is the 3 ports, the LV lead, as well as the same lead is used for pacing as well as defibrillation. When we come to dual chamber ICD, DF1 ICD, these are the ports RA, RV, this is conduction system pacing, and this is DF, RF, DF1 port has to be used in this. And of course, we cap the pace sense button. Now we need variable device options. In so far we are using many times off study to show just the priority of various people, like luminous lead, the luminous more than the stillet driven, or stillet driven lead more than the luminous. So you have the combination of factor. There are many people who use the stillet less lead, and these are the percentages. But as far as the left bundle branch area is concerned. Now, what about the near and long-term directions? New pacing leads and delivery system will come. Conduction system pacing, but defibrillation leads safety and efficacy of the conventional special design high voltage leads. Device header standardizations, DF1, DF4, what has to be done in lot or hot CRT. Device algorithms for capture confirmation. I think there was also a discussion in the previous talks that it is not that you have done the left bundle pacing, but capture confirmation algorithms are being looked into. And that's very important because one of the reasons for clinical deterioration may be that you lose the left conduction system pacing in some of these patients. EGM-based device optimization will come, standardized intraoperative testing and associated PSA tools, PSA facilities. And then there is a lot of thinking on the leadless CSP. And I think if the best system, I think in the future, to my mind, will be if we have a leadless system with conduction system pacing, either for both Brady indications as well as for CRT indications. So you have CSP pacing capability, number one. Number two, you have a extravascular ICD, plus that may decrease the complication to a very, very significant level and still give you physiological pacing in these patients. So these are the new options will come up, a DF1 device, DF1 with ISLV and, various kind of connections which we have to understand in a new conduction system pacing. Again, this is again to show the same thing, sinus rhythm, atrial fibrillation, like sinus rhythm, RV, CSP, in double dual system pacing. RA we can use in CSP and RB we can use in the backup pulse in these patients. Well, leader trial is a defibrillation with CSP. I think you guys already discussed that if we can have a defibrillation and left bundle pacing in the same lead, and there are two leads have been used so far. One is the Medtronic lead, which is the practically same lead with the defibrillation coil. Another is the Abbott device, and these are the phase 1 results. They showed 97.1% success rate. The complication-free rate in these defibrillation leads. Study lead electrical performance has been demonstrated in these defibrillation leads with the left bundle pacing, and good electrograms have been achieved in the majority of these patients. There is not much data. The Durata lead follow-up is there 9 French lead, Helix locking tool connected to the S1 as standard things. And this is to show the same thing that you are trying to use Durata lead for the left bundle pacing as well as for a defibrillation coil. This is European center, 11 patients, 12 were out of 12, 11 were successful. And if you see the baseline QRS, the reduction was significant. It was day 1 and up to the last follow-up has been shown that, well, it is maybe it's a long-term reliable situation. Now we need CSP specific algorithm, as we have already discussed. In a long term, those things will come. Sensing issue with current generation defibrillation devices needs to be looked into, and there have been interaction with the left bundle branch area pacing and the defibrillation, which is recent data from the January 2024. So there are implant support tools and
Okay, thank you, sir, for your nice presentation and overview of the future. And now, Dr. Dilip Kumar for a few cases.
Yeah, so we lost Dr. Claire, and we'll be quickly moving on to the next session after this. It will be a little, I will be try to be brief. So these are my disclosures. And when we do conduction system pacing, we try to look at and hit these areas of, main trunk, anterofascical, septal fascicle, the posterior fascicle, and we try to be in conduction system. And that's what, whichever way we do, be it 3830 lead, be it stylet driven, we get this kind of ECGs, and we are confirmed that we have captured the bundle. So just quickly, those who are new to the system, With 3830 lead, you have to screw like this. You have to really go in a little fast, and it makes way into the septum. But when we are going for a stylet-driven lead, you have to be really gentle, and this is how you proceed. Turn-wise, you have to go in. You can't be so quick, otherwise because these are sturdy catheters, and the lead is higher French, and you can go across the septum very quickly. So 7-8 turns, you just see how the notch is moving, and then the electricals, the LVAT, and the pseudo RV pattern, and then gradually you go. So I think this all has been dealt with. This is a left bundle potential which we look at, and I will be going through some of the, and this part I wanted to show. Many of the operators, they have shown their problem with slitting of stylet-driven lead. This slitter has a long, metallic part, and you don't have, and there is a problem with the length of the lead, and the lead is totally lost there. So you have to start slitting when your metallic segment comes in contact with the blue part of the catheter, and then you start slitting. There will be no problem of length, which is residual length of lead, and you can easily do that. So I wanted to show this tip to everyone, those who are new to conduction system pacing. And this is the classical normal slitter for Medtronic. So this case I did, I think day for yesterday, it was so difficult. So the patient has huge RARV involvement, enlargement, and there the problem comes with you are unable to reach to the septum. You need to reach to the septum with your guide catheters, be it 315, be it CPS locator, be it Boston's system. And many times, once I was proctoring in BHU, and I had a extrathoracic puncture, and the sheath was not reaching the septum. So the first trick is you have to puncture little medially in these situations. If you feel that RARV is large, go little medially. You have extra length of sheath will in your hand. Second, you see, once we are going in, the sheath is still floating. Whichever way we go, the sheath is floating. And you see, the lead is going, just advancing. We feel that in LO and RAO, we are in position, abutting the septum, but the lead is just advancing. It means we are in free wall, and there is no contact of sheath with the septum. So what are the tricks here? One is you go medially, puncture. Second is, you have the system which is there with 3830, you can put the dilator inside, you can make a secondary bend, you can additional bend, and it has got 3 minutes of memory, and then you can try your luck there. Otherwise, you can take a CS sheath, maybe MB2 sheath, maybe a sheath from Abbott or a multipurpose sheath, and through this sheath you take the 315 or a CPS locator. So this is how you can do that. So finally, you can appreciate here, we did lot CRT in this patient, difficult anatomy. We had to do some permutation combination. I did not have to use the entire tricks here. And this was the baseline ECG, and this is how we got the left bundle pacing, followed by further fusion with CS lead. So this is how we do in difficult anatomies. This was one patient who came with 60-year-old lady with LBB with intermittent complete heart block with ejection fraction of 45%. And if you do a normal pacing, the ejection fraction can further drop. And we thought we would do you see the ECG baseline LBB with 2:1 block, rather rather complete heart block. And we had to, and this patient had a severe scoliosis of spine. So no fluoroscopic markers were useful for us. So it was all electrically driven, position of the lead, and we got this ECG. You see, that's what I was asking, or discussing in the morning. Many times you get the best of the QRS, but you may not get a good R wave or a kind of classical pseudo RBB, but it still is a conduction system pacing. And these are 5 to 10% of my cases. 80-90% of cases you get a good pseudo RBB, but in some of the patients you still get engagements LVA2 of 75-80 and in left bundle potential, but you can't, in this case this is LBB, so we did not get left bundle potential, but other criteria of CSP is there, but still you don't get a good R wave, but still essentially this is a conduction pacing. And this was the patient which after the device implantation, and this week published. So this was a series of lot CRT in non-LV morphology, and finally I will last with end with this case. This patient came with a biphasical block with intermittent complete heart block. He had a childhood history of pulmonary tuberculosis. This was the ECG, and this was the CT scan the patient came with. The heart was in right side, and we had committed for a conduction system pacing as the patient's ejection fraction was lesser. And also we didn't want any pacing-induced cardiomyopathy in this patient. He had only one lung working, one hyperinflated lung working, and then the cardiac dysfunction, the patient will have a further problem. So you can see how bad the the course of the SVC was. It was totally shifted to right, and these were the venograms. And this was a difficult puncture indeed. From left side, you see, we had to go. And puncture was made more medially, as what I explained earlier. Whenever you want to reach there, there is a lesser length, in the entire length of the sheath can be lost once you have a dextroposed heart in the right side. And we had fixed the electrodes looking at the echo. So we knew that everything is wrong. It is not dextrocardia, this dextroverted heart, dextroposed heart, where this shift of the heart has happened because of fibrosis of the right-sided lung. And the entire thing has been pulled up. You are not aware about anything in kind of a system. In dextrocardia, still there is a system. Dextroposed heart with fibrotic lung, you don't have a system. Which where heart has moved and gone, you never know. So we position the electrodes depending on our echo finding, where is the LV, where is the lateral border, and then we look at the LVAD. So lead positions were done with the help of echo in regards to placement of lateral leads and V1, and then we put the RA lead in the RB first, and then we took 3830 on 315. We had to do a little of work, and finally after 3-4 attempts we got a position. And this was the final kind of pictures, and these were the final parameters. So you can see here the X-ray of the patient next day. And this was the LVAT of 67, V1, V6 difference was, V1 was, RV peak time was 106, QRS was 116, we are happy with that, and this was the final ECG of the patient. We presented this in TCT this year as oral presentation. So essentially we can do pacing, conduction system pacing in almost all anatomies, be it scoliosis spine, be it dextroposed heart, be it dilated RA, RV, provided we plan things accordingly, we puncture accordingly, we make the bends accordingly and choose the right hardwares. Thank you so much for the patient hearing.
Thank you, Dilip, for showing very nice and difficult case. So,
with this, we move on with the next session, which is dedicated on leadless pacemakers. And this is another area which we are really excited about. And I invite the chairperson and moderators, Dr. Suni Banerjee, Dr. Munna Das, Dr. P.S. Banerjee, and Dr. B. N. Jha.
So, good afternoon, everybody. We all know that device management has gone a long way in the management of chronic symptomatic HFrEF. And in spite of, this is of course a supplementary to the foundational therapy with the 4-pillar drugs, but still there are approved some of the devices like ICD, CRTD or CRTP. And we have also the LVAD, which is a complementary before the cardiac transplantation or as a destination therapy. And we have also the percutaneous mitral valve clipping that also improves the outcome of HFrEF patient having secondary MR. So with this, I will now call upon the first speaker.
So we'd like to hear something valuable from Dr. R.D. Yadev regarding difficult CRT cases and how to bail out.
No. We are going for Dr. Hajra's presentation.
Okay.
Yeah.
Okay.
We go with.
Yeah. So it's a
Live in box,
live
Avir.
in box ever by Dr. Hajra.
Right. Thank you, Dilip, for organizing a beautiful device update. When the lab is wireless, emotion is wireless, why pacing should be wired? So pacing is also getting wireless. That means whether it is ventricular pacing, atrial pacing, connected. ICDs, right. So this is the timeline of leadless pacemaker. And the Abbott started this journey, and Abbott is winning now because it has got a double chamber wireless pacemaker. It is very small and cute. The atrial system and the ventricular system, two are different systems. In the ventricular system, you have this screen thing, but it does not transmit electricity. Whereas in atria, you have double helix, and it has got a larger footprint. That means it is not a screw like conventional lead. And there are different delivery system for Micra and your Abbott Avia. The same delivery system can be used for atrial pacing, atrial placement, and ventricular placement. And you have a retrieval sheath. That means this is the pacemaker which can be mapped immediately. By accident, if you have implanted the pacemaker and the threshold is very high, it's not stable or embolized, which is very rare nowadays with experience, it can be retrieved, it can be reimplanted, unlike your Micra. So as I was mentioning, the atrial one has got a double helix. One is for the pacing, one is for the anchor. Some people do it under fluoroscopy. So if you're really contemplating to do atrial leadless pacemaker, start doing right atrial appendage injections in your day-to-day practice, so that you get to know where to implant and how to implant these devices if you really need it. So for the first time, you're learning that impedance is very important. There will be current of injury. And most of the time, your threshold is 4, 3. We don't bother about these thresholds, unlike conventional pacemakers. You have current of injury, and the impedance goes up above 300. As you continue to screw, it can go up to 1200. And surprisingly, sometimes this threshold comes down to 0.3, 0.5 after waiting for 15 minutes. So this is a complete understanding how this pacing system works in human heart. So don't get surprised if your atrial threshold is 5 millivolt during implant. You can leave it there and come back after half an hour, your atrial threshold will be less than 1. So this peculiar phenomena we are observing with this kind of pacing system. Now we are moving to leadless conduction system pacing. And this conduction system pacing, there are leads, and leads has got obvious issues like infections. So original pacemaker had a screw, and now this screw can be attached instead of the helix on your AVR ventricular pacemaker. Instead of the helix and the footprint, and there is a cathode there, and this has been replaced. So for patent issues, I cannot show the photographs, but this is done for the first time in human being, as I was mentioning we are mentioning in the morning in Prague. And this is the first conduction system, leadless pacing done from the right side. We have other system from Boston. We have learned that these are possible. So in this picture, you have green zone, you have a red zone in the appendage, and this is the system. It is implanted in the RV apex. If the RV apex, you cannot enter the RV apex, sometimes you have to use a snare to bend it towards the ventricle. So this is one of the cases where you are not able to enter, and then you take a snare and push it towards the ventricle system. Most of the time, it can be implanted with single attempt. So on the table, if you are seeing that the contract of the device with the RV lower septum showing very high threshold, just a deflection will shift from a less sensitive zone, a more sensitive zone. So unlike Micra, which can be implanted at the apex, this system is little above the Micra implantation site. That means it usually do not go anterior because it has got a screws, it can cause perforation and tamponade. So you see on LAO or dead lateral. If you on dead lateral, if it is looking anterior, avoid that. And you go, so that footprint I was talking about, that the brown footprint is the active lead, I would say. So instead of that, in leadless pacing, conduction system pacing, LBV pacing, you have a screw now, the helix of the classical system. And now we are saying one pacemaker, one life, one pacemaker. That means if you are using this kind of pacemaker, it can last, if you see that 0%, the span is 27 years. 27 years, that means it's not zero, actually less than 50% pacing, it can last for 27 years. And how do you do that? If you have a Bluetooth technology in any leadless system, that kills almost 75% of the energy. So in AVR, we do the blood pull conduction system by special, this programming system, unlike any other pacemaker. So once we get that signal, once it touches the blood, we get some signal, but not by Bluetooth, like your Medtronic or other, or Boston pacemaker. So we have avoided Bluetooth technology. That's how the battery longevity has increased. Now we have atrial pacemaker and ventricular pacemaker. Atria can talk to ventricle, ventricle can talk to atria. Both can talk to each other. Sometimes they talk too much. It can create noise, but that can be controlled by artificial intelligence. Also, they are also very sensitive to temperature. So temperature, the emotion, your fever, your hypothermia, it will act differently. So these pacemakers can be switched off. So now I'll go to one live case, if I can show you. Just give me a minute. Devu. Dastina Karre.
The live case with them.
Why this is not coming?
It's in the laptop.
So this pacemaker, like right femoral vein or left femoral vein, not from jugular, Micra can be implanted from the jugular as well as femoral vein.
It's in your.
We do RV injection and the large sheath. Large sheath, either by pigtail or multi-purpose catheter, and then we take this sheath, and this sheath has to be irrigated by heparinized solution, and once we reach the right atrium, then it is unsheathed. Vegetation. Now it is coming. Now it's coming. So the video is quite a lengthy one, but I'll try to make it very short. You know, the large bore devices, whether TMVR or Micra or AVR, you have to do a puncture either on ultrasound guidance. Some people, they close it with ProGlide, but most of the time you puncture with the conventional way, put the sheath, take the sheath out, immediately keeping the wear. If you do not see any spot, that is the best assurance that you have not gone through any arteries. So once you do that, they have a different kind of programming. So this man is attached, and there should not be too much of electrical or electromagnetic interference, because we are having a different kind of programming. So now this is done. This is basically local anesthesia. Some heparin is given, and I think this is not edited. There is a problem there. So anyway, like your Micra or any other large bore device, the sheath is introduced. Sheath is introduced into the RA. Now we do some injection. So this injection is very important for the initial learning. Now, if you really want to do good conduction system pacing or LBV pacing or AVR, I would suggest that everybody should do one RV angiogram. That makes your CSP, LBV pacing, and this device placement, a large bore device, very easy and safe. Because in many patients, if you have fibrous heart, you distorted heart, post-CVG, existing lead, you never know where the septum is. Quite impossible. If you're doing CSP in a patient who has gone like a fibrosis on the one of the left lung, then it is a hell of a job to reach to the septum. But once you know that your anatomy, your septum, it is just 2 minutes, 3 minutes job to do a right CSP. So we do that, and once we do that, so you can imagine there are pigtail, and Dilip was with me. We did the first AVR in Eastern India. That was the first patient who had a temporary pacemaker for 6 sinus syndrome, and the multipurpose catheter is flipping back to a zone. That is the safest zone for this AVR. And we do not actually take the temporary pacemaker lead tip positions, because it can cause perforation, because it has got a large screwing the helix. So once we do that, then so this is the large sheath. Unlike your Micra, they have a metal introducer. So there is ABCD. A for your sheath, B and C. C is basically for contrast injection. So there are deflections, like this catheter is very soft catheter, unlike your Micra is much softer. Micra is passive fixation, this one is active fixation. So on the top you have very soft sheath. It is never going to do perforation because of the sheath. So that metal will help you to introduce. They made the sheath very soft, so it's very difficult to go through the valve of the sheath. So that's why you need this. So once you push that, there is a click, and once the click is done, then you infuse. Then there's just clockwise turn, and you are ready for. So pressure, look, this is exactly like your Micra. You have a ring there, and once you reach there, you push the AVR into that system, And now look, this device is very, very gently pushed up. Micra is fall from above. It is pushed from below. And once you unseat this, it comes into contact with the blood. Takes around 3 to 5 minutes to expose this device to blood, and it is activated. So until unless you activate this device, nothing can be done. So there is a protection sheath. It's like the 2 layers, like a balloon. There is an inside balloon. And once you pull the protective sheath, this AVR is exposed and very easy to enter, very easy to enter. And if you have failed to enter, then perhaps you can go up and fall like Micra. So once you put this locking device, unlocking device, the sheath or this delivery device is little bit complicated than Micra. Micra is much easier to deliver. And once you do that, so once you deflect.
Sir, can you hurry up, sir? A little
Yeah,
bit?
it's done. Just one minute. So once it is there, and so there is a chevron. There is a chevron. So you have to rotate. Then the rest of the things are done by the programmer. And when it is, there will be some current of injury. It's a good sign that you have made a contact. And once you made a contact, once they give you a grid signal, you just release it there. It stays there and remove the sheath. And I think that's it. Thank you.
Thank you, sir. Actually, double chamber leadless pacemaker is now a reality, and many centers in USA they are practicing. In India also, sir, in your own experience, how many cases you have done, sir?
I have done 5 cases so far.
So
and Dr. Balbir Singh, I think that's the maximum number. Is there on the
two
first?
things in our mind, particularly for a clinician. One is the stability of the atrial leads, and the second part is the synchrony between the atria and ventricle in the upper leadless subchamber. 2 points. How much is the in data in favor for stability and asynchrony maintenance between the atria and ventricle?
Yeah, so you can interact A to V, V to A, bidirectional communications. And if you do that, then the longevity of the pacemaker comes down because of these communications. You can switch off the atria, you can implant atria, you can switch off the atria, you can switch off the ventricle, you can work it as AI, you can program it to VVI or a DDD. And once you have that, there will be disparity between the longevity of one pacemaker. The ventricular pacemaker may last 25 years, atrial pacemaker may last 27 years, ventricular pacemaker may last 10, 12 years. So if you have this system, the longevity comes down, and the communication, if you really want to communicate with these devices, the longevity goes down, but you have like if you really have LV dysfunction, better to have that synchrony.
And there should not be previous any leads. It should be fresh case always as a
In
6 sinus or AVR.
atrial, I don't have any experience of atrial AVR. If you have a device in the atrial appendage, better to remove and extract, then you go for this.
Thank you, Prakash sir. You have been always, you take the lead in any new thing which is coming up in Eastern India. And for the leadless pacemakers especially, you have done wonderful job teaching so many people to do how to do leadless pacemakers. So I think the IBHRE system has also got benefited with the experience of Micra ones, because with Micra there are some perforations and all, but we all discussed about the necessity of a TPI pacemaker exactly is there or not, how to avoid that interaction. Also the ROS space sign which is there, which they look very diligently. So they give the RV, angiogram to look for the ROS space sign. If there is a space, only then they screw it. And they look for only one time, screwing in. So they don't want, change in position. So we'll be more wiser with Dr. Praveen's and Dr. Balbir Singh's talk. So let me invite Dr. Praveen for his next presentation.
Mine is actually a recap of the talk. Sir had already shown a live in box, which had almost all of the steps. But the thing is, troubleshooting is of leadless pacemakers can be either during implant. There are many implant related problems. For a beginner, these might be important because there are many, although it's probably a 10 minutes procedure for a micro or a VR implant, there are many potentially hidden problems and post-implant problems can happen. First is a venous site injury. I'm going by the procedure order. So if we, about 0.6 to 1.7% venous site access injury incidence is reported in the CED data and micropar data. So that can be well avoided by a dedicated ultrasound guided puncture. These days, most of us do ultrasound guided puncture. This will avoid through and through injury through the artery, or sometimes the vein may be collapsed, especially in elderly. So that also prevents through and through, and also the vein may be collapsed, especially in elderly due to dehydration, etc. So next is sometimes always you have to guide you can take a contrast injection through the delivery sheath once you put halfway through, so that you can know whether there is any venous issues beforehand itself, as and when you put the delivery sheath. Or what we can do is you initially insert a thermo wire with a JR placed along with a JR, and with the catheter placed in SVC, exchange with to an amplatch stiff wire. That also prevents venous injury, so that on that you can track the large delivery sheath. So IVC tear is very rare. That can be life-threatening, but it's not been reported with any of the micro implants. So next is anomalous anatomy. Although azygous continuations, there are reported cases of implantation of leadless pacemaker with azygous continuations. There will be sufficient length, mostly because the catheter is sufficiently long outside. So, but what is recommended is a jugular vein approach in such cases. Another difficulty is it is very difficult in micro implant in small right atrium. Some elderly with may have very small right atrium. So either with AVR or with micra, the implant is going to be difficult because entry into the atrium and the curvature is going to be difficult. While in micra it is a pull down, as was told, and while in AVR it is a push up. So both might be difficult in a small right atrium with a difficult tricuspid valve. Sometimes you may have to make a U-turn with a catheter. At that point, the problems are either the patient may go into vasovagal if you are not gentle with it, or sometimes you can create an AV block or an RBVB may occur if there is injury to AV node or bundle. So our right ventricular, as sir told, although it is not a must to do a RV angiogram, but it's always better to do in the initial part of your experience to do an angiogram to understand the anatomy, because the diagnostics are always good. Always in micra, try to get to the, even in micra, you tend to go to the slightly upper space so that you get an upper septal implant, which will give you a better QRS than a lower septal implant. So even in micra, you tend to go slightly higher, but always keep in watch the RV anterior sign in RIO view. So you need to have some space there, so that will avoid perforations. What it does is avoiding very anterior apposition of the micra, so of the pacemaker, so that there is no pericardial effusion. So generally basal implant will give a better ECG, but the problem with basal implant, very basal implant will be TR. Because even though that is less with micra because of the lower length of the device and more with AVR. With AVR you need to go to this area, almost 6, this area will be the AVR implant, while micra will be somewhere 5. That will be the area of implant of micra. So another problem is, suppose the LV is very calcified, then you are going to get or scarred LV. You are going to get very high thresholds with either of the implants, either screwing or active or passive. In such cases, sometimes you may have to actively resort to other places like anterior area, anterior wall, etc. This happens especially with restrictive cardiomyopathy like pictures. So you may have very calcified LV, and it will be very difficult to sometimes screw in or place it the tines. So the threshold might be very high. This is something which is possible. Especially after implant, if the impedance is acceptable, which is what they say is impedance less than 500 is not very good. There is a higher risk of higher thresholds post implant. So if the impedance is acceptable more than 500, then if it's a tine lead, then it is probably better to wait for some time, as sir had told, wait for 5-10 minutes, it will, especially if there is a good current of injury. If there is a good current of injury, just wait 5-10 minutes. The current of injury subsides, and when that subsides, you can recheck the threshold and impedance. You will find that most of the time threshold has come down. And if the high threshold is persisting, one thing that you have to suspect immediately is a thrombus on the device. So just recapture and remove the whole system, check for thrombus on the tip of the device, and then reattempt. You will often find better thresholds. Thrombus prevention is basically with adequate heparinase. That's the most important step. Even though sometimes it's not required if it's a 10-minute procedure, but if it's a longer procedure, difficult anatomy, sometimes you may have to, you'll have thrombus in the tether, so which will be a problem for both of the devices. So IV heparin 2000 can be given just after serial dilatation of the vein, and 1000 units can be added to the saline infusion, and 2 saline infusions, 1 to delivery sheath, and the delivery catheter can be maintained. And pericardial effusion, present incidence with experience is now 0.8%, is very low. Sometimes you have to be careful. There is one importance of taking an angiogram through the delivery sheath is, sometimes this was a case reported of a coronary sinus implant of a micra. So this is an inadvertent implant, and patient had a pericardial effusion and which had to be surgically removed. So these are very rare complications, but it can happen. Sometimes it may require surgery. And generally, pericardial effusion incidence risk factors are more than 85 years, BMI of less than very thin patient, female gender, heart failure, prior MI, and patients who have no surgery before. Post-CABG patients are relatively better. They had less perforations. Patients with COPD and hemodialysis, renal failure patients are at a higher risk. And microembolization risk are quite, they are low, 0.06%, this is micro data. It can happen either acute or late, and it can happen, this one micra in LPA, so micra in RPA, both can be taken out with triple snares. There are multiple off-label off-label devices, and even a dedicated Senju device also is there, snare now with Avier. And device infection is quite rare. It's reported 0.013% is quite low, and only 2 cases of device infection has been reported in the large CED data. And TR is something which is of concern because it's a late complication. We can't do anything at the time of implant. It can occur later, but at the time of implant, one echo probe, putting an echo probe just post implant is very good to see whether TR is there or not just before releasing the device. So TR will be less with micra because of the lower length of the device, especially if we put a mid-septal implant. But if we put a basal implant, there is going to be a high incidence of TR. And with post-implant problems, device programming. Basically, leadless, the good thing is that it just mimics the physiology. So what we are detecting is basically A1 is just like S1, A2 is S2 closure of A and P valves, and A3 is the area that we are interested, because what we want to pick is just A4, whether there is any atrium mechanical systole. This is atrial mechanical systole which is detected. So we want to program, what is programmable is this window, whether there is any activity during this time. This is the time when blood comes from atrium to ventricle, and that is what we want to detect. That has to be just before the A4. So this is the area where we are interested. So what is programmable is, the device has multiple vectors because it can be positioned in any device, any position, because the body orientation is so much variable. So we can't have a particular vector, but there are multiple vectors provided inside the device. So what we can program is the A3 window and the A3 threshold. A3 threshold and the A3 window is what we can program. So these 3 parameters is what we can program: A3 window, A3 sensitivity, and A4 sensitivity. All 3 can be programmed. It is very variable, so it is individualized for each patient. Post procedure, you have to take patient outside and check the best vector possible. Only one vector, 1 or 2 vectors will be best, so you can pick up the best vector available. So okay, thank you.
One quick question to you. What is the time frame of this pericardial effusion mostly you see?
It can happen, suppose it can happen very acute, because during our, suppose a very anterior implant, you can have immediately. And suppose this coronary sinus published paper, it was a very late one, like second or third day they had understood that there is pericardial effusion.
And was it self-limiting or it went into tamponade?
Yeah, that patient went into tamponade.
Okay. And second is about your migration of the device into the PA. How late it can migrate?
One thing is, I think there was one implant, it had embolized, because one problem is the TPA, temporary pacing lead. After pulling out the tether, everything, the last pull out of temporary is, you have to be very careful. It can embolize at that point of time immediately. Next moment it may be in PA. But there has been no report. I don't know whether HSRS or knows. I don't know whether any late embolization is extremely rare, not heard of.
Over the of the micra, particularly suppose at 45 of age, every 7, 8 years, 10 years. So how many 2, 3 of the micra?
Up to 3 is what is maximum. Recommended.
Yeah.
But I think probably now with that will not be a question in the future, because 16, 17 years device is coming. So I think it will be a thing from 45 years, probably we can start thinking of micras.
Yeah. And regarding fibrillation, defibrillate of the device if necessary. Yeah,
defibrillation as such, there is no nothing, there is no data and all which has come. Probably it should not embolize, but at what time we can defibrillate is also not yet known. We can only speculate, maybe not immediately. If the patient is in AF, you won't immediately cardiovert. Maybe you will wait for 6 weeks or something.
Yeah.
Thank you, Dr. Sri Kumar.
One quick comment. So when we do a micra AV, so there are some of the important points are there. So the micra AV, when we implant, during the implantation, there is no sensitivity testing happens.
Yeah.
So if someone feels that just after the procedure, patient will have a AV synchrony, VDDR pacing, it is not going to happen. The atrial sensing setup will happen in next 4 hours.
Yeah.
So you just look at the threshold in the,
only threshold.
in the cath lab. You put this device in the right place. You look for the R and pacing threshold, and then bring out the patient. And also the mechanical sensing will set up in next 4 hours, and then there will be VDD. And when we program this test, like atrial mechanical MAM test, which we say, we have to be careful about one of the programming features in micra AV, that is AV conduction mode switches. So one patient I implanted a micra AV, and that I got a ECG at around 45 heart rate, complete heart block. There was no VDD going on. So I thought, what's wrong there? Then I had not switched off this micra AV conduction mode switch, because the micra wants to pace and not to go in VDD mode if the heart rate is not falling less than 40. Someone is complete heart block at 45, 50 heart rate, the micra will not go for VDD pacing. So otherwise you have to stop this micra AV conduction mode switch. So just a reverse of what we see in normal dual pacemakers. So this is a little difference in the micra program.
And if the heart rate is higher, AV synchrony is going to be low.
Yeah.
So we may have to use a beta blocker also, post micra implant.
Okay.
Thank you, Praveen.
So next I call upon Dr. Balbir Singh. So you know everybody is well known across the country. So he will be talking the innovation in leadless pacemakers with a view to tomorrow.
So we were fortunate enough to do the first EVIR implant 11th November. Now EVIR is a great advantage over micra. So we have been discussing about battery life. It's a very long battery life, 15 years in average. If you talk of AV synchrony, so with the experience that we have of micra AV, which is huge, the AV synchrony is a big challenge and a big problem. Patient exercises, his heart rate goes up, the AV synchrony is lost. That's the time when you most want the AV synchrony, it's gone. Patient takes a deep breath and his heart rate fluctuates because of sinus arrhythmia, AV synchrony goes. So it's a big disadvantage. So truly it's not a VDD pacing, and I don't expect that that more than 70% of the patients will actually get AV synchrony. So that's a big disadvantage. So this truly gives you a AV synchrony by having two separate atria and ventricle pacing systems. Third is, it is truly got a retrievable mechanism. You can retrieve by putting another sheath and just pull out this pacemaker. So let's look at this patient. This is one of the recent patients that we had. You look at the number of leads. So there are 2 leads being pulled out a long point in time from the right side. They are left inside. Then in 2010, when these leads were pulled out because of infection, another pacemaker was implanted and 2 leads were given. In 2017, the lead got problems in fracture. 2 more leads were given in 2018. Patient comes in 24 with infection and sepsis. Now what do you do? These are the kinds of lead problems that have happened and are actually a factual reason why lead spacing is going to be a problem. Let's look at another example. This is last week. A child who was given a pacemaker, a VVI pacemaker, 9 years old, came with severe TR. And look at the way this lead has gone through the anterior leaflet of the tricuspid valve. So let me tell you that with the pacing leads going into the ventricle, people don't take care of making a loop and getting into the ventricle. 30% of the people have tricuspid regurgitation, which is underreported. Many of the symptoms of this pacing through these leads have tricuspid regurgitation and is a big problem. So imagine the surgeon had to remove this lead, repair this tricuspid valve, and then we will now look into what we can do for this patient. So this came as a big advantage for us to have a AVIR in our country, and this is one of our first patients to get it. One good thing about it is it's electrogram based, so you get good EGMs to decide which is the best pacing site. So this is a patient who had TAVR, post-op CABG, he had LBB, 1 syncope, HV of 74, no VT induced, and we did it with a 7-day monitor, nothing happened, was normal, so I thought let's put an AVIR in him. So this is exactly what Dr. Hazara was mentioning. You get a sheath in, try to get your angiogram. So this is an angle pigtail. We do angiograms in 2 views to localize the septum. So this angle pigtail is sitting right across the septum, and you mark the boundaries of the septum and you know that this is the right place to go in. First, you load the device outside the body. So this is the device which is being loaded. This is the protective sheath which Dr. Hazara showed. This looks a little complex, but after doing a couple of cases, it's quite easy. This whole mechanism looks a little complex. You have multiple switches, one to deflect, one to tether, one to have a deflection handle. So many switches are there, but once you do a couple of cases, it becomes quite simple. So what we have is an introducer sheath and then the device. So the device gets through the introducer sheath into the system. We push the device into the sheath, which is 24 French sheath. You can see the sheath. Now this device is in. Then we pull back the sheath, look at the RV angiogram, and then use the deflection to get it into the RV. This is rather simple, but choosing the right spot is above the apex on the septal wall, using contrast injections through the sleeve. So this is a protective sleeve, and we give a contrast injection to place our device well at the sheath. So this patient has a TAVI with the Evolute FX valve. And another good thing about this is that you can actually see how good is the contact. You can see on this image, the protective sheath moves in, tells you that the contact is good. Now we have pulled out the protective sheath. Once this is done, this procedure is guided by the electrograms. Now this is the map. The tether has not been done. The device is touching the wall, and you see the ST going up. So you see the slight increase in ST, and there is a rise in impedance to 620 ohms from the blood impedance of 420. This means the contact is good. That means you can go ahead and fix this device. Now I'm showing you the figures. This is 702. This was the map. The impedance 620, the ST is up. You screw in a little bit. So we screw half of the device, half of the tether. The impedance goes to 740. Look at what happens to the ST, which goes up. This is within 3 minutes. We tether a little more to full 1 circle. The impedance goes further up, so does the ST. You can see the ST go up. So this is 707. At 710, look at the ST. Now we have done a full rotation, fully tethered device. And the impedance is more than 1000. You wait 1 minute, and you see the impedance goes further up because we pushed in a little more tethering on this device, and the ST goes up. This is in the same patient. Now we have a good ST elevation, a threshold of 1.75. We wait for 4 minutes. You see we have waited for 4 minutes. You see the threshold come down, and so does the ST elevation. So this is a device which helps you to program according to the EGM. So EGM is very important in this device. This is unlike Micra. You know exactly how much you have screwed in and where to stop. Once you have tethered the device, you are satisfied with the impedances, you are now in a process of release. So you unlock this system, so the device is unlocked. Now you have to release it, and we have to press one button and the device is released. So this is how the device would look after it has been released. And this is the ST which is settling once the patient is going out of the cath lab. You can see ST is almost settled, and threshold is now 0.5, and on follow-up it remained at 0.5. This is the screen which looks very neat. And now look at this patient who's paced 90% on day 1, and the longevity is 23 years. And in a period of 15 more days, his ventricular pacing came down to 2%, and the longevity is now 25 years. So this is the longevity we are talking in terms of EVIR. Let's look at patient number 2. He had both fractured leads and had a end of life, which happened very fast on the pacemaker, and he was not interested in getting that same kind of pacemaker again. Now we put multiple ECG leads because everything is based out of ECG. All the programming, all the device talks, there is no other way. This ECG goes into the system, the remote system, and everything, the impedance, everything is measured through these vectors that happen communicating with the device. So you see these vectors, RA, LA, V lead, and left lower leg. All these communicate with the device, and then they generate those EGMs. So he has 2 leads. Again, the same principle. Look at RV is little dilated because he had moderate TR. The same device in the IVC, interrogation first, placing under septum, and releasing it there. So it's practically a half an hour job to do this case. And same thing, the EGMs, how they behaved in this particular patients. Now what did we do to this patient? A very complicated problem. You see all these leads. So I went ahead first with extraction. So we had leads. This I can't do anything because they're just broken leads. I can't do anything to these 2 springs lying there. This was 2010. Now we had leads of 2010 and 2017. So I'd lead extraction. These 2 leads were there. 3 leads I could pull out completely. This got fractured and stayed there. Then we went ahead and put a EVIR on the same sitting, and the patient has done well. So we have now experience of 7 patients in about 1 month's time. We have done 7 cases, and no complications. You can see 2 were post-infection, 2 were 6 sinus syndrome with atrial fibrillation, 1 with malfunctioning leads, and 1 with intermittent syncope. So I decided that this is just a backup for them, and all of them have done well. So we have done 7 cases in 1 month time with using the EVIR device. Thank you very much.
Thank you, sir. And one questions from any comment or questions? Otherwise, we are far behind that.
Sir, just one comment, sir. You showed a case of EVIR in post-hour patient. So usually what we do here post-hour, since this is acquired left bundle branch block, we have given this block to patient, and patient may have a kind of with LBB they can have problem in future, and obviously with normal apical pacing also they can have problems. So we do conduction system in most of these cases. So what was your preference in this patient?
So first
EVIR versus CSP in post-TBR tower patients.
So first thing, this patient had normal LV. Second thing, he had only 1 syncope, and a 7-day Holter did not show any AV blocks. So I realized there's nothing going to be wrong with that. Then I did a EP on him, no VT induced, because if you replace the aortic valve, you have some reason to get a ventricular tachycardia because you are in that zone for getting a VT. So there was no VT induced. And I knew that his pacing requirement is going to be below. I didn't want to give him a lead and correct his LBB with the normal LV. There's no data to show that LBB with normal LV should have a CSP lead. No data. Unless the patient is in heart block.
Sir, what you are thinking future of leadless? Because till now it is restricted to debilitating, frail, infective, so many things. So as you have a vast experience on the what's
right.
the message?
So my thinking is very clear because we have done now about more than 100 micra AV. It's very disappointing to see that the AV synchrony never comes. If the AV synchrony had come, micra AV could have been a hit. But AV synchrony was a big problem, and the cost is of course a problem. But with EVIR, we are going to get AV synchrony, which is going to be much better than ever thought of. So AV synchrony part is settled. The conduction system pacing has not been sorted out. The device which in development is going to be a conduction system pacing. My futuristic thinking will be majority will be leadless pacing with conduction system on the ventricle side.
Thank you, sir. Thank you for coming and sharing. Yeah.
I had one question, sir. Like the recharging technology is increasing. Our iPhones are getting recharged daily. So what is stopping us from recharging the pacemaker?
So the industry spends money on which they also benefit a lot. They are not working on this technology at all. Let me tell you, this is very simple to understand that the rechargeable should be, you have to spend a lot of dollars to get
we can eliminate a lot of complications.
Yes, right. So they have to spend a lot of money to develop a rechargeable system, and to get that money back, they see there's no future in that. So my feeling is that nobody is working on that direction.
Thank you, sir. I give a round of applause for Dr. Balveer, sir. And our next speaker is Dr. Yadav, sir.
Sir, I think we can move on with the next session.
Yeah.
Thanks. We can have a new set of chairperson and moderators.
Thank you.
Thank you very much, all the chairpersons.
Thank you.
So now we invite the next, chairperson moderator for the next session, Dr. Sanjeev Mukherjee, Dr. Saujatu Chakravarti, Dr. Saurabh Das, and Dr. A.S. Trivedi. Please come on the dais. Sanjeev, please come.
Hello. Yeah. I think we are running behind schedule. So the first talk is Dr. R.D. Yadave, difficult CRT cases and how to bail out.
Respected chairperson and dear friends, first of all, I want to thank Dr. Dilip, who always call me during these device updates, and in that way I also learn a bit. So I'm going to show some difficult cases, how I tackle, and this is one case where gentleman is clear indication for dilated cardiomyopathy, ejection fraction below 30%, severe LV systolic dysfunction, and this is the LBBB, left axis deviation, LA enlarged, and we always do levophage of the CS in LAO 45 and AP caudal view, which is my preferred view, to see where to do the lead of LV lead placement. And let me tell you, still, although conduction system pacing has improved remarkably, but still the 2023 guideline says that that CRT, that is the LV CS lead placed CRT is still the class 1 indication for where indication for pacing is required for LV systolic dysfunction. So in heart failure, it's a class 1 indication. So it's, although this is technically more difficult as compared to left bundle pacing. So technically, it's more demanding, more skill related rather than, so here we have put the lead. But unfortunately, this lead after slitting with each contraction is throw away back. So what to do? So this lead is from the Sendute, so there is no screwing system. Medtronic has a screwing system, but sometimes they provide, they do not provide. So what we do, we put 2 wire, and 1 wire, we put the sheath, delivery sheath, we put the lead, and another wire, we put the guiding catheters, a right coronary guiding catheter, and through right coronary guiding catheter, we put the PTCA wire, and with that, we entrap with the stent. So how to stent to entrap the lead? And let me tell you, we have done more than 15-20 entrapment of the lead. It doesn't cause any problem to the lead, insulation defect or anything. So in that way, stent will be, the lead will remain there after, and patient is doing fine. Even I have extracted these leads without any problem. I have one patient having infection, so extracted the lead without any problem. So this is the final result of this patient, and this is the ECG. You can see quite narrow ECG. It's not like conduction system pacing, but it's quite narrow. Another patient of similar type, this is the LV systolic dysfunction. You can see dysynchronous contraction and huge LV, and typical indication for DCM. Same all standard left LO view, subclavian angio, subclavian vein angio, and put the lead. But again, this lead again with contraction came out, put the stent, and it's fine. So deploying the stent is you have to take 2 wire and then go one with the delivery sheath, one with the RCA guide catheter. Then venoplasty before LV lead this. So here, this is one patient where there is a stenosis. You see the stenosis at the origin of the posterolateral vein, and so what to do is the lead is not going, so we put balloon, dilated it, and then put the subselect, and then we can put the lead and do the biventricular pacemaker. So this is another patient, standard technique, put the lead here. We always hook with the decapolar. Decapolar is our choice, but you can use multi-purpose catheter. You can use Sendute TPI lead, 5 French or 6 French. You can use your multi-purpose catheter, AL1 also, sometime right coronary also. And then we put the lead, quite good. But this lead, again with its systole, it came out. So again, what to do? So we checked that next time when we put the sheath, it was in the, you see, in levophage, the sheath is outside the coronary sinus. That means I am not inside the vein. So determine, find out, and then reposition the lead, and doing well. Then another bailout situation where required is patients having, this is typical patient of DCM and persistent left venous, persistent LSVC. So standard technique, nothing serious. But here is the persistent LSVC. So how to put the device here? Here we put here you see, putting the CS lead is not difficult. Putting the RV lead inside the septum is difficult. So we use right coronary angiocatheter to go into the pulmonary artery, and then I use the delivery sheath of CS delivery sheath to put the septal, to put the RV lead inside the septum. And so this is how it looks like in a patient with persistent LSVC. Then this is the final result, and this is the QRS, quite relatively narrow, and this is the CR. Another patient went to proctor the case in Assam, Guwahati, and this is what we found. We have to extract the lead, and after extraction, we have to upgrade to CRT-D. And this is the subclavian, the vein, brachiocephalic vein is blocked. So we did the angioplasty of this vein, and after angioplasty of this vein, we put the just last case, we put the it's not moving. Anyway, we put the device. Can you show? Yeah. It's mobile recorded. So yeah, and this is the final result after extraction, angioplasty, and then put the CRTP device here. And So this is another case. We did the lot CRT in this patient. We have put ICD lead. We have put septal, that is left bundle branch pacing, one lead, and another with the another lead is the CS lead. So you can see the CS lead, you can see the ICD lead, you can see the left bundle pacing by the your what is called screw driven subselect the 3D locator lead into the left bundle pacing and as well. So this is called lot CRTD implantation in one of the patients. And this is the QRS, quite narrow, where we have did the left bundle pacing as well as the CS lead as well as the ICD. And so this is the persistent LSVC with left innominate vein. So another patient where one vein is connecting to the brachiocephalic vein, another is going to the inferior vena cava. So what I did here, I used this upper vein, brachiocephalic vein connected to the right SVC, use the ICD lead, and through this one, we use the LV lead, that is CS lead, and this is the how we did the case. So ICD lead from the brachiocephalic vein connected to the right SVC, and CS lead through the persistent LSVC, and RV lead also through the persistent LSVC. And this is the how we did the CRTD in a patient of persistent LSVC with connecting vein to the right SVC. And this is all, thank you. So all difficult cases, how to tackle.
Yeah, thank you, sir, for those wonderful cases that you showed. Just one or two comments maybe, and that is just a general comment. And that is, both of my comments relate to the proximal segment of the, or the distal segment of the CS, near to the, in between the valve and the CS os. So the first is that, like you showed, we have to be very careful about proximal CS. If there is perforation of the proximal CS, if there is perforation in the distal part or in the branches, that is relatively safe. But if it is in the proximal segment, that can be actually life-threatening, and we can't do anything about that. Distal segments we can occlude and all.
Yeah, let me tell you this incident. Just 2 days back, did 3 CRT. In one of the CRT, while I took TPI lead to introduce the delivery sheet into the CS and perforated the distal tip of the CS, and that caused tamponade, and I have to send the patient for surgery. Although we tried everything to, and patient after surgery, she is doing fine. She is recovering at the present moment. And thereafter, so even distal perforation can cause tamponade and might need surgery. So surgical backup is a must, although we do in many small places without problem, but I have fatality also. 2 patients I have lost in my career for last 20 years of practicing CRT implantation, CRT and CRTD implantation. And 3rd patient developed tamponade. 4th patient also developed tamponade but was settled. So one needed surgery. So all 4 patients in 20 years of experience, more than 1,000 cases, these problems.
Yes, and the other thing is that with LSVC cases, we should remember that 2 to 7% is the incidence of patients with unroofing of the coronary sinus into the left atrium. So if that happens, and if we put leads without being very careful about it, we will have thromboembolic complications into the left side of the heart. So it's a rare thing, but maybe we should remember that.
You can do contrast injection from the left brachiocephalic vein, left vein from the arm, and to see whether the LA is getting any bubble or not. If LA is getting bubble, that means it's connecting to the roof. Don't put the lead through that. You can take the right side, right subclavian access. So in that case.
Thank you, sir, for that presentation. And we'll move on to the next presentation, that is new algorithms in ICD by Dr. Rakesh Sarkar. Dr. Rakesh, please. Yes.
So, very good afternoon, respected chairpersons, my dear colleagues, seniors. At the outset, I would like to thank Dr. Dilip Kumar for giving me the opportunity to speak on this topic. So, today I am going to speak on some of the new algorithms. I mean, although it is considered as new, but it is not actually very latest technology or algorithm, I must say. It had been there, those are there for quite some time, but maybe not utilized over the period of time in that robust way. So the potential area that I would like to emphasize would be to detection about the VT or VF with respect to discrimination between SVT and VT, and algorithm for avoiding some noise and oversensing, and at the same time the therapy to enhance the utility of that ICD over giving shock, or the maximum utilization of the ATP over using shock therapy. So in respect to innovation in discrimination, that we all know that there had been some algorithm utilized by different vendors. So namely, there is an algorithm called SecureSense, which is being used by Abbott for a long time, which is called SecureSense algorithm. And the purpose or intention is to discriminate between noise and the true VT or VF. And the way it actually looked at the different events, so it starts looking at the event at near field, which is the fast channel. And if the fast event on near field comes to be very fast, I mean, if it is the interval is considered very short, even if it is considered to be kind of refractory period, so it looks at the far field channels and it tries to understand whether the same things are being replicated on the far field channels or not. And depending on the the impression of the far field channel, it determines whether it is actually detecting the noise or it is having any true VT or VF or arrhythmia. So the counter interrogation would be 10, which is mostly marked as VS2, which I am going to show you in the next slide. So the near field actually tries to look at the intervals followed by the far field, and if the far field actually doesn't see those things, mainly the near field only sees and doesn't correspond much. So in that case, that VS2 actually represent the counter, and if the counter is more than 10, in that case it is considered to be noise instead of the true arrhythmia, and in that case the delivery of the therapy is getting inhibited. And if the VS2 counter is considered to be less than 10 in a given frame of NID, so in that case the delivery will be delivery of the therapy will be there, and it will be delivering the true therapy. So beyond that SecureSense algorithm, what the problems or the challenges are being countered over a period of time, that is the higher therapy zones and longer detection times are actually resulting in a lot of under therapy in some of the cases. And different study shows even in advanced 3 or merit RIT high rate cutoff, and 2019 FHRS consensus statement also says that the desire to avoid inappropriate shocks has led to programming of the higher therapy zones and longer detection time, which actually delayed or withheld therapy for true arrhythmias. So this unintended consequence has brought lot of insight, and the complex and unanticipated interaction between manufacturer-specific features and generic programming actually can prevent therapy for VF. So moving forward with this idea, so what actually, that failure to detect life-threatening arrhythmias has remaining a great concern for the electrophysiologist or the device implanter or the person who actually handles. Now, this inappropriate shock delivery are getting further introspected by some of the algorithms, namely which has come recently in the name of VFTA therapy or VF therapy assurance. Now this VFTA actually is very alluring, and I must say that if we just go through some of the basic principles of that VFTA that designed to identify and treat the arrhythmia that are actually inherently likely to be hemodynamically unstable and quite a good possibility to get actually misguided by looking at even though that secure sense or the regular algorithms or the features that we are using in different devices. So VFTA looks for poor far field sensing on the discrimination channel at strategic times and applies new detection parameters when criteria is met. So what is actually it meant for, I will tell you in the next couple of slides in detail. And VFTA actually resulted in VT therapy for 86% of patients who would have been otherwise untreated. So this is a considerable and significant sizable number of the patients that can be actually potentially life-threatening arrhythmia. Now that EGM marker review, if we just see that VS2, which is actually is a counter which is being sensed in the secure sense, and actually which is represented as a very low amplitude signals in the far field, namely less than 0.3 millivolt of amplitude. So in that case, the VS2 counter is being not properly sensed, and there is a very long pause because this is going to be true VF or polymorphic VT, which is not being picked up in VS2, and on the other hand, it is actually not also the noise. In that case, actually VFTA therapy gets started or activated, and this that VFT only uses the far field channel. It uses counters to determine when there is a signal dropout of more than 2 seconds or consistently small signals of less than 0.3 to 0.6 millivolt, because below that there is hardly any device industry who can actually find out the signal amplitude. Now VFT uses two independent counters, as I mentioned, that pause counter and signal dropouts, and looking at that, it actually determines how to start and when to start. Now VFTA triggers if the low amplitude counter is more than 2, that means small signals which is 0.3 to 0.6 millivolt increment counter is being considered as a 1. Large signals reset it back to 0, means the signal counting will be withheld. Now notably, the discrimination channel displays the unfiltered signal and a filtered channel in the discrimination channel. So VT therapy assurance, if we look at the workflow, that VF therapy assurance uses the discrimination channel first to check for the far field undersensing during potential ventricular episode, followed by it is determined that far field undersensing is present, and subsequently VFT is triggered. Program parameters are automatically changed for the remainder of the episode, and followed by the redetection, and within next 15 cycles of the end of the episode. Now VFTA is changed to single therapy zone once it is activated. That means there would not be any other therapy zone will be considered. It will be a single zone, and decrease, and that VF detection will be decreased to the lowest programmed active therapy zone plus 100 milliseconds. Let's say, for example, your VF was set as 280 millisecond as the NID, interval. So in that case, it will be 280 plus 100 means 380 or 400. Now number of intervals will be also decreased to 6. Let's say you have kept in the usual thing as 12, but it will be considered as 6 in the VFTA zone. Now end of episode previously turned to sinus increased to 7 intervals and permanently programmed to VF therapy when it is used. So I'll just skip some of the slides because of the interest of the time. How much is remaining time? So I'll just try to go to the another few of the slides. So another algorithm which is used, that is to avoid the T-wave oversensing, and there are few modalities to look at or get away from this. One is the algorithm for T-wave derivatives, that means the differentiation of the sensed EGM that utilize R-wave and T-wave ratio to get away from the T-wave oversensing, which is nuisance sometimes to give the inappropriate shock. Sometimes altered sensing vector can be utilized, and signal filtering is also one of the way to get rid of the inappropriate shock. Now there are other lead integrity suite, which is another way, another good algorithm, although it is not very novel. But this thing I want to highlight or emphasize, that is intrinsic ATP therapy. So this is very interesting per se. If you look at the ATP, even though the burst or ramp will be utilized, but most of the time it will be actually ineffective and unnecessarily, or I would say that inadvertently it will result in lot of shocks which actually invite further high voltage therapy. Now that EP principle has been imbibed in this particular algorithm, where actually it has incorporated some of the extra stimulus to break the circuit of the VT, from where it is actually try to get into the circuit, followed by the termination of the tachycardia, where actually it is coming as a very sufficiently short extrasystole in a closed excitable gap. So this idea has been imbibed in the latest models of the Medtronic, namely cobalt or chromium, and this features is actually translated in lot of I would say that avoidance of the unnecessary shock or regular shock, and termination of the lot of bad VT, which could be otherwise being able to manage by ATP itself. So this is the basic mechanism of IATP, but for the interest of the time, probably I would not be able to emphasize much. So I would like to conclude here, and would be happy to have few of the topics.
Great talk. Rakesh, this VFTA thing, will you like to individualize? Because now we are seeing some shocks which are not required. So do you think VFTA needs to be individualized, or you want to keep it in all patients?
Yeah, so basically in some of the situations where we are actually dealing with polymorphic VT or VF, so in that case sometimes I would say that there is under treatment, and VFTA can have some remarkable benefit, because sometimes in that case, if you use the regular algorithm, probably that patient would not be able to get any therapy. So in that case, VFTA is a kind of bliss, or I would say benefit, to get away from that malignant arrhythmia.
Thank you.
Sir, with regards to VFTA or in general?
Discrimination is allowed or not in patient with complete heart block with dual chamber ICD. Do you program SVT algorithm like stability, onset, morphology?
No, it is not required actually.
Rakesh, one troubleshooting for ICD, particularly beeping sound, and particularly before, even after the 2 years, 1 year, generally it according to device, it gives before the battery, low battery signal or here. Is there any fix? Because all different have a different type of it. So what is one of my patient have a fixed time beeping after putting the ICD.
So basically, there may be different sorts of alarm. So as you mentioned, one alarm might be there in the form of sometimes there may be some issue with the battery depletion or premature battery depletion. Sometimes there may be some impedance rise. Sometimes there may be some maybe lead fracture or lead noise. Sometimes also can give you some alarm in the form of beeping. And there may be some of the vendors have some algorithm which actually tries to measure the threshold or some of the things which can come as a kind of alarm, which is not always a problem, or I would say malfunction all the time.
Can ICD, your IATP, can induce accelerated VT or VF?
Yeah, there is a chance, but the thing is that
because
it
it's
actually
not always safe.
No,
VITP.
Yeah. So theoretically it is possible, as you mentioned, but it also tries to look at the refractory period, looking at the PPI. So post-pacing interval, it always tries to look at. So it doesn't go most of the time below that and tries to, fall in the refractory period to result in just like a R1T phenomena. It doesn't go in that way that it will result in VF from VT. So that features is always there.
Thank you, Dr. Rakesh, for illuminating talk. Next, we invite Dr. Javed Pervez to come and give his talk on next generation devices engineered for performance.
Dr. Javed will also club his next presentation. He will also show his case.
No, it's not getting displayed. So take it automatically, right? Yeah, it's working now. So before I begin, I must thank the organizers, especially sir, for inviting me and giving me this opportunity to present before this August gathering. And my job has been made easier by the previous talk by Dr. Rakesh, because I'll take it from there where he ended this. So there are device updates which are coming almost every year, and it's almost impossible to follow each and every one of them unless we keep attending conferences such as these. So I'll be highlighting certain next generation features of Medtronic devices specifically, because in a 10-minute talk it's impossible to talk about all the different manufacturers and their advances. So the focus is basically on IATP, because it's clinically we found it very much interesting and smart and innovative way to look at anti-tachycardia pacing. So the newer generation of devices, Medtronic has called them cobalt and chrome devices, and these are the highlights of these devices. One was the battery life. I think Dr. Praveen Sri Kumar talked in morning session about the improved longevity, which was always criticism about the Medtronic devices. Then they have increased the maximum shock energy which can be delivered is 40 joules, and the stored energy is almost up to the 47 joules. The Bluetooth connectivity sort of makes things easier for data transfer, as well as it saves battery. And then there are algorithms such as triage HF. We'll talk about only very briefly in the subsequent slides. Predominantly, we'll focus on intrinsic anti-tachycardia pacing. Some of the algorithms to reduce inappropriate shocks, Dr. Rakesh has already discussed, so I'll not go there. We'll talk about intrinsic ATP or IATP, how it is different and why there is so much interest in this IATP from Medtronic. Because it's an automated and smart anti-tachycardia pacing algorithm that provides individualized therapy in real time. So traditionally, the ATP has been burst and ramp, which we all know, and there have been minor variations, and the manufacturer tend to call them by different names, but basically they are burst and ramp, and certain times an extra stimuli that is being provided. So the success of ATP depends upon what type of where we are pacing from the delivering the anti-tachycardia pacing, and where the tachycardia circuit is, and obviously the substrate and the conduction velocity, which depends upon drugs as well as electrolyte disturbances. So it's almost impossible for us to individualize every patient an anti-tachycardia pacing regimen that can be given for every patient, because these things are dynamic. So here what Medtronic has done is it has come up with a simplified programming option that is on and off, and here the ATP therapy is individualized and it is designed for each VT. And not only that, the device is sort of uses artificial intelligence, and it readjusts and responds automatically in the next ATP sequence. So it learns from any failed attempt of ATP and customizes ATP pacing delivery for every other episode. How it does that? Okay, so this some of the slides may be common. So this is the old two-dimensional concept that if you give a drivetrain of anti-tachycardia pacing stimuli, that is the S1, we might be able to enter the circuit and we might be able to accelerate the tachycardia, which is called as entrainment. And sometimes we might be able to, eliminate the excitable gap and terminate the VT. But then there is also a chance of acceleration as well. So Mark Josephson was ahead of his time that when he said that in 1982 that the devices or the AICDs which are involved in management of VT should incorporate ability to introduce a premature stimuli after a drivetrain. That is to be able to introduce an S2. Because S1 might be able to reach and entrain the circuit, and S2 is very much useful so that it can enter the excitable gap and close it and terminate the VT. So how intrinsic ATP, this algorithm from Medtronic does this is, it uses, it delivers ATP, it looks at the post-pacing interval, it analyzes the post-pacing interval, and it learns from the first delivery and how much of the drivetrain is required, whether 8 or 9 or 10 or even lesser, and then it went to introduce an S2, went to introduce an S3. All that the device learns automatically. So this is how it does it. So it just delivers a drivetrain of S1, and how it does that also is also pre-decided. So the coupling interval is almost always 88% of the tachycardia cycle length, and then it divides the post-pacing interval into no reset zone, and loss of capture zone. So the loss of capture is very easy to understand. Whenever the post-pacing interval is less than the tachycardia cycle length, that means we have not captured the ventricle and it has spaced into the refractory period, and that is the loss of capture zone. In the reset zone, the tachycardia reached the VT circuit but did not terminate it. So based on that, the device might either shorten the S2 or S3. If there is loss of capture, it usually extends the S2 and it might add an S3. So we'll take a case example. This is an actual example from a stored data, from some stored event. So these are the interval chart for a VT cycle length, which is going at 340 milliseconds. So the device delivers S1 at 300 milliseconds for 8 beats, and it delivers an S2 at 280 milliseconds. When it delivers an S2, that interval is also defined by certain calculations, and then it looks at the post-pacing interval. So the post-pacing interval in this example comes around to be 400 milliseconds. So it was in the reset zone. So the device understands that the post-pacing interval is in the reset zone. So for the next cycle, it has reduced the number of S1 to 4, and it has introduced an S2 at 260 milliseconds. Again, it looks at the post-pacing interval. Again, the post-pacing interval is in the reset zone. So again, it will subsequently shorten the S2, that is the extra stimulus. So 4 drivetrains at S1 at 300, S2 at 240 milliseconds. Again, it looks at the post-pacing interval, which is now 420 in the reset zone. So this cycle keeps on going until unless the S2 is subsequently is reduced, and sometimes we may land up in non-capture. Here the 5 drivetrains of S1 has been delivered at 300 milliseconds. The S2 was delivered at 200 milliseconds, and that resulted in post-pacing interval of 210 milliseconds. That is less than the tachycycle length. So that means the S2 didn't capture. So the device understands that, and then what it does, it extends the S2 to 240 milliseconds and introduces an S3. And when it did that, what happened is the tachycardia terminated. So this is how intuitive and smart this algorithm is. And again, we'll see certain EGM-based data. So similar sort of, this is from a case where there were 2 episodes of VT, which were terminated by 6 cycles of ATP. So we'll see the intracardiac EGMs. So here is the far field, here is the bipolar, that is the near field, electrograms, RV tip to RV ring, and the second is far field, CAN to RV coil. So there is a tachycardia that is going on around 320 millisecond cycle length, and the NID was reached and the tachy was detected. Then the device decided to deliver ATP, and the initial ATP was delivered at 280 milliseconds. Then the device brought in an S2. After a drivetrain of 8 S1, it brought in an S2 at 260 milliseconds, looked at the post-pacing interval, which was 520, so decided to gradually, subsequently, decrease the S2. So this went on unless to a point where the where the S2 was reduced to 180 milliseconds. So if you look at this after the anti-tachycardia pacing cycle, that is drivetrain of 8 S1, the 9th beat is S2. Here you can see that in the far field there is no EGM, but the local electrogram shows a deflection. So this is a non-capture. So device understood this as loss of capture. Then it extended the next S2 and it brought in an S3, and that terminated the ventricular tachycardia. So again, both the events of these VT were terminated with this. So what about data regarding this IETP algorithm? So Medtronic studied this in virtual models of constructing 3-dimensional VT circuits based on certain patients' retrieved data, and it found out that the success rate of VT termination was around 17% higher than the traditional ATP. So this was in virtual data. What about real world data? Even in real world data, it was found out that the success of termination of monomorphic VT for cycle lengths less than 320 milliseconds was almost around 80%, or more than 320 milliseconds was almost around 85 milliseconds. So coming to one of the questions which I think Dr. Yadav sir asked, what about acceleration? So in this real world data, they found that almost there was 3% acceleration, that is defined as 10% increase in the tachycycle length, decrease in the tachycycle length, and subsequently the patient, 3% of the patients developed VF, which was terminated by appropriate shock. Otherwise, 79 to 85% success rate in terminating the VT without a shock. So when this data was compared with the already existing older trials, so this is how it stacked up. Obviously, the comparison is not direct because of differences in different studies, but this is what it is. So almost 85% reduction or success in terminating the VT in IATP has been shown. So this is regarding the battery life. So Medtronic has improved its battery life, at least what it claims. So but this has been because I have implanted only 3 or 4 cases, and I am seeing definite improvement in battery life. Just a couple of more slides. Another one of those important innovation which I think Medtronic has done is effective CRT algorithm. Just one slide on that. So what it does in effective CRT algorithm is basically for atrial fibrillation. So during atrial fibrillation, the device cannot beat the intrinsic condition, and usually that results in loss of effective BIV capture and loss of effective BIV pacing. So the device stores a sort of far field electrogram at the time of effective BIV capture and labels it as effective. So whenever there is an atrial fibrillation and after a pace beat is delivered after a sense beat, and the device matches the morphology between effective and ineffective, and if it finds that if the BIV pacing was ineffective, it will increase the pacing rate so that there is more chances of delivery. And if it finds that it was effective, it will decrease the rate of pacing so that there is effective delivery. This is how it is in actual life. So this is from same patient. Here the effective CRT is turned off, here it is turned on. So atrial fibrillation is going on with varying ventricular rate and fast ventricular rate. As you can see, there is loss of BIV pacing. Here the device attempts to pace, and this morphology is different from the stored one, so the device labels it as ineffective. And once you turn on the effective CRT, what the device does is increases the pacing rate so that the morphology matches to the stored electrogram, and it is now called as effective CRT. And in trial data, it has been shown to increase almost 16% of pacing in BIV delivery during atrial fibrillation. Just a word about this heart failure risk triage tool, that is Triage HF. It looks at, it's a basically remote monitoring tool. It looks at certain variables such as these: OptiVault data, patient activity, atrial fibrillation burden, night ventricular rate, heart rate variability. Based on these variables, it divides patients into high risk, medium risk, and low risk. For all the high risk patients, it intimates the primary physician so that these patients can be brought back to the OPD before there is an actual heart failure hospitalization event. So with that, I conclude. Thanks. If there are any questions for this, I'll be happy to take them.
Thank you, Dr. Javed Parvez, for an
Sir.
excellent question.
So V-sense response and effective CRT, what's the difference?
So,
equivalent to V-sense response?
Sir, in V-sense response is basically something similar to adaptive CRT. The name can be different between manufacturers, but it's nonetheless but the same thing. In adaptive CRT is algorithm based to achieve fusion between optimizing, it will look into the intrinsic AV conduction and shorten the phase dB delay, sense dB delay, so that there is effective by CRT delivery. Here in AF, it is looking at electrograms, which are basically far field electrograms, looking at some sort of morphology equivalent to find out whether the pacing which is going on is actually effective or not effective. So there is slight difference between the two.
With the V-sense response.
Yes, sir?
So it's not related with the V-sense?
No, it's not related to V-sense.
So Javed, you can show your case of conduction system.
Yeah. So I'll just finish off with a very small case. After Yadav sir's exotic cases, my case will appear very simple. So this is a case of conduction system pacing, which I did in almost 2 years back in a patient with corrected transposition of great arteries. So 31-year-old, relatively young patient presented to me with situs solitus, CCTGA, syncope, and the echo showed normal systemic ventricle, which was the morphological right ventricle. So the problem in patients with CCTGA is there is almost 2% annual risk of complete heart block, and patients who have we have got additional defects such as a VSD. Almost 67% of such patients develop right ventricular failure, that is the systemic ventricular failure by the age of 45, because that ventricle is not suited to tackle the systemic pressures. And even without defects, 25% of the patients with CCTGA develop without VSD, they also develop systemic right ventricular failure by the age of 45 because of the same reasons. So when we consider pacing options for patients with CCTGA, we must think about that this patient, if delivered with a conventional pacing, there are very high chances of developing heart failure, premature heart failure than the age at which they develop it. So the options are, if patients have heart failure and significant AV valve regurgitation, CRTP versus conduction system pacing. Again, considering CRT in these patients with CCTGA, another important consideration is almost 20% of these patients with CCTGA have some sort of coronary sinus abnormalities, such as os atresia, or sometimes the right ventricle is drained by only the smaller Thebesian veins. So these are the problems. What about his bundle pacing? Again, we'll see very brief in a little bit of anatomy. What happens in these patients is that this is a diagram taken from one of very famous papers by our own Dr. Nambudiri sir. So this is in CCTGA, situs solitus CCTGA. What happens is, obviously there is atrioventricular discordance and ventriculo-arterial discordance. So there is the pulmonary outflow tract is usually deeply seated in between the ventricular septum and the mitral valve. So what it does is it causes a malalignment between atria and ventricular septum, and usually there is a gap between these two, and usually it can this gap is either filled by a large membranous septum or there is a ventricular septal defect there. The usual posterior AV node is hypoplastic and does not connect with AV bundle. So on its place there is an anterior AV node, which is located below the orifice of right atrial appendage, close to the lateral margin of pulmonary mitral continuity. So here we don't have aortomitral continuity, we have pulmonary mitral continuity. So their anterior AV node is usually located. From there, penetrating bundle of his arises, which pierces the fibrous trigrone and runs in the subendocardium in the ventricle to reach the top of the ventricular septum, that is the interventricular septum, and there it divides into the left branch on the right side and the right branch on the left side. Because ventricles are inverted, they take their blood supply and they retain their the bundle branches along with them. So here the problem is, if you want to deliver conduction system pacing, the left bundle, as we all know, extensively arborizes and branches so that it gives us a larger target area to achieve conduction system pacing, while the right bundle is thin and slender and it doesn't give so many branches. So there is obviously a difficulty with achieving conduction system pacing. Then the anatomical differences. So my patient had mesocardia. While you can have dextrocardia as well, you can have levocardia, and then you can have situs inversus as well. So my patient has situs solitus and mesocardia. So based on the anatomy, you can see there could be a lot of variations in how the septum is oriented and how we are going to achieve conduction system pacing. So just for the sake of anatomic interest and academic interest, and also to identify the venous anatomy, as you can see, there is atresia of the coronary sinus os there, and it opens by a smaller vein into the right atrium. And it does, as you can see, the ventricles have retained their blood supplies, and the systemic ventricle is supplied by right coronary artery here. That is one of the reasons why it fails in the long term. So we went ahead, we decided to, we had put a temporary pacing catheter, and we used fluoroscopy to define the septal anatomy by using injections, contrast injections or the septogram, and luckily we could find out a stable position, or we could find out the angles where the septum was, interventricular septum was truly perpendicular, and we targeted that area for conduction system pacing. We'd obviously, since morning we have been hearing about conduction system pacing. The setup is not different. It was the same. Septal thickness was 11 millimeters here. We tried to position the his, but here it was due to anatomical difficulties, it was very much unstable. So we went ahead without pacing. We removed the his catheter and we went ahead with the conduction system pacing. So these are the tools which you all know. So we'll not describe that. This is on the right side of the septum, where we we wanted to start screwing there. So again, we don't know the exact ECG criteria as they have been described in traditional left bundle branch pacing, but we saw a positive QRS complex in inferior leads, AVR AVL discordance, so we thought of going ahead. And especially if you see there is some sort of narrowed QRS on the right side of the septum in V2, V3, I believe because we were sitting on the left bundle, which is much more superficial and easy to capture. So at this point we started entering into the septum, and we could move in very easily, and this was done with the Medtronic sheath, Medtronic lead, so there is no continuous pacing during that. You have to stop and see the paced morphology, and we were able to get that traditional RS pattern. And at one point during the threshold testing, we found out between 1.1 volt and 1 volt there was a separation of the local ventricular EGMs, so that gave us confidence that we were doing conduction system pacing. So this is how I hypothesize that sitting on just on the left bundle branch, this was the paced morphology. In between where we went in, the LVAT was slightly changing between 1 volt and 1 volt. So we gave another turn, and then after that, the RVAT here. So the R wave peak time became fixed between 5 volt and 1 volt, confirming that we have done a conduction system capture. So this was the final result, and this is how it looked. And we got very good lead parameters, and the patient has almost completed 2 years of follow-up. Until now she has not developed a systemic ventricular failure. So to summarize, CSP should be offered to every CCTJ patient because of increased likelihood of systemic ventricular failure. In this particular case, I thought that I was lucky because the anatomy was forgiving, and we could delineate the septum as well. Otherwise, as I mentioned, there could be a lot of variations in anatomy. I looked up into the literature, almost 20 to 25 cases of situs solitus and TGA have been done, and majority of these cases have been done with 3D mapping, because the right bundle is a slender structure. Unless we know that where to target that right bundle, then there could be difficulties in cases. So ideally we could have done with the 3D mapping, but because of cost constraints we couldn't do it. And ICE is another option where the anatomy is challenging to achieve success. Thanks.
You could have done the left bundle pacing by only few screw without too much deep.
Yes, sir. The septum was thin here, and it was going quite fastly in. So I had to actually, slow down my screwing in process.
Here you don't need to do, because septum is profiled vertically.
Yes.
In AP,
yes.
So you don't need to do LAO or so. So you can.
No, that was the LAOB which you saw. The septum is vertical.
And mostly mesocardia is associated with corrected TG.
Due to lack of time, we will move ahead. Thank you, Dr. Javed Parvez.
Thank you, sir.
Wonderful case, Javed.
Thank you, sir. Thank you.
Now we would like to invite Dr. Rabin Chakrabarti, sir, for where, when, and how to pace to improve responder rate in CRT patients.
So we'll break for lunch after this presentation.
Thank you very much. It's a really privilege and honor. Congratulate Dilip for arranging such a wonderful meeting on device, and I'm sure that this kind of meeting would be very popular nationwide. So I'm going to talk on this your LV lead positioning and relationship with the responder rate. So as we all know that in heart failure with wide QRS complex like left bundle branch block morphology with ejection fraction less than 35%, it's a very standard indication for resynchronization therapy. However, even non-LBBB group also there are some indication in some subgroup, probably CRT would be an important tool to improve the LV function. But we have to accept that CRT implantation has some problem. We know that nearly 30% may be non-responders, and there is a challenge in LV lead placement to get an actual capture of left ventricle and to synchronize left ventricle with the right ventricle. Often the coronary sinus anatomy could be treacherous, and it is a big challenge because we don't have any control on human anatomy. It is a completely God design, so we can't sort of challenge God by any means. On the top of that, there are certain conditions like ischemic heart disease or previous myocarditis or cardiomyopathy may have extensive left ventricular scar, particularly of the lateral wall. That also causes the problem of the left ventricular capture. And it is important for us to recognize that interventricular electrode distance is very important to cause and to create a very optimum synchronization between two ventricles and therefore to achieve a good ventricular function. So these are the kind of situation that we encounter. For example, there could be extensive myocardial scar which can be seen by cardiac MRI. There could be anatomical abnormality, particularly the coronary vein, and also there could be epicardial activation mapping can also say that the activation sequence could be really abnormal, which again can be captured nicely by three-dimensional technique. And similarly, the image integration sometimes is extremely helpful to recognize that which area could be an ideal place for left ventricular lead placement. And sometimes the CRT implantation guide also very important. With this background in mind, we'll proceed to talk about it. Over the years, we understood and recognized that the left ventricular lead challenges are particularly that when you place the left ventricular lead and then you try to pace that left ventricular lead either from the distal lane or proximal lane, and then it has been shown that if we try to capture from the apical end of the lead, then this is one way of capturing it, then you synchronize with the right ventricle, or if you try to capture the left ventricular wall from the non-apical side, could be lateral or could be posterolateral side, then whether that can sort of make some difference. And now we have data. It has been shown that non-apical pacing locations which have shown to improve a better clinical outcome. But at the same time, it may be difficult to go there and achieve that kind of pacing. And this is the situation which has been told, which has been quoted in the literature. There are 3 recommendations which are provided regarding the choice of mode and CRT optimization. Goal of CRT should achieve biventricular pacing as close as 100%. Apical position should be avoided, and left ventricular lead placement may be targeted at the latest activated left ventricular segment. To make it more simple, like this is a kind of paper. This is Jasmeet Singh's paper circulation, but I'll quickly take you further. And it has been shown that MEDIT CRT trial, which has shown that if you could go to the left ventricular lateral lead and fix the left ventricular lead appropriately, then you can actually have very nice pacing, and therefore the complication can be avoided, which essentially means that this is the coronary sinus and you are taking the lead, and left ventricular lead location should be such that then you try to sort of create an algorithm by which you can go as basal as possible to achieve the maximum resynchronization. Like this is an apical area, then you go to the mid part, and this is the basal part. So when you place it and then you place the lead and try to go proximally in such a manner or in such a manner that you design an algorithm so it captures the basal segment of the lateral segment of the left ventricle, and by synchronizing with the right ventricular pacing, you can actually get an optimum of pacing or optimum biventricular pacing. So, and there are a lot of studies, I just, because there's a time constraint, there's an example. So, left ventricular pacing time to fuse with the intrinsic conduction improves the left ventricular function. This is a very essential line you have to remember. The pacing time has to fuse with the intrinsic conduction, and if you can manage to do that, you can actually improve the left ventricular conduction, left ventricular contractile function, and that is what is important. And this slide clearly shows that how you can do that. So this is a paper which has been published sometimes in 2019, and this again Jagmeet's paper, and it has shown that you can have by two activation, a biventricular pacing, you can have fusion, intrinsic, and on the top of that the biventricular fusions. If you could do that, for example this one, you can probably get the best possible result in CRT therapy. This is an example where you can see that this is a QRS wider, and then with the fusion of the intrinsic conduction versus the pacing conduction, you can get a very nice narrow QRS complex leading into progressive improvement of the left ventricular contraction leading into left ventricular ejection fraction. And nowadays, all the companies like Medtronic, Abbott, and even the Boston Scientific, they have actually come up with their algorithm with automaticity, and you can actually assess the intrinsic conduction function, and accordingly you can adapt the left ventricular pacing, and then you can create an algorithm by which you can synchronize the left ventricular pacing versus the other pacing. And if you look at the MEDIT CRT sub-analysis and reverse sub-analysis data, again highlights the same position. Now if you look at this another, this is an acuity family lead, and if you could take this particular lead, it has been shown again that you can have a basal as well as the apical thing. And if you get into the basal part, advance the lead, place it in position, and then you follow the algorithm and try to pace the left ventricular lead position. This is again the same paper of MEDIT CRT trial by Jagmeet and his colleague, and it has been shown that left ventricular lead position in the apical region were associated with an unfavorable outcome, which suggests that this lead location should be avoided in cardiac resynchronization therapy. This is an example. So this is the MEDIT CRT trial, you can see, and then you have to place the lead in such a manner so that you can capture between 3 o'clock to 5 o'clock position somewhere there. For example, this is the 4 o'clock, so you can probably sort of place the lead like this and try to capture the left ventricular lateral wall musculature in such a manner so that around 4 o'clock position so that you can get an optimum pacing system. So then you can see that if this is a apical, this is the basal. If you go to the basal, there's a nice sort of delay between 170 millisecond. That interventricular conduction time probably help you in the best synchronization. So this is an example where by doing so you can actually get a very narrow QRS complex as compared to the apical. If you go to the apical, you can see that it is biventricular pacing, but the QRS is still wide. If you go to the apex, you can actually see the QRS is narrow. So obviously the ejection fraction is going to improve. So I'm going to finish it because this is another lead which is again a Medtronic lead. They're very nice active fixation quadripolar technology. You can fix it nicely and then you can program it and try to get into minimum musculature somewhere there which will avoid the phrenic nerve stimulation, at the same time can improve the left ventricular function. So, and finally, this is my last slide. This is a new technology which has come called Smart CRT technology. Although by word it's a Boston's technology, but technically, in fact, all companies have the similar technology in various names. To make it more simple, multi-site pacing probably a very important component these days about to getting the maximum optimization and maximum improvement of the resynchrony. This multi-site pacing, there's a nice paper being published by Neeraj Verma from Cleveland. And he has shown that if you can apply this multi-site concept of pacing through their electrode, then you can probably get the best possible function of this. And 77 to 3% can be achieved by one particular company's lead, but sometimes it is a little less. But again, you have to play with this algorithm to get the maximum result. So and the last one, there will be certain situations that where you can actually cannot do the CRT because of the anatomical abnormality, because of scar, and sometimes the patient has low ejection fraction, but it is non-LBBB group. So you are not quite sure because you do not have enough data to support that all three leads will do a good thing. So those situations, people are actually doing conduction system pacing, which is very nice. And this is our own work, our own publication, which has shown that in lot CRT in patients with refractory heart failure and non-LVV morphology, we've actually proven that if you can take up this group of patients, there is significant difference to improve the left ventricular function. Thank you very much for your attention.
Thank you, sir, for your enlightening presentation. I think that these newer algorithms will go a long way in reducing the non-responder rates along with LBBB optimization and everything. So any questions from the audience?
Thank you.
Okay, sir.
Thank you, sir, for the wonderful talk. And thanks to chairpersons and moderators. So now we can break for lunch. It will be a 30 minutes lunch and then followed by Dr. Hajra's presentation and Dr. Balveer Singh's presentation, the next session. So now may I invite the chairperson and moderator for the next session, Dr. Devdatto Majumdar. Please take your seat. Dr. Anand Kumar Pandey, Dr. Suvradip Datta. Dr. Parida is there, has he left? And Dr. Praveen. Praveen, can you chair the session for us? So we have the flow of this session will be Dr. Hajra will be presenting, then Dr. Balveer Singh will be presenting, and then there will be case presentations.
PK Hajra. SICD. SICD.
So, okay. Dr. Asra will be talking about subcutaneous ICDs and latest clinical trials and their recommendations.
Right. Praveen, my friends. So I'll be speaking on SICD, subcutaneous ICDs. We have moved away from transvenous system to subcutaneous ICDs and also EV ICDs. That means extravascular ICDs from Medtronic. And in near future, we'll have a modular system. So this is the history and this is the timeline of SICD technology and the evidences from Praetorian trial to untouched trial. Next is Atlas trial. So the device has also improved in their longevity, and this is the story behind the success of ICDs therapy in human being. So 1931, Fuben to Barkovitz, the transvenous pacing made cardiac pacing widely applicable. Then the inventor of external defibrillators. Then this is the Dr. Michael Miroski, 1924, he died in 1990. He's from Tel Aviv, basically, and the first implant was done in Baltimore. And these are the legends of subcutaneous ICD. So Boston Scientific, they are the first to introduce the subcutaneous ICDs. And I have an experience of doing only 4 because of its cost. And perhaps there are some people who needs ATP pacing or bradycardia backup. These are not the devices to be adopted. So with time, we know that the device size has come down because of the battery technology. And still, the lead system, though it has improved over time, the lead fracture, the extraction of the lead due to infection endocarditis is hell of a job. Though we know now that laser system can help for the lead extraction on the same day, and you can go for either leadless pacing or wireless SICD. Most of the cases where the SICD is preferred, like people who had an infection or do not want to have any device, so without touching the heart, you can treat the heart. The transvenous ICD has its own complications, the infections, lead dysfunctions, recall of the devices because of lead dysfunctions, insulations problems, a large access, I mean you have to have a pocket, large pocket. The small frame people, both the SICD and the transvenous ICD is a problem. So there is a solution in the future. Now, who needs this device? Is it a first line of therapy if you do not need bradycardia pacing, if you do not need a device for heart failure indications, like you have a quite wide QRS and low ejection fractions, and a recurrent VT requiring ATP, perhaps these are the people require transvenous ICD or CRT-D. And if you have a failure of screening because of obesity, you have to screen these patients before thinking of SICDs, and these SICDs are done general anesthesia. So if you do not have all this, you can go for SICD. But the ATP problem is solved now by modular SICD. So this is a system, this modular CRM system from Boston. You have this leadless pacemaker like Micra and AVR. The system is Empower. It looks like Micra. It is a passive fixation. And this can interact nicely with emblem MRI, and it can cause can give good ATP and bradycardia pacing backup. So because of this, we have more and more confidence of, but again, the cost. The company has considered the cost issue, and probably it will be, in the future, it will be like your regular SICD cost. So it doesn't come with a premium price for the leadless, but yet we do not know. So these devices are passively fixed like your transcatheter pacing system of Micra and AVR. And once they are inserted, these two devices communicate with each other and makes life, the number of shocks can be reduced by ATP. Now, as we are discussing early in the morning, there will be some other devices like AVR, which is basically can be inserted in the LVB zone, which can work as CSP pacing, also has some ATP in the backup. Some of these ATP-induced ventricular fibrillations can be terminated by SICD. So the battery longevity can be increased by this kind of system. And you know, there are other systems from Medtronic. There are many implants have been done with the EVICD from Medtronic. You have to do it under general anesthesia. Substernal tunneling is done by a specific device. You go lateral and you go AP, 2 centimeter away from the midline, and you have this coil, the ring coil. Placement is very important. There should not be any kinking of this coil. The coil should look exactly like this. If there is a bending or kinking of the coil, the delivery of the pacing or the threshold may be high. You have to reposition. All these are possible now. So these communications can be achieved in almost 100% of cases. It can pace at low voltage, so modular CRM is the future. So pretorian trial, this is basically comparison between transvenous system to subcutaneous system. And we have shown that perhaps both systems are equally good. You can argue about the inappropriate shocks, but the difference or the delta is not very wide. And in the New England Journal of Medicine, this has been published. They are merging together at the end of 5 years. So device-related complication will definitely be much lower with subcutaneous ICD pocket. This is a bigger device, and subcutaneous pocket is made either by a surgeon or by a cardiologist. There is no wear, only a lead inside your substernal subcutaneous tissue area. So inappropriate shocks has been reduced by artificial intelligence and different algorithm, and SICD as good as transvenous ICD is getting better every day. So there are untouched trial, more and more trial, and all these trials are trying to solve one issue, that inappropriate shocks, and obviously the complication rate, whether it is your P wave or undersensing muscle potentials or any other thing which can trigger a shock, has been reduced by newer devices and more artificial intelligence. So Atlas trial, inappropriate shocks, two groups, again, it is little higher on this SICD, but as I told you, the beautiful, the biggest advantage of having a drug-eluting balloon in the coronary, you leave nothing behind. In SICD, you leave nothing behind, whether it is a lead or any other coil inside. So life is beautiful in future. There will be more improvement in the technology. So life, the complications will come down further, and perhaps it will be the first line of choice for any VT, VFs, or prevention, primary, secondary prevention of sudden cardiac death in future with ATP and bradycardia backup. Thank you very much for your kind attention.
Nice talk, sir. Very lucid. The thing is, one thing about Praetorian trial results, they have shown not much difference. But do you think
non-inferior?
But do you think it is true because most of the arrhythmias are nowadays being treated by the ATP alone?
ATP only.
So how can this be?
I don't know. You are the EPP specialist. You can answer it back, Dr. Balbir.
So I have I'm not very sure about that. They have shown the result, of course, but did they select the patient? Was there a selection bias? We need to see.
Right. So there are two things in life in cardiology. If something is published in NEGM and Lancet, two journals, you have to believe as a gospel truth. There is no criticism of NEGM journal. So that is an indirect evidence, perhaps whatever they are saying is a truth. But if you go into the detail, I do agree with you that inappropriate shocks definitely is a burning issue with SICD. But I think the algorithm and newer AI, artificial intelligence, which has been embedded in the newer generation of ICDs, whether it is transvenous ICDs, IATP, or newer emblem-based CD, the newer generation will be available 2025. The inappropriate shocks has come down definitely significantly.
Trial, probably.
So this is initial trial, 2020.
Yeah, 20. So once the implanters start implanting, we'll get.
Dr. Balbir.
Pacing or had a monomorphic VT to begin with were excluded. So answer is simple.
Yeah.
So if you exclude this group, the ATP is going to be less.
Yeah. So there was some selection.
So where shock therapy
selection bias and small number of people.
So subcutaneous ICD is meant for where shock only therapy required, like VF, polymorphic VT, channelopathies, or Brugada syndrome, hypertrophic cardiomyopathy, where polymorphic VTs are more common. So another thing is that in Praetorian trial, the oversensing because of T-wave oversensing is more common. Inappropriate shock is mostly because of T-wave oversensing. I think new algorithm will change it.
The PA oversensing almost 15% in the Praetorian trial.
About the extravascular ICD, the major problem is atrial oversensing. So they have now new programming done in such a way so that atrial oversensing is not done. Because you are on the atrial lead, sensing electrodes is also on the atrium of the atrium of the heart.
So they have two coils, I think. So if coil 1 is oversensing the PO, we go for the coil B. But most of the time, the coil, I think one of the coil is very important. Yeah. If one coil is oversenses something, then do go for the second.
Now they have modified the programming so that they senses P atria as a P, so that it is not counted as a VT.
Right.
So I think I'll invite Balbir sir to have a talk on remote monitoring. That is another new thing which is there for clinical follow-up of patients. So it has been used extensively outside, but in India, I think sir will have good experience. So we'll hear from sir what sir has to say.
So thank you, Dr. Dilip, for having me here. So let's look at a new era of remote monitoring. So we understand that as we grow with AI, as we grow with smartwatches, phones, we are going to have a huge population which will want even health to be on the remote monitoring. So in India, by 2026, we'll have 1 billion people on a smartphone. So benefits are that we can access data quite fast. We can have a medical care person collect this data, analyze them, and use for the patient benefit. So in the 2021 guidelines by the FHRS, IBHRE, it has been emphasized that these devices, digital data devices, are going to be the future. But have they helped? So we had data from the previous generation which were not mobile-based, which were not Bluetooth technologies, which was Merlin, which was kept at home, and sometimes it would travel with the patient. So there was some limitations of these technologies. But even then, they showed that there was 34% reduction in all-cause mortality over 3 years by using this remote monitoring. And in ICD patient, 50% lower risk of all-cause mortality, which was huge data. And this led to people thinking of more trials. And this led to Merlin clinical benefits, which again showed that if you have a remote monitoring devices, the longevity is much better. All-cause death, even the all-cause death was better. So now there were more trials, and data started emerging that remote monitoring is important. So look at this divergence of these curves right at the beginning, tells you that the benefits are huge. And so are the CRT patients, and the data was building up at that point in time. And many trials showed, including the altitude trial, the benefits. Also came in that, does it reduce the healthcare cost? It did, because the ER visits were reduced for something which wasn't there, and the patient was trying to reach the ER. And hospitalizations were also reduced because you could advise medical management on the remote monitoring system. So this healthcare utilization also helped. So arrhythmia management, improvement in detecting heart failure, early detection of heart failure, malfunctions, led to reduction in office visits and emergency room visits, leading to cost effectiveness. So this is the value of remote monitoring. Now, once this was known, what did HRS do in 2023? Put it as 1A indication. So they said in patients with CIIDs, remote monitoring is recommended as a part of standard of care. So to put it as 1A means that you need multiple large randomized trial. And this is a huge indication, remote monitoring for these devices. But as the things improved, we got implantable devices on the patient's smartphone with an app, which led to going to the clinical portal. And this was the next new thing which happened. So what it does is that patient has the device. A patient used to earlier have this transmitter, now doesn't need it. Now the mobile phone acts as a transmitter, goes to the clinical portal, and then to the physician clinic. So this is the loop, and which is very simple. A phone lying in the patient's pocket is enough. We could get these as non-continuous detections of the device, or a continuous detection, or alert-based. So what mobile phones have done is led to a continuous connectivity, led to an alert-based connectivity with the physician. So in a scheduled transmission, we set it at, say, monthly. At 1 month, the transmissions come between 2 a.m. to 10 a.m. in the net clinic. In the patient-initiated, patient can actually activate any time. He can activate, he's having symptoms, he can just press the button and his device data is transmitted. And then we have the alert initiated, which happen automatically for some alerts which are set in. So this Bluetooth technology helps us look at these 3 parameters: patient symptomatic setting in, continuous monitoring every month, and also the alerts. So this was our first in Asia implant, which was just before the COVID lockdown happened in the February of 2020. And this was the 4th in the world of a Gallant device. And this was the first implant in Asia and the 4th implant world over on 28th February 2020. So this device could collect data and send it to us. And since then, there have been many countries which have adapted this technology. And early global experience versus Indian experience was quite satisfying. So the question came when this device was introduced to India, there are so many people who are staying in remote areas. Will the connectivity be as good? And we'll be surprised to know that it is better than many other countries in Asia. So the level of satisfaction you can see is pretty good. And you know that mobile technology is now everywhere and we have such good networks. So the satisfaction level is almost 100% with most satisfied and extremely satisfied people. And you can see the app usage was quite frequent in the Indian patients, and the compliance to the look at all the green signals, the compliance was excellent. So this led to the idea that this compliance is going to make all the difference in mortality and patients coming up early. Now we have, which we have also started implanting in India, wireless loop recorders. So this is the Confirm RX device, which is also similar to a ICD or a CRTD where it transmits data. So these are the 4 pages that you look for when you get this data. The fast path summary, exactly like what you see in the programmer. Diagnostic summary, exactly like that. Episode summary, and the EGM. So when you see the printout, it looks as if somebody has taken these printouts with the programmer. So clinical alert management. So we can set the alert. ICD shock is high alert, so it gives the red signal. Low battery is high alert. High low impedance is high alert. And these are yellow alerts, high threshold or anti-tachycardia pacing. So you will get one of these 5 alerts will come straight as an alert to you, even the patient didn't know about it. Like for example, one of our patients, we got this alert, 3 or more VT/EF in 24 hours. So this was alert generated, patient's phone number comes, you can call him up. One patient had a VT and it was an incessant VT. He was traveling on a train. When he was called up that you have a problem, you need to come. He says, I am asymptomatic. And the device detected an incessant VT at 140 and he was called for a further procedure. So this is important to understand that we need to program the alerts well for the patient. Let's look at one example. This is a 50-year-old lady, ischemic cardiomyopathy, LBB, undergoes a CRT with a Gallant device. And she's on a remote monitor, 1 month remote transmission, asymptomatic. And then we suddenly get an alert. So the alert says that LV lead impedance high, not pacing. And this is when we called her, she didn't know anything. And we called her, please come. And this was the lead position of the LV lead, which was repositioned and 6-month follow-up, no alerts in her case, and she did very well. Her ejection fraction improved to nearly normal. So this alert would have led her to come, would not have led her come to the hospital, maybe should have come 3 months later. And there he could call her fast. This is AT-AF detection, and this patient again was asymptomatic. We called him up, started anticoagulants on the phone, and then scheduled his visit. But with the meantime, he started getting more episodes. The episodes increased. You can see the frequency. This is all through the remote monitoring. He's not presented to the clinic. We called him up for an ablation, after which an ablation was done, and he's asymptomatic. This patient was from Iraq. And during the COVID times, again got an alert, and he had multiple episodes of VT. We told him to get admitted somewhere in Iraq, and such a catastrophe could be avoided. Another patient, post-op CABG, ICD for a primary prevention. We were not expecting this, a monomorphic VT, multiple episodes. You can see multiple episodes of VT. ATP was working, so he was fine. He didn't know about it. Called for an ablation. After increasing in drugs, we called for an ablation, which was successful. We ablated his circuit, and since then, no episodes of VT happened in this patient. So I'm showing examples where patients were asymptomatic and went for a procedure. As we move into the future, we'll have multiple monitoring devices. There'll be multiple parameters which will come in. How will the healthcare system cope up with these? Is going to be the next big question, that patients are sending huge data, and how do we cope up with this? So we started a study on remote monitoring system and trying to compare in a non-randomized fashion against conventional devices. And we have now a large number of enrollments in this trial, more than 600 at the moment. And it should end very soon. The target was 788. We are close to 600 now. And we should be able to complete this trial. So these are the centers which are contributing data to us, and we hope to complete this trial and give some answers to what questions we have for this patient. So in summary, I would say remote monitoring is a great advantage, and we have all the randomized data pointing towards benefits in reduction of mortality, emergency room admissions, office follow-up visits, and can help patients in a big fashion. Thank you very much.
Thank you, sir. So one thing, what percentage of patients will be on remote monitoring as of now?
So in our institute, about 50% are on remote monitoring. The reason is cost, nothing else. We offer them the remote, and they have a choice whether they want to take. So in my institute, 50% are on remote monitoring.
I remember one patient I had, an orthopedic surgeon from Murshidabad. I had implanted a CRTD, and then I got the transmission that he is having multiple episodes of VT, and then he was reluctant to come, and he didn't come to Kolkata. So we increased antiarrhythmic medication from here only, and someone from there, a local cardiologist, saw, and still he did well, but later on he succumbed. So device, like home monitoring is a really wonderful technology. We come to know the patient is far away, you tell them and try to adjust the medicine, at least he is not coming. Thank you, sir.
Thank
probably you. In the future, probably when CSP monitoring comes with the ECG integration, that will be better.
Yeah.
So sir, what are the particular group of patients we would prefer or advise? Which group of patients who are vulnerable, who live in remote areas, and particularly what are the, just identify those categories.
Yeah, this is a good question. So if a person is less likely to come to your follow-up, remote monitoring is the most useful thing. Second good thing about remote monitoring is it keeps the patient involved in his own healthcare, because he's happy to see his own data, he's happy to send the reports. This is the second thing. Third thing is patients who are likely to receive more shocks or likely to have atrial fibrillation should be better managed with remote monitoring. But pacemakers also have remote monitoring, but I'm not too keen to use pacemakers for remote monitoring, because they do very well without it. So you call them for 1 year follow-up, and you don't need it. For ICD CRT with LV dysfunction, particularly, these devices are very useful.
Thank you, sir. Thank you. Next, I think we have case presentations.
Yeah. So we have next presentation is Dr. Shamshad Alam. So we have case presentations, and then Dr. Suvridip Datta, and then Soumyakanti Datta. So this is how the flow
will be. Good morning, everyone. So, being a non-EP center, we started our conduction system pacing almost 2 years back. Day by day, we went on learning, and initial days were difficult for us, and we thought that no, we need an EP guy. Initial few cases, for 5-10 cases, we called some EP guy to get it done. The more difficulty we faced, those where we were implanting for a CSP in place of a CRT. Cost is an issue in our state, so that's why we are now preferring CSP in place of CRT. So why LVB pacing? This is very obvious. The previous discussions have been quite very much elusive regarding this, and day by day we are getting it to be a replacement for CRT if we are getting the adequate ECG parameters after implantation. So one thing, when we started this, it was a paper published in IBHRE, and this was very helpful for us. Initially, when we started, we thought that left bundle branch pacing is very important. But now it turned into left bundle branch area pacing, which comprised of left bundle pacing, fascicular pacing, anterofascicular, posterior and septofascicular, and left ventricular septal pacing. Morphologies, it is not always possible to get all the morphologies of left bundle pacing. So these are the techniques which you use, the steps, different steps, and this paper gradually it made it very simple that these are the steps you have to follow. It is not always that you have to meet all the criteria. You just follow the step-by-step protocol which is described in this flow chart. And finally, if you fail, you can go with a deep septal pacing. These are the ECG changes which we gradually get, and these are the different morphologies of ECG changes in different leads when we pace the left bundle branch, left fascicle, whether anterofascical, septofascicular, and posterior, and finally left ventricular septal, deep septal pacing which we get. Starting from the first case, this was the case of a LV dysfunction, left bundle branch block patient was having, and the QRS was almost 140 to 150 millisecond. We had an electrophysiologist in-house on that day for a workshop. So we planned with a left bundle area pacing. It was very difficult. It took almost 2.5 hours to localize where we can get an effective ECG. We were unable to get an effective ECG morphology all over the septum. So finally, this was the ECG which we got, and we settled that no, QRS, we have settled the QRS, it is almost 110 millisecond hardly. And finally, we planned that it was suggested by electrophysiologist that two things have to be done. We have to increase the dose of the beta blockers so that the intrinsic conduction, which is occurring simultaneously, it has to be superseded by our pacing thing. And to my surprise, the LV function improved from 25%. Currently, it is almost 45%. This patient has almost elapsed 2 years after the implantation of the device, and she is well maintaining. Her functional status has significantly improved. So it is not necessary that you get a proper morphology in ECG. You get an QRS narrowing, you get a good LVAP. That is very important. This is the second case. This patient presented to us with a sinus arrest, syncope. The first time when echo was assessed, the LV function was hardly 20 to 30%. It was corroborated that it might be due to prolonged CPR, which was done to this patient, or it might be due to a persistent LV dysfunction previously. But to our surprise, we did a conduction system pacing to this patient. Coronaries were normal. Before pacing, we performed this, and we thought that this might not be an ischemic cardiomyopathy. And this was the ECG pattern which we got. And still we were confused that LV dysfunction for which we did it was a true LV dysfunction, or it was a transient CPR or metabolic parameter induced LV dysfunction. But anyways, this patient improved. It improved in it took hardly 3 to 4 weeks in follow-up to improve her LV function. Currently, her LV functions are completely normal. The duration which has passed it is almost 1.5 years. Now, this is the case 3. This thing we implanted in a patient with a normal LV function with left bundle branch morphology. This was the ECG pattern. One thing which was surprising to us that unipolar versus bipolar. When we checked the parameters during implantation, we got very good ECG morphologies, good terminal R wave in V1, the LVAT were very good. But after slitting the sheath, when we calculated that QRS and the different morphology in bipolar mode, that was not that much significant. So finally, our plan was to keep all the conduction system pacing on unipolar mode, which we usually do. to have that persistent ECG morphology. And second thing, when we check the parameters during implantation, the QRS morphology on only ventricular pacing, we are very successful in getting that in almost 90% of our cases. But when we change it to a dual chamber pacing modality after implanting the right atrial lead, when we have slitted the sheath, the change in the morphology we usually get. And finally, most of the cases we conclude that this is an intrinsic conduction also which is occurring. So let's increase the dose of beta blocker, and gradually we follow the device programming, and we have to change the output of the for the left ventricular lead. So we have progressed further. We have progressed to the other leads apart from Medtronic. Medtronic we use that lumenless leads we use in our most of the cases. This was the case. Basically, this was the case taken for CRTD implantation. It is a case of ischemic cardiomyopathy. LV function were hardly 25%. It was left ventral branch block morphology. Almost the QRS was 150 to 160 millisecond. So coronary sinus cannulation we failed. Once we cannulated, the coronary sinus was dissected, but again we recannulated it, and we were able to cross the wire, extra support wire whisper, followed by all-star wire, but we were unable to negotiate even after the use of subselect to the required coronary sinus branch. So finally we shifted this patient to a left LVB dual AICD. And the morphology which were very good, and it was surprising. We got the very good morphology, and we thought that why should not we have thought initially to do a LVB dual chamber AICD for this patient. This patient is doing good, although LV function have not significantly improved. Ejection fraction, his ejection fraction is currently almost 30-35% only, even after medical therapy which he was continuing, and it was escalated. This patient again, it was a this was done for LV dysfunction, and obviously this patient was unable to afford it. Even he was unable to afford a D. He was a post-CABG patient. Ideally, we should have implanted a D, but he was unable to afford. But anyways, we have asked them to let's do something to improve your LV function, and this was the morphology. His QRS was not an issue. QRS duration was almost 130, 135 millisecond only. So we got a very good narrow QRS after doing this his conduction system pacing. Currently he is doing good. He is almost 76, 78, 77 years, and symptomatically improvement has been occurred. Now let's coming to this last case. Basically this case was just like a challenge for us. A patient who was already on dual chamber pacemaker, a conventional pacing was done. We took him to upgrade it to a CRT-D. He was having VT for which he was admitted. LV dysfunction was there. That might be due to a pacemaker induced LV dysfunction, because this pacemaker was implanted almost 4.5 years back only. So we planned that we will do a left-sided complete device implantation, but it was surprising that there was a persistent LSVC. Previous records were not available to us of pacemaker implantation, so that's why right-sided implantation was done. And it was a big coronary sinus. We were unable to delineate any coronary sinus branches. Angiogram was done earlier, but a significant coronary sinus branch we were unable to see on the angiogram. So we plan to do it, a redo device from the right side. We plan to convert it into CRT-D from right side. The first issue was we were able to puncture this is subclavian vein, but we were unable to negotiate catheters. We were even unable to negotiate our sheath for AICD lead. But gradually, after we dilated that with coronary balloons after passing out wire, and then we were able to negotiate initially the AICD lead. Further on, we tried to cannulate. Our CS and see if we can see any alternate branch which might be arising just beside CS, but we are unable to negotiate our CS sheath through that initial part of the constriction of the subclavian vein. at the site of anastomosis. So we finally did a conduction system pacing, and we finally converted this patient into a left bundle dual chamber AICD, and this was the ECG which we achieved. Although the results were not very much satisfactory for us, a terminal R wave was observed. QRS duration, on conventional dual chamber pacing, it was almost 184 millisecond, which we were successful in decreasing it to almost 130, 140 millisecond. Thank you.
Thank you, Dr. Samsad. Moving to the next presentation, I would like to ask Mr. Subhadeep to come to the dais.
Hello. Good afternoon, everyone. I will be, I think whole of the day there is lot of knowledge we all gathered about the CSP and left bundle branch area pacing, all the parameters, electrical parameters, what we have to see. So I will not go into the detail. So I'm very thankful, Dr. Dilip sir, to give us both me and Dr. Anand, who is on stage, to give us the opportunity to show some cases done by our team in our hospital. So I will be presenting 3 cases. So 2 cases are very basic cases that we are doing on day-to-day basis. So this is our case 1, the 68-year-old lady with a LVEV, morphology QRS duration of 152 milliseconds, with intermittent CHB with a history of multiple episodes of syncope. So on echo, there was EF of 40% with the global LV hypokinesia, and CAG was showing normal coronaries. This was her ECG. So, what can be done for this patient? So as EF is on the lower side, 40%, and as we can see, the anticipated ventricular pacing will be very much high, at least more than 40%. So we have options for conduction system pacing, and according to the last 2023 HRS consensus guidelines, we can opt for BIV pacing also. So we opted for conduction system pacing because in our state this conduction system pacing is more economical. So we gone ahead with the conduction system pacing, and we got these results with QRS narrowing of, and as you can see, it is come down to 120 milliseconds, and patient is doing well. After 6 months of follow-up, patient is doing well, and we have seen also improvement in her LV function. So coming to the case number 2, this patient is a 42-year-old male patient with a diagnosis of dilated cardiomyopathy, with a EF of 28%. As we can see, QR is prolonged, it's LBB morphology with around 180 millisecond. And despite OMT, he had 2-3 episodes of heart failure hospitalization. So, in this scenario, I will ask Dr. Anand also, as there are options for, we can go for conventional CRTP, and there is option of left bundle optimized CRT, or we can go for conduction system pacing only. So after discussion, so as the patient's age is very less, so we want to give him the best benefit. So as much as we can narrow down the QRS, so he has a long life to live. So after a lot of discussion, we proceed for left bundle branch optimized CRT, and we got a very good result with QRS narrowed down to around 130 milliseconds, as we can see. So this patient is still under our follow-up, and he is also doing well, and his EF improved up to 40% on subsequent echo after 6 months of follow-up. So last case, so this is a bit atypical case, not atypical, but a different normal day-to-day cases what we are doing. He's a 56-year-old male patient with a exertional shortness of breath of NYHA class 3 with a LVEV of QRS duration of 158 millisecond, and he is having a long persistent AF, and which is tried with lot of rhythm management drugs and all optimized drug, but he has having that persistent AF for long with the dilated LV cavity with the EF of 28%, and CAG was normal coronaries. As we can see, the QRS duration of around 160 milliseconds. So, we also, these are the options we have. We can go for AF ablation, or there are options of CRT or AV junction ablation followed by a CRT, or AV junction ablation followed by a left bundle bunch optimized CRT. So we discussed with the patients 2-3 times regarding for proceeding to AF ablation. We have given option, but we have also discussed regarding first we can go for an AV nodal ablation followed by a mandatory BiV pacing. But actually patients and patient relatives, they were not willing for a double procedure, and there was also economical constraint. So we first did with the AV nodal ablation, and then we did the CRT, lot CRT, and this video is not that much good, but after a lot of difficulty we faced during placing of our LV lead. After a lot of difficulty, we placed in middle cardiac vein, and afterwards we got a good result, as we can see, and we also see improvement in the ejection fractions. It went up to around 30 to 40%. Thank you.
Thank you for your nice presentation. I would like to ask one question.
If we can open the discussion a bit. So last patient had a LA size of 5.2 and a persistent atrial fibrillation. So who would go for a AF ablation in this patient? Anyone? So I think these are the situations where we can look for junction ablation and lot CRT preferably, or maybe a conduction system pacing, even not going for a left bundle coronary sinus pacing. And this patient really improved, like from 25%, 28% to 40%, and after that the patient never had to be hospitalized again. So we have done around 3 such cases with atrial fibrillation, with white QRS, with normal coronaries, and node ablation with lot CRT, and all of these patients improved.
Thank you, sir.
Thank you, sir.
Thank you, Sudeep.
Now, what is the scope of AF ablation? What is the scope of AF ablation?
Yes, it's because the LA size was very large, and so it's a persistent atrial fibrillation. So it's already a persistent atrial fibrillation. Chance of success of AF ablation is very less. We can try, but this is a viable option.
The trial has been done, PAVA CHF trial, where they compared AV node ablation versus AF ablation. AF ablation and biventricular pacemaker, and AF ablation with AV node ablation. What they found that the result is better if they have done the AFib ablation without AV node
ablation. But here the LA size was quite large, 5.3.
So good afternoon, everyone.
As today's long discussion, we have already in light that we all know the indications of CRT, HEES, CRT, conduction system pacing, LV area, lot CRT, and all those things. So my case is a simple one. I will not know the conduction system till now. But the most important thing, I had a case that has LMCA to LAD stenting, and post stenting he had an extensive enteral MI. Almost ejection fraction has come down from 35%, and after ERNI he was still in heart failure. It improved from 35 to 42% around. It is hovering around 40 to 42%, and on Holter monitoring he was having 2:1 Mobius type 2 AV block with the underlying LBBB. That was a new onset while he had an MI. So you all know the indications of CRT, that is a class 1 indication of QRS duration of more than 150 millisecond with a NOIHA class 2, 3 or ambulatory 4, and obviously ejection fraction less than 35% with a wide QRS. But in our case, the LBBB was around 135 to 140 millisecond, and the ejection fraction was hovering around 40 to 45%. So we decided to go as according to the criteria we all know is it has to be either his CRT or the his bundle pacing or the lot CRT in that case. So ultimately the patient could not afford that lot CRT that we prescribed him the first, and ultimately he decided to go for a dual chamber pacing only because that could be the only affordable thing. But we were afraid of increasing the LV dysfunction again, so that's why we decided to go for an LV area pacing in that case, and believe me, ultimately his ejection fraction improved a lot after that LV area pacing. So definitely before going to the conduction system pacing in LV area, we have to take a proper echocardiographic report and proper analysis of the ECG and other tools of conduction system pacing that was done in the cath lab. So we proceeded with the Abbott system, that is a helix locking tool with the tender lead and CSP locator. So ultimately, in the echocardiography, the septal thickness was till 11 millimeter even after the MI. So we proceeded for another 8 to 9 millimeter deep into the septum. This was the ECG first, the LBBB with the underlying of Mobius type 2. You can see the 2:1 AV block, and till now the patient was asymptomatic. He had a syncope 1 year back when he was stented, but ultimately he had a recurrent history of heart failure, and even the ejection fraction was around 42%, 42 to 45%. So this was the pace mapping ECG. We can see that was an LBBB, and if we see there was a notch in the 2-3 AVF also, and typical of RS-RDS pattern in the RBBB was not there, so it was a QS complex. We decided to go according to the anatomy by a contrast injection. The septal localization was done from bottom to up. We decided accordingly, and after that there was a helix screwing lead that was inserted from the right side to the septum with the stellate driven leads of the Abbott system, and ultimately continuous monitoring of the impedance, because we had a chance, because it had an MI background, it had a chance to perforate also, so we go quite slowly in that case while checking the impedance all throughout the screwing, and ultimately we landed in the proper LB area. It was a good ECG. You can see that the QR pattern in V1 with a unipolar 5 volt, obviously 4 millisecond of LVAT of less than 90 millisecond. So it was a good ECG, and ultimately we had an improvement of ejection fraction, and the most important thing, within 3 months of the implantation of that LV area pacing, he had an improvement of the ejection fraction from 42% to around 52%, 50 to 52%, with a narrowing of the QRS complex. You can see it was almost 140 millisecond, which landed up in the 120 to 110 millisecond, and the QS complex in the V1, and obviously there was a notching in the inferior leads too. So today's take-home message from this scenario is that in those patients who could not afford the HIS CRT, who could not afford the lot CRT as well, and obviously the conventional CRT, even in the post-VCI, specifically with the left main critical lesions, and those patients who have a ischemic background too, this kind of LV area pacing helps us a lot in preventing, not only preventing lives, but also improvement in the ejection fraction and improvement in the heart failure status in the ischemic background. Thank you very much.
Thank you for your nice presentation. I will request Dr. Manak Mukhopadhyay to come to the dais, please.
It's so good to see so many operators are there for conduction system pacing now in Eastern India. Manak is a mature operator of CSP. He has been doing for the last couple of years. So he'll presenting case Soumya Kanti showed such a nice case from stellate driven CSP. To begin with, stellate driven is little difficult to take up.
Good afternoon, everybody. I am grateful to Dilip sir for providing me this opportunity to present my case. My case is relatively simple. So let us just start. It's a CSP, a holistic approach where there is a synergy between image and current. So my case summary is just like this. It's a 65-year-old gentleman. He's a non-diabetic, non-smoker and euthyroid, hypertensive on regular medication, presented with recurrent syncope with also history of dyspnea on exertion. There was in the ECG baseline, there was LBBB with a duration of around 100 milliseconds, whereas in 72-hour patch Holter showed a multiple episodes of AV dissociation CHB. Echo Doppler done showing a 43% ejection fraction, which corroborates with mid-range ejection fraction heart failure. There was raised NT-proBNP and normal electrolytes and renal parameters. If you can see the ECG, that this is an LBBB, but not that wide. It is something around 100 milliseconds. Now this is the baseline echo. You can see over here, the LV systolic function is compromised, and there is at least a moderate grade of mitral regurgitation, and septal thickness was around 11 millimeter. And this is the extra advantage that we can get when we are doing the advanced imaging in this group of patients. Here you can see where the regional mechanical heterogeneity, if you can see in all these panels, be it apical 4 chamber or 2 chamber or 3 chamber, there in all, if you assess each image in the right upper part, there is a complete heterogeneity of the contraction that is in support of the extreme dysynchrony in this group of patients that we can see. And this is a strain imaging. You can see there is a very significant amount of the decrease of the strain value, particularly in the septal and the inferior and to some extent in the posterior part. And the right lower panel is the extra another advanced imaging, that is what we call the time to peak. That is from the onset of the QRS complex to the extreme nadir of the strain, that duration what we has been assessed over here. And from this image we can generate, that is the peak strain duration, that is the PSD, which is around 150 millisecond over here. In normal human being, it should be below 60. And here the red color means it is the much extra duration of the time which is required for the depolarization of the zone, that again corroborating with the LBBB. Now that has already been discussed by the Sanmuga sir in the Madurai LBBB study, which was an MRI, cardiac MRI based study, that the ideal position to put the lead is something is around this zone 2 and the zone 3. And as per the 2023 HRS guideline, my patient is having a 2A level of evidence to undergo for the CSP. Now this is the procedure in a nutshell. Our lab is a non-EP lab, and unfortunately on that day the 12 lead ECG panel was also not available from the TMT lab. So hence we had to undergo just the bedside ECG that I have already done quite a number of cases even in that setup also. Now, most of the times I do use this lumenless Medtronic lead. The sheath is the C315 His conventional sheath of the 7 French outer diameter and 5.5 French inner diameter. And the lumenless lead dimension is something around 4.1 French. So the procedure was done. The sheath was placed properly both in the LO and the RO. It has been checked. And the lead tip is made just outside the sheath tip, and to assess for the initial currents from the septal depolarization from the right side. And after the confirmation, then we should go for the septal penetration. At that point, most of the times I do follow the template VPCs and along the VPCs changes over there. And then the septal penetration was done conventionally. Always I do check with some dye also, lead in the RAO, and then the sheath removal. And then just to adjust the lead loop, and also to adjust the lead loop in the LAO, both in RAO and LAO. Then the atrial lead placement, and that's the final view. So these are all very simple things, but the interesting thing is this post-CSP ECG. Now you can appreciate that the ECG, which is paced ECG, it is almost similar to a normal ECG. And in the lower panel I have shown there is an on-off phenomenon. There is sometime when I'm offing the machine and then I again owning the machine, you can see the beautiful transition from relatively wider to the extreme narrow and normal complex. Now 3 months post-CSP echo, you can see over here, the yellow circle is showing the tip of the lead, and the contraction has improved markedly. And here again the post-CSP regional mechanical heterogeneity, if you can assess here, you can see At the initial, there was so much heterogeneity, but at present, there is such a beautiful homogenization of the electrical phenomenon leading to the mechanical synchrony in this group of patient. Again, if you can see the post-CSP strain imaging, there is a beautiful improvement of the strain along with the post-CSP. The time to peak has also improved with a beautiful green or more green heterogeneity has been abolished. There is a good synchrony of the entire mechanical contraction of the different regions of the heart. And if you can compare, the left side was the pre and the right side is on the post. In the pre, you can see again those different color graphs. There was so much heterogeneity, whereas in the right, there is so much homogeneity. So that is how the CSP actually improves the synchrony of the heart. Again, the pre-post strain comparison along with the time to peak, again you can see in the images that how beautifully the synchrony been achieved through this CSP. And again, if you can compare the pre-post echo, the mitral regurgitation has improved quite significantly, also the contraction pattern, and all these things could achieve within a very fast 3 months. This patient also underwent CAG after the pacemaker implantation because he was having the dyspnea on exertion. And I have just incorporated these images because there was a normal CAG and also just to adjust our eyes along the actual location of the CSP lead. So the take home is that the basic concept being a medical science healthcare worker is first do no harm, which particularly holds true in case of the CSP implantation. And CSP improves the electromechanical heart holistically, and CSP should ideally be done in the EP lab for the best possible result, but it is also doable in non-EP labs too. Follow-up of my patients over the last 6 to 7 months has been completely uneventful. Thank you.
Yeah, thank you, Moinak. Is it audible? So, wonderfully done case, and you showed us the, the strain corroboration as well, which is important. Now, according to you, what are the ECG parameters that you look into immediately post-procedure in order of priority, which will predict you long-term success in terms of ejection fraction improvement? You have number of criteria, ECG criteria. Which are the ones you take into account?
Sir,
not
only ECG,
all the criteria.
Not only ECG, I will incorporate all the clinical parts because in the initial echo, I have seen that there is no significant amount of scar, and RV systolic function is also good. So for this kind of patients where there is no ischemic background, I will always think about a good amount of improvement of ejection fraction in this group of patient. And regarding the ECG, obviously the QRS narrowing is important, but along with that, we should also stick to the proper morphology achievement during our day-to-day procedure. Because it is also true that what Dilip sir has told, is almost in around 20% of the cases we are not being able to achieve the classical QR pattern in the V1, but at least we are able to achieve the positivity in the 2, which is very important, that the lead 2 positivity more than the lead 3, and also the AVR and the AVL discordance is also very important.
I have a question. If the ECG shows LBBB morphology and QRS duration is 100 millisecond, can we call it LBBB? Or should we name it something else, like, say, left axis?
You are calling it, no, you are calling it LBB morphology, not LBB.
Morphology.
So, in the term coinage itself, you are showing that it is, morphology is there, but it is not complete LBB by definition, as you are showing by the definition. Duration is not there. I think Moinak can elaborate more.
Yeah, actually the
so
last...
We should, basically, we can call it either interventricular conduction defect or left anterior hemi-block or even, yeah.
Sir, actually 2021 Strauss criteria, as per the Strauss criteria, the classical complete LBBB is we are supposed to define the duration should be more than 120 milliseconds. But again, that is for the typical LBBB. There can be other cases where there is atypical LBBB where the QRS duration is relatively narrow.
So that is incomplete. Incomplete LBBB.
Incomplete LBBB.
So thank you, Mainak. I think it was a great discussion, and thanks Dilip and Dr. Anand. So we can move on with the next session, and this is a penultimate session, and we have the 3 presentations here. Somyo is not there, Dr. Balbir has already done. And may I invite Dr. Arup Daswiswas, our teacher, Dr. Dipankar Mukherjee sir, and Dr. B.R. Nath and Dr. Kashinath Gusajra sir to be there, dais as chair. So we have a last session which is dedicated on brainstorming amongst ourselves, how we can generate data and evidence, since we are doing conduction strap pacings, leadlesses. So we have Mr. Sumit Anand, who is involved in all this kind of research activity from Abbott of Southeast Asia, and he will be talking to us and giving us some suggestions how we can generate and streamline data keeping and come up with some good presentations and publications.
Thank you. So we are going to mixed kind of potpourri of sessions, but the ultimate end goal is patient benefit and patient care. So Balbir's presentation has already been made. So may I invite Dr. Sanjeev Mukherjee to present his case. It's not a case really, it's CID's infection management, our common problem.
Thank you, sir. Respected chairpersons, my dear friend, good evening. I thank Dilip for organizing this. So in the next few minutes, I'm going to talk on this very important topic, CID's infection management, standards, care, and new advancements. So I think I'll be brief. So obviously we need to understand the problem. Now CID infection is a problem, about 1.5 million devices are put every year across the world. And about 1 to 4% will present with infection. So all of us who are implanting devices are going to come across this problem, and we all face it. And therefore, we should be aware about what needs to be done. Look at the mortality, more than 3 times. And the best part is about 20 to 50% of these patients are predisposed for infection. So we have a chance to pick them up and probably treat them and avoid them getting into infections. So these are some of the important points that we need to discuss. There have been now a lot of studies. There have been recent 2 randomized controlled trials. One is PADIT, which looked at antibiotic use in device infections. And the other one was RAPID, which used antimicrobial envelope from Medtronic called Tyrix, and did show benefit. So we need to be aware of these data that have come up. Role of TEE, it has become very, very important now. Now, when we talk about CID, you will have to talk about TEE because of the reason that you need to look at vegetation, whether the lead is involved or it's only a pocket infection. So you need to do TEEs. The role of FDG PET has become very important. In an entire day of discussion we were talking, and there were some talks about FDG PET. Now it is a very important thing when we talk about CID infections. When you see a CID, please remember that you should not forget about infective endocarditis. It is now a minor criteria in Duke. So when you see it, look for valves because the valves might have developed vegetation. So its IE must be kept in mind. Role of leadless pacemakers and ICDs, sub-Q ICDs have been discussed today. They are options when you have got recurrent CID infections. And of course, newer devices like mechanical aspiration which have come up, which have got roles mainly in the right-sided vegetations, which something acts like VV ECMO, takes out blood, takes out the vegetation, and it has got some role. Now let's look at these scenarios. Now if you have got this kind of a presentation, there is no doubt, no confusion about using antibiotic. The device has to come out. This is clear-cut pocket infection, device has to come out. The only confusion happens when you have got this kind of a presentation and you all see it. Now, like in the first case, you have got a voluminous collection. Now, if this patient has got fever, if this patient has got any features of inflammation, this device, this pocket has got infection, device has to come out. The second shows a very small inflammation with some leak, and many will say, okay, let's try an antibiotic. But I'll say focus it slightly more and you'll realize that this inflammation is not on the line of incision, but it is on the course of the lead, on the sub-Q course of the lead. And this particular kind of infection, if you see this inflammation on the course of the lead, the device has to come out. This is pocket infection. The last is again same, where the incision line has got adhered with the device, patient has got inflammatory features, pocket infection, device has to come out. So many a times we keep trying antibiotics, but I think it's important to look more carefully. Now these are some of the modifiable and non-modifiable risk factors. I'll not go much into detail, but we all know that very well. If somebody has got a skin lesions, if somebody is on anticoagulation, if somebody has got an abdominal pocket, if there are prior procedures, prior infection, these are all modifiable. There are non-modifiable like immunocompromised patients of diabetes, ESRD, patients who have got multiple leads. When you're going to do a pocket change, a lead repositioning, all these predisposes a patient to infection. Let that be very, very clear. And certain points on down helps you, kind of avoid that. Postpone procedure if the patient has got fever. Treat comorbidities. Make sure diabetes is well treated. Make sure if the renal failure is that is well treated before you take him on the table. OSCs should be uninterrupted. Don't stop the OSCs. Continue and then do a device rather than doing, because bridge trial has shown that if you take them on heparin, you're going to increase bleed. Hematomas are very, very responsible for infection. So avoid hematomas. It's always better to reduce procedure time scientifically. Limit the number of persons who are there in your cath lab. Reduce the numbers who are inside the lab. There should not be crowd. Surgical field which should be well prepared. Make sure that IV lines are reduced. There are not a lot of patients will have multiple lines because they are in intensive care units. Reduce their lines before you take them for a procedure. Try to avoid using TPI leads if you think they are not required. 6 sinus or somebody transcutaneous support can be used to avoid TPI leads, and evaluate the need of Tyrix or antibacterial envelopes, because now that it is available, you can use it. Pre-procedural antibiotic, yes, very, very essential. Must use it, and consider leadless when there are recurrent infections. Very quickly, some of other tips that I will say, chest preparation. Make sure clippers are used. Once clipper should be used rather than shaving with a razor. Antibiotic, give only cefazolin, fair enough. Flucloxacillin is good enough. Staph aureus coverage is enough. Vancomycin, only when if it is an MRSA dominant area. Patient has got an MRSA, think about vanco. Otherwise, cefazolin or a flucloxacillin is enough. Surgical preparation, again, trials have shown that alcoholic 2% chlorhexidine is better than povidone iodine, right? The various reasons they have given, but this is the end line. Try to use non-powdered gloves, because they say that when you use powdered gloves, you cause inflammation, and again, that in turn can result into infection. So again, some data on it. Vigorous pocket irrigation while you are doing. Use normal saline. You irrigate your pocket well. What it does is, it will take out devitalized tissue, it will take out contaminants, dilute them. It again has got benefits as far as data is concerned. Hematoma evacuation. When should I evacuate a hematoma? Only when if there are, if your suture line is threatened, or if the patient has too much of symptoms, that is when you plan for a hematoma evacuation. There are some operators, we have seen that they try to poke from outside. Never ever put a needle from outside. You're going to put in infections, whatever needle you are using. Antibiotic envelope, we have already discussed. Any role of antibiotics in the pocket? Answer is no. Padit has shown that there is no benefit in keeping antibiotics in the pocket. What about capsulectomy? Don't do it. Capsulectomy increases hematoma, again infection. What about closure line? It's better to have multiple layers of closure line because it reduces stress on your suture line. So try using multi-layered closure line. What about post-procedure antibiotics? Padit has shown that there is no benefit. Though we use it, not much of benefit. What is rather beneficial is probably applying of pressure bandage, which they say reduces hematoma. Antibiotics we have discussed. So what do I do? How do I proceed with? If a patient comes to you with physical signs of inflammation and you see that the device, the wound is dehisced, already the lead is coming out, no question, send off to antibiotics, device has to come out. That is what the patient must know. The only confusion comes when there is some amount of erythema inflammation and it doesn't look very serious. That is the only time you're worried. Again, there send off blood cultures. What happens if your blood culture has come negative and if the device has been put it within three months, you can try a course of antibiotic, doesn't work, go for a PET CT, and if the PET CT is positive, again, device explantation. If the PET CT is negative, then probably you can wait for 4 weeks. On the other hand, if it is a dehisced case, there is no question, send antibiotics, remove the device, treat at pocket infection. If your TE or a PET scan shows evidence of inflammation, then it will be treated as a lead infection, and there your antibiotic course is going to be longer. If you have got a valve involvement, your antibiotic will be 4 to 6 weeks. If you have got lead involvement, it's about 4 weeks. Otherwise, 2 weeks of antibiotic is what you should be following. After 2 weeks of antibiotic in a lead infection, send cultures again. If they are negative, that is the time you can plan for a re-implantation of a newer device. So I think any advancements? Yes, Tyrix data has shown that about 40% reduction in infections, 61 in pocket infections, and there was no side effect of this device. Leadless, yes. Why? There is no pocket, there is endothelialization, and 3,000 patients of MICRA and AVR have shown no infection. So you have got definite evidence. And not just that, you can also implant them in a scenario where you have got recurrent infection, pull out the device and put a leadless, and that has been studied, has been shown to reduce infections to a great extent. This is a new advancement I was talking about, percutaneous mechanical aspiration of vegetation removal. Now this happens when you have got a lead vegetation on the right side and you think the vegetation is very big. If it is more than 20 millimeters, if it is between 10 to 20 millimeters and you have got an ASD or a foramen ovale patent, then you will have to use this. What it does is it kind of circulates blood. Veno-venous blood is circulated, reduces the burden of IE and helps penetration of the antibiotic or helps you in removing the device mechanically. Some new advances in pathogen detection, like you have got genetic studies, you have got something called as vortex sonification. You can take the device, send to micro, they will vortex sonify it, get some tissue out of it, and the culture improvement is much, much higher. The amount of culture positivity improves with vortex and sonification. So this will be our take home, if I say, and most of the points I think we have already discussed, and I think I'll end it here. Thank you.
Just one comment regarding the reconditioned pacemakers. There is one study that if you, particularly in our financially challenged nations, where the reuse of the pacemakers, and there is no chance of increased incidence of infection in comparison to the newer devices. And do you have any experience regarding that one?
Yes, so it's a good question. When I was, during my EP, when I was doing with Dr. Narasimhan, they have a very active program where they collect not just pacemakers, they collect ICDs also, which have got good battery life. But the thing is, I think this has got nothing to do with infection because all these devices, they are autoclaved at least 2 to 3 times and then they are offered to a patient. And that's a very good program. And I think it is running in many centers. It's a very good program and there is no increase in infection at least with using these devices.
And it has already been published recently.
Yes, 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 sir. There has been publication.
Published from, Africa, somewhere
yes,
it is being used from US pacemakers.
There were French.
My Heart, Your Heart program.
Yes, yes, but it is not allowed in India.
2 comments to make.
Medico-legally, it is not allowed in India.
No, in India, Dilip, what I'll say is that a lot of centers are running the program. Like Care Hospital, when I was there, they were running a program where the patient's relative who was died, will write and give that I am donating this, and the patient who will receive will also be informed that you are receiving it. So that is how it was working.
But there was an article from Dr. Banja, 1998, from where some of the Chinese centers still they do as a legal, option for this. But that article is clearly stated that in India, the DCGI doesn't allow kind of going for these refurbished devices. This is not legally, allowed. Okay. Maybe if it's mutual consent, if we are doing, not doing, but the onus comes to only operator and who is implanting the device, because in fact this is a practice which is not allowed from the government of India.
Legally not allowed.
Maybe yes, but I think even JIPMER runs a program.
Yeah, in China, they get a lot of China. This is allowed from the government. Okay. In India, it's not. This was discussed somewhere in High Ministry as well as the article, discusses everything.
Okay, okay. But because I saw it, so I thought maybe they would have.
There is an ethical question, but I myself have used and successfully, without knowing the ethical implications and without knowing the rules. But anyway, besides that, 2 comments I want to make. One is a general comment that the aseptic and antiseptic measures I see in the cath labs where I work are not at all congenial for pacemaker implantation. Cardiac cath labs are not sterilized as it should be for device implantations in whatever I have seen. And I could not improve anywhere, anyway. Luckily, we get away without infections. And I have seen infections occurring in the device after 3 years. Patient was all right. Under my follow-up, he implanted the pacemaker in some other hospital, and all of a sudden, he came back with device popping out. I re-sterilized it, I explanted it, and re-sterilized it, and implanted it on the other side, on the same side, sorry, because the leads were on the same side, and he did well afterwards. So it is not only during implantation, you may have infection, but even after 2-3 years, I have seen in my own experience. And number 3, continuation of antibiotics. After implantation, you give pre-implant antibiotics, prophylactic, but continuation, as he said, it is not proven by studies. But which studies? What studies? Are we practicing it in our life? I have not seen anyone practicing discharging patients without prescribing antibiotics. I want some light on this. Which study?
Yeah, so as I said, sir, this padded trial which has come, it's an RCT, and it has shown that there is no benefit in continuing post-procedure antibiotics. The stress is predominantly on pre-procedure antibiotics.
No, that may be in US or Europe, where they do not use sometimes even prophylactic antibiotics.
No, sir. There is a definite indication
Actually,
of
pre-procedure is definite indication is there.
indication of pre-procedure antibiotic.
Yes.
And that has to be 60 minutes prior to the. You know, that is very important.
Yes.
Everyone should note
60 minutes before the incision.
Before the incision is given.
Dilip,
Just
I have
giving in cath lab
a
and taking the patient to for procedure, this is not going to be sufficient enough.
And if you are using Vanco, it has to be
Dilip,
1.5.
regarding Dr. Nath's comment regarding cath lab, I fully agree that our cath lab is in very bad shape regarding sterility. In abroad, I have seen that for the EP and this pacing purpose or device implantation, they have a separate lab, totally sealed. Nobody is allowed to enter there. That's a separate issue. But I would request my colleagues to post their device cases or PPM cases as early as possible in the morning, so that it gets less contaminated. This is just a practical suggestion from a man with grey hairs, may not be with grey matter. So,
problem is, even if you take the patient to the lab, your surgical theatre, I mean cardiothoracic surgical theatre, the problem of infection could not be stopped. This study has been done. They tried to take all the cases to the cardiothoracic OT and get it done. Even there was problem of infection. So cath lab involvement is very important as suggested, but it cannot be stopped.
Can I have a comment?
Sanjeev, one last comment, maybe this is the last comment regarding this issue. Why this Tyrex type of thing didn't become popular?
So I think data is definitely there, but I think cost is probably one of the issues, I would say.
Cost or any other inhibition?
And I think so there is a specific subset where I think we should be using it rather than making it more generalized. Like somebody who has got a low body mass index has got a higher chance of infection. Somebody is going for a device replacement, second or third time or a repeated, there it has got an indication. Somebody you think that on anticoagulants is going to develop hematoma, because this trial showed that even in hematoma, somebody with a hematoma, the infection rates have come down. So I think selection of patients is more important, and cost. I think these are two things.
I agree with Sanjeev.
1 minute.
EHRA doesn't recommend Tyrex yet in normal pacing patients. Patients who are going for a replacement or a CRTD devices, large bulkier devices, there it is recommended as class indication.
Yes. Can I have a comment?
Yeah.
Sir, is there any difference in the incidence of infections when between subcutaneous and submuscular implantations?
So, I mean, subcutaneous, you're talking about device implantation?
Yes, device
So
placement.
I think, see, the point is, I think you never put a device in subcutaneous space. If you are putting a device in a subcutaneous space, rest assured you are going to get infection. You will have to reach the prepectoral fascia. So that is where you're going to implant a device. Now you are talking about probably submuscular, yes. Now submuscular, I think all of us sometimes put a device. The problem with submuscular is make sure you have good anticoagulation using your cautery. Don't have a hematoma, because the moment you will cut the pectoral fascia, you're going to get a lot of bleed.
I use a plastic surgeon for that.
Yes.
But is there any difference
no.
in incidence of infections?
I don't think so.
Yeah,
I mean,
no.
no data at least I have.
If under the muscle, the chances of erosion is less. So we prefer, if the patient is lean, thin, we prefer submuscular.
No, his question is, he's asking whether you got any scientific data, so I don't think there is any data.
There is no scientific
I am not
data.
aware.
Another thing,
But sir, it comes at a cost of hematoma. When you, like Sanjeev,
May I call upon the next speaker?
Thank you,
sir. Just one more suggestion. What we do,
Dr. Arindam Pandey.
It is published by your Taiwan Heart Center that we put 12 hours to 24 hours gauze piece on the left side or right side, wherever you do, with the chlorhexidine. And that's got benefit.
Thank you. I think it was a very important topic. That's why I gave it to Sanjeev, who can do justice. And before Arindam starts, one more comment, sir. Dr. Nath told experience that after 3 years we get infection, and that is true. One of the studies have shown 70% of patients, after 1 year, if we explore the pocket and do the culture test, it will be positive for bacteremia. Positive bacteria. It will culture, it will grow the bacteria. So it is not like only the sterility which accounts for the infection, but also the immunity of the patient and multiple factors they also play in.
Thank you, sir. Before I start, just one comment regarding the last very important topic, because infection is very concerning fact. I had infection after 12 years of implantation. In fact, the patient implanted pacemaker. He was, I implanted that time during my postdoctoral traineeship. He developed 2 years back infection, and the machine has to be extracted. So that can also be possible. One point regarding the intramuscular injection of antibiotic, I don't agree, because pediatrical data do not show that it is actually beneficial, but I do it routinely for all my practice. In fact, my first year DNB is doing thesis. His topic is intra-pocket injection antibiotic compared to control group. So we are very eagerly waiting for the outcome of the result. So thank you, the chairperson, respected chairperson, dear audience, Dr. Dilip Kumar, for giving me a talk, which is, I found it very interesting. So ARNI and ICD shocks, we all tell that if you start ARNI, the requirement of CRT comes down, the requirement, indication-wise, the requirement of AICD comes down. So it was a good opportunity to dig into the research. So I'll be showing you a few of the studies which I actually went through. So background, you all know, they are both ICD, CRT as well as ARNI are the greatest development. In the first decade, the AICD, CRT, all these devices came up. The second decade was definitely for ARNI, which revolutionized the heart failure therapy. While ICD prevents around 50 to 60% SCD, but definitely not all. CRT has shown its consistent efficacy only in selected subset of heart failure reduced ejection fraction patient, so it is not for all, and has a non-responder rate even in today's era 25 to 30%. Now let us try to find out what this ARNI does to the indication-wise the devices as well as the number of shocks and all. So I'll start with this sub-analysis of Paradigm Heart Failure Trial. So this was published 2020. You can see in Paradigm Heart Failure Trial, overall 8,399 patients were included. Out of them, ICD at baseline were there for 1,243 patients. That means around 15% patient had ICD in place from the baseline. Now, it was further analyzed and it was shown that they had a class 1 indication for only 14%, and rest of the 1%, that is around 87%, actually did not have a class 1 indication to have AICD. Now, again the patient who had class 1 indication already had ICD, this 14%, around 9.3% had ischemic etiology, around 4.5% had non-ischemic etiology. And this arm is totally the patient who did not have AICD. So let us see what this molecule ARNI did. You can see the sacubitril valsartan in Paradigm Heart Failure Trial. If the etiology is non-ischemic, then they significantly reduce the probability of sudden cardiac death. Whereas in ischemic etiology, it was actually similar. So no difference. So that is very important. ARNI, the action is not similar to all the individual. So ICD use was associated with 56% lower risk of sudden cardiac death in ICD eligible patient, in both patients with ischemic and non-ischemic etiology. Sacubitril valsartan reduced the SCD risk in patient with an ICD. Even on ICD, it further reduced the SCD risk. And in those who were eligible but did not receive an ICD, there also the risk of sudden cardiac death was significantly reduced. This effect was particularly evident in non-ischemic etiology. That was statistically significant. So in ischemic etiology, the reduction of sudden cardiac death actually was statistically not significant. I'll show you another very interesting trial. This trial is from Taiwan. So clinical impact of this molecule ARNI on patient eligible for cardiac resynchronization therapy. This is very interesting trial. You'll see. So this was a METOAC level analysis. So 10 hospitals, they analyzed the data from 2017 to 2018. Around 1,772 patients. Group 1 patient,
Now, first, the individual who already had a CRT, they were excluded. Now, then they divided. In group 1, there was class 1 indication for CRT. So what does it mean? QRS duration of 130, more than equal to 130, and a LBBB morphology, or a non-LBBB morphology with a QRS duration of more than equal to 150. And second group were the DCM patient, reduced ejection fraction, who were not candidate for CRT. So they followed them up, and very interestingly, you'll be surprised to see the patient who did not have indication for CRT, they responded very nicely. So change in echocardiographic parameter following sacubital valsartan, you can very interesting change in, this is the, fact which suggests that if your patient is actually eligible for CRT therapy, only ARNI probably is not going to give statistical significant benefit, whereas it is very important to provide this therapy for patients who are actually not candidate for CRT or cardiac resynchronization therapy. Another trial from Italy, this is again a registry trial known as Discover ARNI. So Discover ARNI, 300 small trial, 351. At baseline, 255 patients already had ICD. So they actually evaluated the patient who were candidate for AICD. Now they excluded the patient who already had an AICD. Then rest of the 113 patients who had class 1 indication for putting AICD, but somehow they did not get the device. They followed them up for 6 months. And what they found, the requirement of AICD or the indication of AICD is no longer there for about 69 patients, which accounts around 60%. So this is a very good trial which suggests if we use ARNI, the indication-wise, the need of AICD actually comes down. So this is a piece of information which probably is very relevant, and this is the further analysis. Another trial which I like to show is this effect of ARNI in the investigator-reported ventricular arrhythmia. In the original trial, paradigm heart failure, this was published in 2021, and you can see, they consider at least 2 arrhythmia outcome to be, something which the investigator should report, and obviously resuscitated cardiac arrest. And you can see sacubital valsartan had a lower risk of composite outcome of ventricular arrhythmia and ICD shock, as well as resuscitated cardiac arrest. So this clearly indicates if you initiate the patients on ARNI, if already they are having AICD, the requirement shock comes down, the chances of sudden cardiac death, even after implantation of AICD, actually further reduces, which is very important. So that emphasizes the fact, even if you are providing the device, you should not hold yourself from providing the guideline-directed therapy to your patient. Now, this was another, I think meta-analysis, which was published in Circulation, which showed that ARNI has a tendency to decrease the ventricular and atrial arrhythmia as well as appropriate ICD shock. This is a fact which will boost our confidence. I think this is the last paper which I'll go through. So this study evaluated whether ARNI reduces the heart failure hospitalization and death in CRT non-responder. So this is also very important because nowadays, particularly in our state, lots of patients are actually undergoing CRT implantation, but a significant proportion still they do not benefit. This was published in a pharmacological research journal, and they also looked into the micro aspect of it, the molecular structure. So the CRT non-responder, they were put on optimal doses of ARNI. After 1 year of follow-up, 34.9% patient among ARNI users became responder. So that is very interesting. Only 20 patients became, responder in non-ARNI users. So this was statistically highly significant. They also looked into the microbiological character of this patient. So microRNA 181, which is actually something very bad for your cardiac remodeling. In the ARNI user, it was down, but in non-user, it was high. Similarly, other markers, say for example, microRNA 18, microRNA 145, which are actually good for the remodeling of the patient, they were elevated in the ARNI user. Also, the ejection fraction, the hard endpoint of the echocardiography, say for example, LV end systolic volume, 6-minute walking test, everything was improved. So that suggests that even in non-responder, you should give it a trial of ARNI. So my take home will be,
ARNI shows greater benefit of in heart failure reduced ejection fraction patient who are not candidate for CRT. That is very important. We can tell that from this discussion. It can also be a potential option for CRT non-responder. In large global and contemporary trial of heart failure reduced ejection fraction, ICD use in potentially guideline eligible patient was associated with lower SCD risk. We all know that. But ARNI reduced the SCD risk regardless of ICD use or the eligibility in heart failure with reduced ejection fraction patient, providing further support for the complementary role of optimized guideline-directed therapy. And proper trial optimal doses of ARNI may actually reduce the indication of AICD implantation. Moreover, the hard echocardiographic parameter, elderly age, particularly lower LV GLS, Moinak was showing us a GLS trend pattern, were strongly associated with persistent ICD indication after 6 months, could therefore be useful to predict the improvement. And same is true for ischemic etiology of dilated cardiomyopathy. Timing of ICD implantation can be reconsidered in the light of current ARNI era. Thank you very much.
Thank you, Arindam, for your nice presentation. The basic rule of putting ICD is that one should have a liberal and appropriate time of all the 4 pillars of heart failure therapy. And after that, you should consider the ICD therapy. And in your last, the paper, whatever you have quoted, that the patient was not having ARNI before implantation of AICD. You mean to say that they were implanted AICD and subsequently they were given the ARNI. That means they were not given the benefit of ARNI prior to implantation of AICD.
So I showed you around 5-6
No,
trials.
last one.
Last trial was on
non-responder.
CRT non-responder.
No, but before putting the AICD, they must have been given the opportunity or the benefit of all the 4 pillars of heart failure therapy.
Yes.
Then why there was a reinstitution of the ARNI therapy after implantation and just
I take your point, but these are all retrospective analysis. So you take it from there. Someone who is declared non-responder, then they included them into the study protocol.
But before that, they must have been given the appropriate dosage, appropriate duration of all the failure therapy.
Yes, that is idealistic situation. But sir, real world penetration of guideline directed therapy, even in Western world, if you see 4 pillars of heart failure therapy, which is almost established as class 1 indication, actually is received by 1% of the population who are candidate. So this is the data.
The take-home point is that one should not rush for AICD before giving the appropriate time and the dosage of the heart failure therapy in adequate duration. That
Similar
should be
is
there.
the situation with CRT non-responder, you said.
Yes, sir.
So they should have also received ARNI, but they were not, unfortunately.
Yes, somehow I don't know, this point is very valid because 20 patients were not given ARNI on the comparator arm. How the ethical committee approved that can be a question, but this research was published in a pharmacology journal. So this is...
Dr. Devbrata Majumdar. Dr. Devbrata Majumdar is... yes, please.
If I'm audible. In one of your points you mentioned that ARNI would be less responsive in patients who are likely to be CRT responsive. You mentioned one point there.
Yes.
What we gathered is,
yes.
suppose you have 2 patients, both non-ischemic. I specify non-ischemic DCM.
So I re-emphasize, there was possibility of less response of ARNI in patient who are ischemic background, and second is who had classic indication of CRT implantation.
But our understanding should be clear, I think. If you have non-ischemic DCM, arguably maybe 30 less, and you put them on GDMT, both improve to post 35. So automatically both are spared of, either an AICD or a CRT. So I don't think ARNI would be having a differential effect on patients having a classical...
So that is not what you and me think, that is the sub-analysis of paradigm heart failure trial.
Yeah, you understood what I'm...
I understood your point, but that is a sub-analysis of paradigm heart failure trial that I showed.
You understand. I'm not,
I understand your point, but what I meant to say, if there is some mechanical thing which can be corrected, say for example ischemia, or a wide QRS LVBB classic, that means notch, those patients
Actually, that problem lies even after ARNI use, because ARNI cannot correct that.
Okay, we can discuss it
Now,
later.
just one comment, please. Now we are down to a basic question, whether it was sequestrial or valsartan, or both are required to reduce the inclusion of ICD and
Next
CRT.
speaker,
that is now to be explored.
Next. Thank you, thank you.
In
Very good presentation.
In
Now I
paradigm
invite
HF
Dr.
trial,
Dilip Kumar.
sudden cardiac death is reduced by 20%. So there is no doubt ARNI is helping.
So when I was designing the program, can you, yeah. So when I was designing the program, I thought, so the important, things which we come across in our routine practice should be discussed, more and more. And that is why lead extractions, infections I'm talking about. So 2-3 things are very important. I will re-emphasize is one should not leave the patient with pocket hematoma. If there is any hematoma next day, it's going to be crucial for the patient for having an infection. Second is use of temporary pacemakers. So many of the times we get patients with complete heart block with heart rate of 30, 35, 40, and my nursing staffs ask me, let's do an TPI and then PPI. So if you go with the predictors of infection in pacemakers, the first one comes the hematoma, and the second one comes is the use of TPI. I rarely do temporary pacemakers when I go for permanent pacemakers. Around maybe 1 or 2% of patients who are really sick getting recurrent syncopal episodes. With this, let's move on to lead extractions. So lead extractions, I have been getting a lot of patients who have been referred to me for lead extractions. And here there is a kind of a definition which involves lead removal, lead explant, and lead extraction. So lead removal means it's a just general term. It's a lead explant as well as lead extraction. And lead explant we use when simple techniques, less than 1 year, old implanted leads have been just pulled out. This is called lead explant. And when we are using, specific tools like tight rail, laser, snares, or more than 1 year old leads which have been implanted, then we term it lead extraction. So lead extraction is an important and novel technique which we need to know, and only then we should start practicing, because it has got definite incidence and of complications. Around 1 to 2% of even death can happen to these patients. So these are indications for lead removal, we all know. The commonest one is infection. And we have the world moving towards constant monitoring with video-assisted thoracotomy. You can see here, this SVC is about to give way, so you stop there, think of other thing, getting surgeon back in the cath lab, and whatever you need to do required to the patient. A T should always be there to look at the earliest sign of pericardial effusion. If you miss the pericardial effusion, allow the patient to go in tamponade, you may not get the opportunity to send the patient to cath lab to surgical unit, because once we are extracting the lead and we are doing a lead, pericardial effusion, these are always nasty effusions which are really very difficult to tackle only by pericardiocentesis. The patients invariably need surgical intervention, so you have to have a constant kind of monitoring with transesophageal echocardiogram. Now let's look at the techniques and the success rate. Simple traction, 85% is possible. Locking stylets, that is LLD, 93%. Mechanical telescopic sheaths, these are 98%, but their injury is high. Laser sheaths, 94% compared to rotational mechanical sheaths, which is 98%. So that is very important. Everyone should take a note. Rotational mechanical sheaths have higher incidence of success, higher chance of success than the laser sheaths. So we talk about laser, but we have something which is very easily available with us, rotational mechanical sheaths, like tight rail we try to, not to use. So we have to have a radial arterial line, we have to have imaging in transesophageal echocardiogram, we have a 9 French left femoral vein just to fluid resist this patient, because patient can exsanguate by SVC injury in 5 minutes time. You don't have much time. You are working at a very thin balance. You need to have 12 French access for peripheral occluding balloons. If SVC tear happens, you need to occlude and send the patient to surgeon, and another femoral lines for snares, catheters if you want to use or assist you in extraction. So let me show some of the cases. This was a 66-year-old male, had a VVI pacemaker implanted in 2002, lead with PG replacement done 1 year back, old lead was cut. So this is a real wrong practice to cut the leads. And there was a discharging sinus, history of fever for 2 weeks, no other identifiable source of fever. Transesophageal, possible small vegetation. Patient was put on IV antibiotics, vancomycin, and meropenem for 6 days, and then patient was taken for extraction. And you can see here, since the lead was cut, you don't have access of the lead from the pectoral place, site. And then you have to bring the device, the lead, which is their abandoned lead, to the SVC to have a kind of a free end to catch hold with snare and to bring it out. So you can see here, we published this, since we had published our series of using EP catheters in intracardiac trap devices, we utilized that idea. We pulled this lead into IVC, and you can see here we pulled it, and we then snared the free end and we removed the lead. And patient really improved. The fever vanished, patient was doing well. This was a 55-year-old male, first pacemaker done 4 years back from left side. Patient had pocket infection for which the PG was taken out, lead were cut again, and pacemaker was done from right. So these are common, happenings which I see in other hospitals happening, and we do get referrals for these infected patients. So now there is a discharging tract on left side, and you can see right side there is a working system, but left side leads were abandoned, cut, and they have got a discharging sinus. So we have to remove that. One was pulled and other was not coming. There was a 4-year-old lead, and it was not coming even with stylus going in. So we had to use a tight rail. You see how tight rail goes in. So it cuts, it has to be coaxial, and then you have to be slow in your movements. So once you, the maximum adhesion happens in the SVC, subclavian junction, and then below. You have to keep on your patience, and finally it comes out. And this was the shot after the removal. We see that everything is fine or not. So these are shielded dilatation, dilation blade, and until and unless activated, they can move 560 degree, 540 degree, and chances of injuries are really less. And this I need to show all of you that when I went to Proctor, a lead extraction case, that was a pacemaker lead, and what was available there was a tight rail of 11 French that is used for ICD leads. So these, one should know, there are 2 extraction tools, tight rail, one for normal pacemaker leads, which are basically for 9.2 French internal diameter, that comes in 9 French, and the outer diameter is 15.9. And the second comes for ICD leads, shock leads, which is 11 French, which has got an internal diameter of 11.2 and outer of 18. So one should ordering the device to the companies according to the lead which is going to be extracted. I will end my presentation with this final case, which was really interesting. This 78-year-old male had everything in pacing technology was utilized on him. You just see. He was given a 1999 first pacemaker was done. Then replacement was done in 2013. Infected, PG removed, leads were cut, VDD pacemaker were done. Patients developed pacing-induced cardiomyopathy, lead was capped, and new CSP was done through left. Left-sided pulse discharge, left side there is a pulse discharge now. So these are the condition of the patient. So we have multiple abandoned leads, you can see here. So 5 leads, 2 cut from right side, and then 2 working from left, and 1 abandoned. And this is the importance of ultrasound guided puncture when we are, so we tried a micra pacemaker first in this case. In morning I was telling, when there is an infection and dependent patient, we don't go for TPIs, because with TPI and micra, it is a lethal combination. So we did Micra pacemaker first here. You can see. And then we tried removing this is the Micra which was implanted. And then we removed 2 leads in the same sitting with tight rail. And then we staged the procedure. After 3 days, we took the patient again. And you can see here we are explanting. And this time, since these are older leads, we are not only using EP catheter, we are from other groin, we are using the snare to catch the distal end of the EP so that there is a complete loop. You can pull the entire thing down. So with this way, we removed slowly and slowly all the leads possible with some of the fragmented segments still there. So you can see here, we are really scared at this moment what is going to happen to this patient. We were constantly watching with the transthoracic echocardiogram, and finally it gave way. There were some of the remnant segments were there, and this was the final result which we left the patient. Only these 2 small segments, and with Micra, and expectedly, the patient developed pacing-induced cardiomyopathy in next 3 months, and we were ready for CSP this time. After 3 months, everything was healed up. We did a CSP, and now patient is doing well. And he is completely free of his symptoms. The gentleman did not take shower for 1 year when he came to us. Both-sided infection, one was pacemaker and second was lead, abandoned lead. So lead extraction is a teamwork. Thorough planning and availability of hardware is a must. Success rate is more than 97% with current techniques, and it has got a learning curve, and difficult cases should be probably done with a proctor. Thank you so much for the patient hearing.
Fine, excellent. What about the difference between the use of tying lead and screwing lead? So
screwing lead is easy to extract. So if you take, and in our practice, this 100% screwing lead, there is no tying lead now. If you take your stylus down, unscrew, then it is easier. At the RV implantation side, the adhesion is not going to work because you are unscrewing and then things come up. Only the SVC segment, SVC junction side, there can be a problem because of adhesions, especially in ICD leads. Pacemaker leads, we can extract 8-9 years. I have just removed with locking stylus and unscrewing and pulling. But ICD leads, we have to sometimes use tight rail more often, sir.
How can you plan that which patients will need only the stylus or laser? How can you pre-plan? And secondly, which cases would you like to do in the operation theatre?
Sir, it's a very good question. So first of all, as compared to laser, this rotational mechanical sheets they have got higher success rate, and they are handy, they are easily available. So with laser vis-a-vis tight rail, I prefer more on tight rail. And coming to which patients we should be more cautious. So all those patients who have leads implanted, especially ICD leads, wider leads, more than 3-4 years old, 5 years maybe, ICD leads, they should be given more attention. Surgeon should be in the discussion, and then you should plan at least surgeon ready in the cath lab, in the OT, and you are doing under transesophageal echocardiogram or a transthoracic guidance. Everything has to be monitored. The patient is not developing the pericardial effusion. Yes.
Is there any protocol that this patient will need laser, this patient will need...
No, sir. Many cases of laser have been failed and has been done by tight rails. And these are not very high volume cases, because even the best operator of lead extraction has done around 150 to 160 lead extractions. So I think we have done around 30-35. Tight rail I have used in 6 cases. So these are not very high volume cases for every operator in world. Maximum cases have been done by someone who has done 135, 140, because infection is not that common, especially with ICD leads and more than 5-6 years. So these are the patients where we require extraction with complex devices.
Dr. Dashvishas, would you like to have any comment? Thank you, Dilip.
Thank you, sir. Thank you very much.
There is no other presentation, no? Dilip? There is
no, sir.
No other presentation?
No, sir.
Okay, thank you. Excellent.
Thank you, sir. Thank you.
Thanks.
So we are, yes sir?
Next meeting, start with lunch and finish with cocktail.
So I think we are moving for the last session. Before we assemble for quiz, we will be having some informal discussion with amongst ourselves and Sumit, who is there. Can we have Sumit on stage, please? Sumit Anand? Yeah, please come. Sanjeev, can you come? And I can request Dr. Arup Das Viswas if you can join us to guide us, making some of the kind of giving suggestions and streamlining the kind of process by which we can accumulate data, do some research work. So may I ask or request Sumit to introduce himself, and it was just an informal discussion. We'll sit there and we'll have a talk for 5-10 minutes. Please come. Sunandan, Arindam, please come. Arindam, please come. Sunandan. Yeah, so anyone willing to join us can come, and since this is an informal discussion, I have already told, anyone can participate in between, okay? So Sumit, please introduce yourself and then we can go ahead.
So thank you, Dr. Dilip, for having me here today. I'd like to introduce myself. I'm Sumit. I've done my master's in pharmacology and doctorate in clinical research. And I've been associated with Abbott and conducting these clinical research for the medical devices for over 16 years now. And I'm happy to participate in the panel discussions here today. Thank you.
So yeah, so may I begin? So Sumit, so how many kind of studies you have been involved with? If we can know, and what kind of studies, then we can throw some correct questions to you.
So we have been at Abbott, so I take care of all the medical devices, be it vascular, CRM, EP, structural heart, as well as neuromodulation and heart failure. So I've been conducting clinical trials in India, South Korea. In India, we have been doing the pre-market study, which is before starting off the FDA approval. Now we would be, if you would have heard that we are coming up with a new CSP lead for ICDs. We are going to begin a clinical trial next year for that, so that the data could be used for FDA approval and the launch of the product globally. Last year we did FDA label extension kind of study, which was more observational. So what we did with our existing tendril lead, we collected the data on the patients where it was used for LBB AP indication, and that's how we collected the data and submitted to FDA for an approval for the LBB or the CSP indication for the tendril, and now the Ultipace lead as well, what we have. For TAVI, we did a Portico pre-market study in India.
So we are for CRM, since this is the meeting of
Okay.
CRMs, we will stop there.
Sure.
So now we got an idea. We as a center from East, we have published our long-term and very large data on incidence of coronary artery disease in pacemaker patients. So on the same lines, what now I'm planning is there is a kind of inflated stats on incidence of PICM, patient-induced cardiomyopathy. Some of the studies have shown 26%, which I am really not happy to accept. This 26% is little overinflated. So we have started in raw form, collecting data. So once a patient is programmed in the OPD, you people give a kind of a report where there is every time it's highlighted how much percentage of ventricular pacing was there, atrial pacing was there, sensing was there, so percentage of AP, VP, VS. So we are gathering those data. It is not long time. It's just 2-3 weeks we have started, and we are following all these patients 6 months, 1 year, and we are really eager to present our pacing-induced cardiomyopathy data. So tell me how we can make it. Can a third party be involved here, or because we are really short of manpower? Sanjeev and Arindam and Sunandan, can you give an idea out? We are just accumulating ourselves, our residents and all.
So actually we have a pacemaker clinic.
So all of our pacemakers are in general, so about pacemakers, so St. Jude's in it. So most of these patients also have echo reports. So if their person who is doing the pacemaker checkup has a pro forma, he can write the pacing percentage, he can write the thresholds, he can write the echo EF also. So that person can itself become one of the coordinators for accumulation of the data, at least from the NH side.
So can we have a kind of this kind of a third party agreement with someone, and Abbott facilitates this kind of a
itself has its employees who are
no so to make it a kind of a in a study kind of thing.
Yes, so what we can definitely support is that we can have a third party agreement, and then the person can collect all the information. Now there are two ways of doing it. One is somebody actually looks into the manual PDFs and enters in an Excel, and then we do the analysis. Second option is that we get all the session records in raw format that goes to our US R&D. They give us all the thing at once. So there are two options. It's not that you need to do it prospectively. Even if you want to select a pacemaker model or some model, you identify that all the session records which are there in the programmer can be extracted, and that can be done at our end.
So let's look at the possibility. Arindam and Sanjeev, can you tell something?
No, I mean, I just missed it. What is your area of expertise? I mean, you are looking at, you're like a data analytics, or you are trained in lead manufacturing kind of thing?
Sir, I'm a clinical researcher. I'm more into clinical studies and data analysis.
Data analysis, more of, right, sure. So, I mean, from your end, what do you think, do you have got any research idea that you think, in terms of lead, lead longevity you want to look at, or the material that you're using, something like that? Any ideas that you have got as far as
we are always interested in looking at our device longevity data in a prospective plus a retrospective manner, especially in India. Because what happens in US, we have an insurance tie-up, and then we get a dump of an extract every 2 years, and we can look into all ages that how much devices, what is the longevity and other things. But that becomes difficult in an Asia scenario specifically, as well as in India. So if we get some kind of data on our longevity for pacemakers, devices, that would be really helpful, and we would be keen in putting up thoughts on that.
So I think in that sense, I think that is where it stands. You look at, one angle is you look at your device longevity, start with that program. Along with that, you're also looking at LV functions that your devices are giving. I think that will tell us about the incidence of PICM in our population. I think that is what.
Just one thing, the problem for us is that we are not the owner of that data. The physicians and the implanters are the owner of the data, so it has always to be initiated from your side first, that you can submit a proposal to Abbott that, hey, we are looking at this number of centers and this number of pacemakers devices, and how we should go about it. You can put up a grant amount to it. If you don't want it to be done by Abbott, you want to hire a third party, you can request, say, we need 20 lakh rupees or 50 lakh rupees, whatever is the grant justified. And then we look into that as an independent thing. This is not being looked only at the India level, it would be looked at the US level by all the compliance, regulatory and legal things. And most of the times we make good decisions on research part. So I'm pretty happy to say that if you submit a proposal, we would be okay in looking into it at a very high senior level and come out with a definite solution. Be it a research grant or be a support you need from other side, either ways it would work.
I think the support which we really need is someone who is really after the job most of the time. So Eastern India has huge number of pacemaker patients, and I was telling Praveen Shanmuga that we want to give West Bengal, which was long overdue to this place, clean leadership in CRM therapy. Not only numbers, but also in publications and the leadership role which we take in taking the therapies forward. And there comes a role of someone who can anchor, be it because these two companies are there, Abbott, Medtronic, as well as Boston, Biotronic. They can leverage this number and skill and the operators, their ideas. Someone who is after us, not we have to be after anything. Someone from your side, you appoint as a research lead of East India, and then he can move around weekly to some of the hospitals like Dr. Das Vishwas, where he is practicing us, and there he is instrumental in generating data, collecting things. That will be the most, what do you say?
But what he's saying is, as a clinician, you will have to take the lead, because
that will take ethical permission. That anything we have to do, we have to make a synopsis, ethical committee clearance. That is our job. We'll do that. but someone has to be pushing us all around.
So what
Research. We
what
want that
can-
kind of support from the companies.
I get your point. What we can definitely provide you is a resource. But again, for that resource, the whole proposal thing has to come up, and then we provide a resource who would be based out of, say, your hospital itself. He'll have a dedicated place where he does all the things. He starts following up as per your guidance to the other institutes, visit them weekly or whatever the frequency is required, and then gets the data, collates them in a single system, and then gets back to us that this is the data. Now we look into that in terms of analysis.
Any input, sir?
No, one point I would like to just raise, as I rather ask all the panelists. So, if we want to actually look into it, first thing is the long-term efficacy of the lead, which is very relevant because nowadays we are putting the lead in unusual position. Conventionally, that used to be in the apical position of the RV, but now we are pushing the same lead into the different kind of location. So does that have any long-term outcome or not? Because I can tell you the Medtronic lead, the long-term failure rate actually is higher compared to the conventional lead. So what it happens to the abort lead, if it is positioned in the left bundle area, does it behave in the same way or not? That we also can actually see. So is there any proposal or idea of generating data in this field from your end?
So the idea is only that we generate the long-term follow-up of the patients. And again, what happens in our country specifically is that the patients are coming in from long distances. And once, like for pacemakers especially, the patient gets an implant and then we don't know where he is, right? So those cases are there, but then for the local places, we should definitely have a protocol, and we can support you on providing a long-term, say 5-year, 10-year, and then the data keeps on adding up, right? You continuously say have a program of collecting all the patient follow-ups from a particular date, and then you start publishing it every 2 years, and then it gets accumulated forever, right?
Yeah,
so that's how the best.
Yeah, let's have inputs from our teachers and our colleagues. Sir.
Started. So, are you meaning any kind of study or trial or registry in CRM?
He is just there to, help us generating and guiding us. But the idea and push should come from us.
No,
what are the ideas which we can bring in? Yes,
what
sir.
I think,
Sir, please sit, sir. Please.
No, it's not sitting. They can see me. Actually, what I think, this state was the maximum in pacing once upon a time. Maybe it is a bit lagging behind regarding the high-end devices. Whatever, all put together, we can have a lot of good data from this end. So for that, I think 2-3 of you sit together, form a good group, and take a leadership in generating a registry. How can you do that? Suppose you take 1 or 2 from the government sector, maybe IBHRE because they are the maximum implanters. Maybe your center, your and his center are same. Sanjeev center is probably same or different?
Kalyani.
2 or 3 from the different private sector. So sit together, form a registry, send an appeal to your colleagues that as far as the devices are concerned, give us data. And they can help with the fund of deploying some paramedical staff. Because you remain so busy that you don't have the time to come back and put the data in the computer. So in the paramedical staff, you give the data or dictate it. He or she will put down in the computer. It is very easy nowadays with these computers to have and the telemedicine facility, etc. And request all the patients, whoever he is from, Swasthya Sati, ESI, CSI, whatever. Don't mind my joking at the CSI. So, from whatever source he comes, he should give you some data feedback. And when you have some home monitoring device, then it is further easier to get the data. There are a few and far between. Home monitoring devices are also there. And with the newer mobile entitled devices, that will be, is it too costly to have a mobile-enabled device? Mobile-enabled means linked with the mobile so that the data are fed back in the mobile system. Are they too costly?
So there is actually a price difference between the mobile versus a non-mobile device. But once a patient purchases a mobile devices, it's Abbott's responsibility to have him connected always through the Bluetooth. But then there's obvious a first.
So if those kind of devices can be encouraged, maybe there will be a separate subset. So you can compare what is the data input from those who are having mobile enabled and those who are not mobile enabled. So likely that mobile enabled patient will be having a better communication with you. In this way, I think you can go ahead.
So we have our colleagues from Medtronic and Boston also. If they have any comments, they can give. Otherwise, I think what we gathered in last 10 minutes of discussion is we are primed, number one, to have this mindset to generate data, number one. Second, we have now hospitals included, our center, NH, AIMS Kalyani from government hospitals. So we are on the same page. We have the same frame of mind to have a kind of collecting the data. So I request all of you, our industry colleagues, to have someone as a research kind of representative to deploy in each part of country. This is the only way to take it forward. See, we clinicians, we can't do everything. We need to be assisted, supported, as well as guided. So if some of the comments, and then we can conclude.
Yeah, any questions?
Any other comments? Saurabh, you have any comment?
Check.
The execution has to be from one center, one place, because multi-center, after some time it will fizzle out. It has to be like driving force, it has to be time limited.
Yeah. So we'll talk, we'll make a group, and once we make some headway, we will talk among ourselves to how to go ahead. In between, we will the way we are collecting data, we are able to publish 1 or 2 papers, 3 papers in a year. We'll continue till we get a streamline things with a some of the people only focusing around research work, because lot of work is going on in Eastern India, I tell you, and the entire country has taken a note. This device update, where none of the speakers whom I approached said no. So guys like Sanmuga, Gopi, Balbir, they're quite a kind of a name and doing good job. And since our work is there, that's why they are ready to come here and deliver and to collaborate with us. So we'll take it to the next level. Sure. And thanks Sumit for being here, and thanks everyone for contributing and joining. Let's hope for a better future. Thank you so much.
Thank you, sir.
Now it's Sunandan and team to take over for quiz. If we have Souvik, do we have participants for quiz?
Question 49. So we come to the last session, and that is the quiz session as always. So I think Souvik is there, and I would like the industry people also to participate in this quiz, because it is their quiz only. So there will be some questions, some will be basic, some will be some slight difficulty, but not very difficult. So everybody should be able to participate. Yes, pointer. So I think the industry can also participate. They can come and join here. Yeah, so now question is, so you can see, I think in the mobile you can scan the QR code. QR code is there for scanning. So you can scan the QR code and get it on the mobile, and you can see on your mobile.
one patient recently I had, I just forgot to mention about that patient. He's speaking here. Patient has got a reflex pulse generator. It is working for 5 or 6 years since the earlier one was doing well. Old date has been kept. Now, suddenly he developed symptoms of bradycardia, sympathy. One time he was admitted to the hospital. Neurological surgery.
So there is some marking, I think. So the markings will be how fast you give the answer and how correct you give the answer. Both of them will be clubbed into one point. This is what you call Kahoot. Kahoot. Yeah, you can do.
Everything was done. Despite that, after 7 years, we have a
QR code केवल है इसमें.
Okay. So after 7 years,
ठीक है, जो आस्ते पूछते हैं.
So again, everything was evaluated.
Oh, this is the QR code, I think, yeah?
Still higher.
So they can scan the QR code, I think. So Sovik, you come, one of you operate this one.
Oh yeah, I'll just zoom in. Yeah, sure. In case some of the members in the audience are not being able to see the QR,
Whether you can replace it at the end of the year, so now for last 3 weeks he is doing well. So what is the reason that initially there was no much quick rise in threshold? We usually get the rise in threshold earlier much quick.
all right, I already see some of the members are joining in. So keep putting your names and let's quickly hope that we join.
Patient may have some, I don't know, what's the age of the patient?
So I think more people should join. I think only there are 3 or 4 names.
Can we have more
So it will be
volunteers
fun.
from the
It is
audience?
nothing to be worried about, or because it will be a lot of fun. So more people can join this. So where are our industry friends? Can they come in and join? Because they doing this job day in and day out. So
Other parameters are okay, as you said. You probably need to check more into details.
Yeah, actually I am thinking of when we will open up this year, we study the needs in a better manner.
any more who want to join, because we will now start?
I'll definitely ask this.
Because it would be good to know exactly what are the reasons.
I see a couple of new names popping up.
Sometimes even the device is being sent across to the R&D center to check what if there was something.
No, they will do it.
Yeah, yeah.
They will do it. They will routinely do it. You all do it.
Okay, so we can go to the question. Yeah. So we go to Shovik, or anybody else want to join? Okay, so
I see more names. All right.
okay, we start.
Everyone's joined? Oh, sir is joining, no problem.
Okay, okay, okay. Yeah. So we start actually from the very basics, because if it's a device update, it's not just about hi-fi things, but very basic thing. So this is a question about Riobase and Chronaxi. So if we look at this diagram, we know that it is a strength duration diagram. So which option is correct? Riobase 0.25, Chronaxi 0.25, Chronaxi 1.0, Riobase infinity. So majority have answered correct, and that is Riobase 2.5. So as we know, Riobase is the lowest amplitude or voltage that can be utilized with a very long duration of time. So lowest one, that is 0.25, that is the Riobase. Can we go back one slide? No, next na. Back. Go back to the next one. We have back one. Because we also have to learn, that is the thing. One yeah. Back one, na? Okay. So
if you can pause and...
So if you look at the strength duration curve, the heel of the curve and which it crosses the amplitude, that is the Riobase. So this is the current, the minimum amount of current if you give for a very long time can stimulate the muscle. So that is Riobase. So next question. Next question. No scoreboard. Yeah. So now we come to a ECG tracing. Which beat is a pseudo fusion? So we can look at it. There are actually a number of beats. So which beat is a pseudo fusion? So look at this. There are a number of beats. And which beat is the pseudo fusion beat? So we have just 3 seconds left. So it is we have a learned audience because this is a basic question. So if we look at this beat is, the QRS complex has a spike, but that spike falls inside the depolarization time of the ventricle. So this is between a fully paced beat and a normal beat. Basically it is more like a normal beat because the spike didn't capture the ventricle. And this is a fusion beat because the spike partially captured the ventricle and the ventricle was depolarized by one of its intrinsic beat. So it is a fusion beat, this is a pseudo fusion beat. Next slide. So after this we'll check who is going ahead. So we have a 60-year-old lady with VVIR, with dyspnea and syncope. So we have a very basic question. So the options are, what is depicted for this ECG? Undersensing, lack of output, oversensing, and loss of capture. Mind it, in this question, there may be multiple correct answers. So we have 1 second left. So yeah. So there are 2 correct answers, both undersensing and loss of capture because of the dislodgement of the lead. Now let us see who is faring. I think SP, who is this SP I do not know, but he has come up from behind. And T, who was first, he has come down. Anyway, so next question. So we have a patient who has been done a CRT and his dyspnea is persistently increasing. So what is the cause of this increasing SOB? Atrial fibrillation, LV non-capture, long AV delay, RV non-capture. So this is also quite basic question, but look closely at this ECG and there is the answer. Yeah, so most of people have got it correct. So as you can see, in this beat, there is wide QRS, and in this beat, narrow QRS. So there is intermittent lack of capture, and also P wave is present here, so it is not an atrial fibrillation. So that is the answer, that is intermittent LV non-capture. So we have the next question, recurrent AICD shocks. What is the cause? This is also a basic question. We have lead fracture, ventricular fibrillation, electromagnetic interference, myopotentials. So if you closely look at the tracing, the electrograms, you can have an answer. No, yeah. So a majority of the people are correct, and we can see definitely that there are high amplitude and high frequency deflections here that indicates lead fracture of the ICD lead. Yeah. So asymptomatic patient, dual chamber AICD, what is happening? So we can look at these tracings, and the options are pectoral myopotentials, VF, electromagnetic interference, diaphragmatic myopotentials. So look closely at these two marker channels. Yeah. So what we go back to when we go back here, it is a very short duration of time this persisted. And it is in both of these atrial and ventricular leads. This is the giveaway thing, both of these in both of these leads. So lead fracture is not common that way in both of the leads. And there is a possibility that there may be pectoral myopotentials, but this is the frequency of this is more like an EMI. It's very high frequency, very small amplitude, and very short time. Maybe some cautery was done and that patient had this thing. So EMI is the answer. So yeah, so we're halfway through. So this is a very.
Can we have the winner's name? Who is
who is the running fast?
Running fast.
After this.
So, but I can announce here, I should announce here that I have checked first for first, second and third, 10,000, 8,000, 6,000 rupees check I have to hand over. So I think everyone should be gearing up.
Dilip, you should have told it before we started.
No. That's why.
Okay, so. Yeah, so this is a very terrific thing that to have in a cath lab or post-op. You have a patient who is having pacing, and we can definitely see also that the spike is coming after QRS. And then he has a ventricular asystole. So this, if you have a lead reversal, this is the classic thing that takes place. And we have, once the patient has an intrinsic rhythm, this will go on. As soon as the patient's own rhythm goes, there will be complete asystole. So lead reversal.
Now look at the leaderboard.
Yeah. So this is the score.
The mysterious T.
Mysterious T? Okay, Pritam.
Next. Syncope, 1 day after DDD implant. So these are the choices. Look carefully at the ECG, and we have the different options. AV lead reversal, atrial lead dislodged, ventricular lead dislodged, and undersensing by the ventricular lead. Yeah. So the answer is actually atrial lead dislodged. This is a very peculiar situation. You can look at this, that there is one spike which depolarizes the ventricle, correct? And there is another spike also on the same. So when this patient has some intrinsic rhythm, there is a fusion, and the atrial lead is having the enough amount of current to depolarize it. But because whenever the patient does not have any intrinsic rhythm, then at that time there is no pacing, because the atrial lead is not able to capture that current strength. So this is atrial lead dislodged, and the ventricular lead not able to, because the atrial lead is pacing, so ventricular lead does not give any pace at that time. Next. No, lead is dislodged. The pacing that doesn't know that this lead has dislodged. The machine will not change. We have to change it. No, I don't think so, sir, because the lead has dislodged the machine. How will the machine go into VVI mode if the lead has dislodged?
It will always pace. There will be always a atrial spike will be there. Yeah.
But that spike may not be able to capture the ventricle. That is this.
Yeah.
Next. So there is some event is going on. What is depicted in this elderly patient with DDDR? There is a rate at which it is pacing, and there is a rate at which it is pacing, which are not equal. So what is this phenomenon? Hysteresis, ventricular oversensing, rate drop response, atrial overdrive pacing. For one clue, I will say that there may be something that was done here. So what is this? Yeah. So this is the answer. Here, if you do a carotid sinus massage, so there is a rate acceleration after this carotid sinus massage, which is because of this rate drop response of this pacemaker.
So T is still leading, huh? T is still leading.
So what is the event that has taken place? So this is a very classic ECG, because this shows us which rhythm the patient is now in. So look at this rhythm, look at the electrograms, and then answer the question. So we have sinus rhythm and SVT, sinus rhythm and VT, SVT, AF. So this is a VT. We go back. Oh, actually, I think we can come again. Huh? Yeah. So look at this trace. Two things are important in this trace. This trace was started by actually V more than A. So the ventricular beat started this event, number one. And number two, there is a cross below the T. So the match with the template was very minimal. So it was not matching. The template is not matching, and this tachycardia was started with a V wave. So this is a VT. This is a very basic question. So what is the VF detection rate in this curve? 200 millisecond, 300 millisecond, 400 millisecond, 1100 millisecond. Very basic question. Many things in the curve we are not often taught. That's why I put this one. Many things are written there already. So yeah, so this is a very basic question. Look at this line. So this is line tells us about where the device detection, arrhythmia detection is set. So it is between 200 and 400, it is at 300. So this is not very common phenomenon, but it can occur. What is happening in this device check? So this will not produce much symptoms, but there is some interesting thing that is taking place. Ventricular oversensing, atrial oversensing, T-wave oversensing, atrial lead dislodged in RV. So A channel and so the answer is V oversensing. What? Why? We go back to there. So there is atrial signal when there is intrinsic rhythm of the patient. Now there is no intrinsic rhythm. What happens is that atrium starts to pace. And once the atrium pace, the ventricular marker checks up this, and there is a, you can see the ventricle actually has a far field sensing of the atrial signal. Once it starts pacing, not while it was not pacing. So the output of the atrium is set in such a way that the ventricle can oversense it, so the output of atrium may be reduced. So T is still leading. So this is of the modern, which one is selective left posterior fascicular pacing, posterior fascicular pacing, please check out. All of these have relatively narrow QRS, but which one is posterior fascicular pacing, not the LBB pacing? A, B, C and D. We have 1 second left. Yeah. So this is actually a very common thing nowadays with these Abbott stellate leads. That's why I kept this question. So if you look at this, so the posterior fascicular pacing is characterized by negative 2, 3 and AVF. Here these are all positive 2, 3 and AVF. So negative 2, 3 and AVF, but with a RSR prime in V1 and narrow QRS. So D is the answer. This is a posterior fascicular pacing. I think we have reached the end of it. Dilip, we are at the end of this, and the scoreboard shows still T.
So T is still is the winner, huh?
Yeah. So he has consistently been fast.
He is being prompted by someone or Pritam? Actually, he was trained in Medica, that's why he is winning.
Okay.
So we now get to look at the podium.
Finished? Yes. Great. So we can have a good round, big round of applause.
And who is the fastest T?
Who is first? First is Pritam. T is Pritam. Second is SP. Who is SP? You are SP. What is your name, boss? Huh? Dr. Sojatyo, huh? Subrato. Very good. And third is SD. Great. Can you, sorry, all were trained in Medica. That's so great. So I invite Dr. Das Biswas to hand over checks to them. So Sunandan, please wait. So the third one, SD will be given a check of 6,000 by Sunandan. Second will be given by Das Biswas sir, and first will be given by a special guest who has come. Sorry,
I think there was a good applause for the winners, But there should be going good applause for Sunandan also for conducting a very good session. So this is for no, third prize first. So tomato jodi third hai tumi aage dao.
Saptarshi, sorry. Souvik Dev from Medica.
Which prize?
Third.
Hello, check.
Please write your name. Sir, please come on stage. Sir. Sir, May I invite Dr. Suabratu Patro from FSCAI Hospital. Please. Second. Good. Please write your name. And there's a special guest who has come. Praise to Pritam. Come.
Both for the winner and for the prize giver.
Thank you so much. So here we come to conclusion of this session of Device Update 2024, and it was really a wonderful event, and so much of we garnered so much of attention and kind of discussion it happened. And I think we have guests from Kathmandu sitting right there from the morning, 9 o'clock. So please give a big round of applause for them. Our overseas guests. And we have speakers.
Before Dilip goes into the vote of thanks, I think he himself deserves a standing ovation from the audience, because single-handedly he has organized this thing. And I am proud of my ex-student. He has grown to this extent. Yes.
And
we had So Dilip is my friend from a very long time, and I have seen him also as Sarah has seen him grow. Many times I say that what Dilip is doing today, that is the thing that should be done, and all people should follow him, at least try to follow him as that extent as possible. He is more ahead of his times, and he always thinks 2-3 years ahead. At least what he is thinking today, if you think, you will know what will be going back after 2 years, coming after 2 years. So that is from our friend and colleague. So many thanks to Dilip, and give a big round of applause again.
Thanks to all the participants, speakers, and finally the industry partners, Medtronic, Abbott, Boston, and then we have from Novartis and Sun, and it was a wonderful event. I think this is going to stay for at least 7 days, 10 days hangover for me. Thanks again. Thanks everyone. Thanks.